morning to one and all gathered here. As we come together for the annual conference of Indian Society of Gastroenterology, Tamil Nadu chapter, I take an immense pleasure in welcoming you all. I welcome Dr. Ubal Das to start the session. Over to you, sir.
Good morning, everyone. It's my honor and pleasure to invite everyone for the wonderful meeting of our annual conference. I think each year the standard of meeting is keep on going. So we have a wonderful session yesterday, that pre-conference workshop conducted by Dr. Chenduran and Dr. Ravi and his team. And a huge round of applause for the team for the wonderful session. Today we are going to have already we had a session on breakfast session as well as e-posters, very well attended by postgraduates. I thank the faculty who have considered their time and energy to spend with the postgraduates. Again, thanks to Kaushal Madan, Govind Makaria and Dr. Ravi for spending their valuable time. I request the first presentation for today is CPC. CPC is a wonderful way of learning things, and I requested Dr. Ramakrishna and his team to give a case. I requested Dr. Babu to give a brief before we go on to the next.
So, good morning. First of all, we would like to, on behalf of the SIMS team, we would like to thank Ubal and the organizing committee for thinking of us and giving this case. Actually, this was suddenly Dr. Ubal asked me to come and give a short introduction. So, actually, this was a case which we had a mild difficulty 2 years back. Subsequently also we had many cases, but we thought this would be a very good case to be discussed. So the pattern of the CPC will be, first the history would be given to Mr. Rao, who will come and discuss about only the history and give a short gist of his diagnosis using history. And then Ms. Dinu will take investigations and then give her view of the case, and Alagamai would at last give her expert opinion. And to rebut them all will be Dr. Bhanumati, who will finally give the diagnosis. So the CPC will be conducted by Dr. Ramakrishna, sir. Fine, sir. You just sit.
I request Dr. V. Jayanti, Dr. S. Jeshwant, Dr. P. Batmanabhan, Dr. Kani Sheikh Mohammed to chair the session. I kindly request you all doctors to take the place on the dais.
We start the proceedings. We request Dr. Ramakrishna to take over. And who's taking up the presentation? Okay, Dr. Kondi. Dr. Ramakrishna and Dr. Bhanumati can come onto the dais. Bhanumati and Dr. Alagamai.
Oh, okay.
Good morning, respected professors and my dear colleagues. Today I am going to present, my name is Dr. Kondalrao. I am DM resident from Madurai Medical College. I am presenting a CPC today. Case history I am presenting. This is a 43-year male who is a diabetic and hypertensive on metformin and amlodipine. He is working in a construction company. Presented first index presentation in July 2017 for dyspeptic symptoms, and upper UGS scope showed submucosal mass lesion in the esophagus a small gastric ulcer in the antrum, and whitish spots in the duodenum, chorylymphangiectasia. The histopathology report revealed H. pylori associated chronic gastritis, lymphangiectasia in the duodenum. And he underwent CT chest, which showed a homogeneously hypodense eccentric submucosal lesion in the upper thoracic esophagus, which is measuring 2 into 2 cross centimeter, followed by which he had an EUS and FNB with an histopathology suggestive of leiomyoma. Patient was told no active intervention was required and discharged. These are the images showing the submucosal mass lesion in the esophagus and EUS finding and the antral ulcer. And in December 2017, he again admitted with diarrhea and uncontrolled diabetes. In February 2018, he again presented with the pain in the right iliac fossa with no fever and vomiting. CT abdomen was suggestive of acute appendicitis, and he underwent appendicectomy. Again in April 2018, he presented with high-grade fever, vomiting, and upper abdominal pain, which is non-specific in nature. At that time, CT chest revealed bilateral basal segmental infiltrates with consolidatory changes with right middle lobe infiltration and bilateral minimal pleural effusion. Sputum culture showed no growth, and bronchoscopy was normal, and BAL culture was normal. Expert TB and ABP is negative. Patient treated with antibiotics improved and hence discharged. After discharge, again he admitted after 5 days with persistent cough, treated with inhaled steroids, with which the symptoms subsided. Again in the first week of August 2018, he again admitted to the emergency with bilateral flank pain associated with vomiting, and serum creatinine at that time was 1.94 with normal urine routine and negative urine culture with a total count of 12,000. CT KUB done, which showed bulky kidneys with perinephric fat stranding and an incidental focal wall thickening with ulceration and calcification in the posterior wall of the stomach along the lesser curvature was noted. So again he underwent an UGScopy, which showed the similar esophageal lesion with submucosal lesion and ulceration in the distal body along the lesser curvature involving the incisura. Again the histopathology report showed mild chronic gastritis with focal minimal active inflammation, reactive changes, and evidence of ulceration. During his stay, the serum creatinine increased to 3.85, and nephrologist opinion it could be interstitial nephritis, and urologist opinion in view of thickening of bilateral uretral thickening suggested DJ stenting, but patient refused and he improved with antibiotics. Renal parameters came back to normal. Again in the last week of August 2018, he admitted with pain abdomen for 3 days and non-bilious vomiting minutes after having food and was non-blood stained. The pain was acute in onset, persistent dull aching, lower abdomen, non-radiating, pain subside momentarily with vomiting. And there is no history of abdominal distension, constipation or obstipation, weight loss, fever, jaundice, early satiety, loss of appetite, odonophagia, dysphagia or any altered bowel habits. Family history nil significant, personal history denies any addiction, belongs to upper middle socioeconomic class according to modified Kuppuswamy scale, consumes mixed diet and daily intake is 1500 kilocalories, proteins approximately 40 grams. General examination, he is an obese, weight 90 kgs of BMI 30, vital stable, no pedal edema, clubbing, cyanosis, raised JVP, palar, icterus, lymphadenopathy, other systems are normal. Per abdominal inspection, no peristalsis, no distension, no visible lump or scars, palpation is soft, no hepatomegaly, except mild tenderness in left lumbar region. Percussion, tympanic and percussion, no free fluid, auscultation, no bruit, normal bowel sounds. So this is the history and summary. 43-year male, diabetic, hypertension and obese, metabolic syndrome, initial presentation in July 2017 with organic dyspepsia and diagnosed with antral ulcer and esophageal leiomyoma. Again in 2017 with acute diarrhea. Again in 2018 with appendicitis, underwent appendicectomy. In 2018 he admitted with respiratory tract infection with improved with antibiotics and steroids, and in 2018 choriopilonephritis, and again in August 2018 it can be related to peptic ulcer disease. And the endoscopy, which was initial in July 2018, and this is in August 2018, and endoscopy showing gastric ulcer. So my differentials should I consider as in view of recurrent gastric ulcer or refractory gastric ulcer with multi-system involvement. And benign causes are first H. pylori related peptic ulcer disease, second IgG4 related, and third is Crohn's, fourth is tuberculosis, malignant neuroendocrine tumor, lymphoma, systemic mastocytosis, carcinoma stomach, GIST or G cell hyperplasia. And
there's some confusion. Yeah, can you analyze? You've got too many differentials, based on the chronological sequence of events that has taken place.
Okay, ma'am. First, in favor of peptic ulcer, because
No,
it
you have
can
to explain. Do you think it's one disease? You think it's multi-system disorder?
Multi-system-
or
multi-system.
you think the same disease has progressed to the end stage, what you're seeing now?
it is multi-system disorder, I am thinking, madam,
So
because
what are the systems that have been involved in this particular patient from 2017?
first initial index is about GI symptoms he presented, madam, dyspepsia, followed which he had diarrhea, after which he again went appendicectomy.
So how do you explain the diarrhea? What was the diarrhea in this patient?
Madam, it can be due to one episode of diarrhea, it can be due to infectious also, but we don't have history whether it is similar episodes of diarrhea is there or not, we don't have history,
No,
madam.
we need the details. I just want to know whatever information was given to you, what was the duration? It's chronic? Is it related to the dyspepsia? What was
Duration not given, madam, only patient admitted with diarrhea, at that time noticed uncontrolled sugars.
So you think it was diabetes related, uncontrolled? Do you think it's a possibility?
Because of uncontrolled sugar, I thought it is due to infectious, any etiology.
No. Diabetes itself can cause diarrhea.
Yes, madam,
Uncontrolled
diabetes,
and bacterial
yes.
overgrowth. So that
Yes.
itself can cause uncontrolled diabetes. Metformin can cause.
Yes.
So do you want to put that as one of the problems in this particular patient, or you want to ignore it?
I
And
want.
what's the link between that leiomyoma and that one pain in the right iliac fossa? Do you think, what are the differentials? You have too many differentials which was not fitting into. Just bring your differentials. Now, can you explain all your problems related to peptic ulcer disease and H. pylori related treatment failure?
Because, yes, madam, H. pylori, initial biopsy showed
The
H.
entire
pylori.
presentation till now. Can you explain just on that?
No, madam, we can't explain that, madam.
No, so just move forward to say what are the possibilities that could tell you what is the differential?
My diagnosis, I favor of IgG4 related, madam, one, because I can explain diarrhea, appendicitis, and episode of respiratory tract infection, which is relieved by inhalation of steroids, and refractory gastric ulcers. And it can history of appendicectomy is there, so I consider Crohn's disease.
Would you like to consider carcinoid?
Yes, madam, malignant I consider as neuroendocrine tumor.
In that, is it functional or the non-functional? Which one do you think? Is it
Functional, I am thinking.
Pancreatic or non-pancreatic?
Functional, madam, pancreatic I am thinking, because of gastrinoma, it can present as refractory ulcers. And in neuroendocrine tumor, functional pituitary gland tumors can present with ectopic ACTH secretion, can cause obesity, diabetes, and hypertension.
We don't have all that information, no?
Patient is diabetic and obese, madam.
What is the BMI? I didn't get that.
BMI 30, madam.
30. Okay, you think, so one possibility is probably in NET.
NET,
In
madam.
NET, which type you think it is?
Men,
Can it be Zollinger?
Zollinger associated
Ulcer
with,
disease, watery diarrhea,
yes, madam. And
refractory ulcer.
patient also having and CT diagnosed of calcification. It can be due to dystrophic calcification because of hyperparathyroidism.
No, is it men? Is it one of the men?
Men.
Is it one of the men? No, you have to shortlist and tell me. Is it? To me, it looks as though it is one of the NETs. So in that NETs, what do you think it would be? Lymphoma, I don't think I would consider.
Okay,
Systemic mastocytosis?
Because of refractory ascites and diarrhea, I considered as refractory ulcer and diarrhea is there, madam. Patient also having wheeze, which is decreased with steroids.
I think what gets out is carcinoma stomach, that will be
Cards out, madam. Gist
Lymphoma,
also out.
Lymphoma will also not be there. Gist is also unlikely.
Unlikely.
So
My
Aligama, you would like to rebut?
This diarrhea was not mentioned as recurrent diarrhea. It was not a chronic diarrhea. It was treated as infectious diarrhea and diarrhea recovered. So that means you should take it as a short duration diarrhea. So whether to bring in diarrhea as a part of this persistent ulcer, I'm
So
not
what's
sure.
your take? What's your take in this particular patient?
So benign will be peptic ulcer disease. Malignant will be either neuroendocrine tumor or some other mesenchymal tumors. May not typical of GIST, but other mesenchymal tumors also we should consider, I think, because it is more of submucosal lesion with a small mucosal ulceration.
Respiratory symptoms?
So he is a diabetic, madam, so he can have infections. He is an uncontrolled sugars, short-term diarrhea, one appendicitis, one respiratory infection that settled, not like a recurrent wheezer, not like recurrent diarrhea. So if you have to put everything together, it's difficult. But neuroendocrine tumor, I will put in first among the tumor.
Biopsy?
Chronic inflammation only, sir. First biopsy was H. pylori, second biopsy was chronic inflammation. But this endoscopy mention is it's a submucosal lesion. I think the esophageal lesion and this one are different. This is a proven leiomyoma in the esophagus, which is a small lesion which was not even picked up in the further CTs, and it is asymptomatic, is incidentally detected.
We don't have any information on immunohistochemistry.
We don't have. But the biopsy is reported as leiomyoma is mentioned. So we guess that leiomyoma was diagnosed with immunohistochemistry.
Anyone in the audience would like to take a call on the differential? Who are the other participants? Dino is there, no? Yeah. There were two other participants. Dino?
First possibility will be a peptic ulcer disease, and second, I would think of a
You have to keep the entire, from 2017 till date. Peptic ulcer disease, what is it? Acid peptic disease, is it gastric ulcer, duodenal ulcer, what are we talking about? And explain the whole gamut of presentation in this particular patient with your diagnosis.
So considering the entire case, I think it is more of a multi-system involvement. Whereas when we consider the refractory ulcer, it could be a gastrin-secreting tumor causing this recurrent ulcers or a non-healing ulcer, probably a gastrinoma with the MEN1, and his diabetes could be explained by the multiple infections he has had. Also, IgG4 disease can explain the multi-system disease, this pyelonephritis and this interstitial pneumonia. Also, other thing I would think is a hypereosinophilic syndrome leading on to eosinophilic gastroenteritis and ulcerations, and also lung pneumonia. Because the bowel cultures were all negative, we don't know what was the eosinophil counts.
What was the eosinophil count?
Eosinophil count not. Total count only there, madam. 12,000, madam.
12,000. So the differential?
Not given, madam.
Can we have some information? We don't have any.
Later, some more differentials are given if there is no eosinophil.
There's no eosinophil. Dr. Govind, you would like to come in?
I think it's too many things in this patient. So first of all, the certain things are not part of the same disease. For example, leiomyoma or diabetes, and few of the episodes of admission because of diabetic complications like pneumonia or other things. But coming to crux of the thing, what he has is non-healing ulcer for years together, despite PPI. That's one. Number two, his kidney functions have worsened from creatinine from 2 to 3. So now he also has chronic kidney disease. Bringing two of these together, is it some kind of hormonal secretion which leading to both disease? For example, hyperpara, hypercalcemia, calcemia-induced disorder. At the same time, hypercalcemia-induced peptic ulcer, like hypergastrinemia secondary to hyperpara, or there's a MEN1 syndrome, some kind of MEN syndrome, which is a multiple hormone being secreted, leading to multiple manifestations. This looks like one of the possibilities.
Amyloidosis?
Less likely. I mean, uncommon, too diffuse, like amyloid leading to kidney disease, then also lead to peptic ulcer disease. Amyloid only peptic ulcer, not sure.
It is acute disease recovered also. Creatinine became normal. It is not a chronic disease.
I missed that. That part I missed.
Dr. Ashok, you have any comments? Ashok, any comments? Anyone else? Anyone else in the audience? Should we move on?
Still patient is obese.
Yes,
Taking
sir.
1,500 calories only, 40 gram protein. How will you explain the concept malignancy? Uncontrolled diabetes. Uncontrolled should cause weight loss.
Yes,
Not
sir.
taking adequate calories.
Still
he is obese.
Weight loss, we can't explain, sir, because in I am thinking in favor of neuroendocrine tumor. So any hormone secretion, even the patient on diet, he will be on.
Dr. Raghuram, sir, any comments?
I came late, time in the discussion. My bet will be neuroendocrine tumor. Multiple hormones, I like go in my career. Multiple hormones are being secreted. Possibility is gastrinoma is high because of the intractable pepticles in spite of PPA therapy. But diarrhea is only short duration. But appendicitis, I am not able to explain. Right?
Too much of differential diagnosis, both benign and malignant. Do you think these are unrelated or two different scenarios?
Because every system we can't explain with in peptic ulcer we can't explain why diarrhea and renal involvement, sir. But H. pylori positive and whether a patient has treated with H. pylori or not, we don't know, sir. So I put as first benign of peptic ulcer disease and neuroendocrine tumor because I considered it is a multi-system and patient having obese, diabetes, hypertension with refractory ulcer. So I considered it as some neuroendocrine tumor.
I think the second bit would be systemic mastocytosis, probably. Rajesh? Salem Rajesh? No comments.
Ma'am, I don't think we should take it as a multi-system. I feel all these things are, one consolidation, one pyelonephritis, we commonly see in diabetic patients. Since it is multiple things, it should not be bringing together into a single diagnosis. What I feel it's given for confusing us rather than directing towards a single diagnosis, I guess. Because it was not a recurrent respiratory infection, it was not recurrent wheeze, it was not recurrent diarrhea, it was not recurrent renal involvement. It's all one episode over a period of 1 year in a patient with uncontrolled sugars, which we regularly see in our daily practice. Somebody with ulcer, which is there for about a year, 2017 documented ulcer, 2018 documented ulcer, peptic ulcer disease scores first. Then we have to think of tumor, is because it is a submucosal lesion mentioned in the upper GSCOP, not as a mucosal ulcer simply. So it could be something like tumor. Definitely no carcinoma, no lymphoma. Must be mesenchymal tumors, GIST or other mesenchymal tumors rarely, because it is CPC, we should think of rare things. Schwannoma, glomus tumors, such mesenchymal tumors can also present as stomach wall thickening with submucosal lesion and mucosal ulceration. So instead of thinking everything together, I think we should go as gastroenterologists and think of something.
What was the presentation to the hospital, the last admission, last time?
Last time, pain abdomen, vomiting, madam. Pain abdomen and vomiting.
Was it like gastric audit obstruction, that last bit, the last final?
No, madam, not any GVO features are not. Immediately after taking food, patient vomited, the non-bilious vomiting and pain abdomen relieved. Whether it is due to peptic ulcer or pancreatitis, we can't able to tell.
Yeah, Jayanti, the thing is there are many issues which came up. I think most of them are single issues which can be ignored. For example, the respiratory infection, the acute diarrhea, all this if you put away and concentrate on the stomach. That has been there for some time.
Yeah, that's what I was thinking. What was the current?
Yeah, the current thing is
renal
he has had recurrent ulceration in the stomach. They've had surgery for a mass lesion in the posterior wall of stomach. The other important point I thought is when they gave PPI, there was a significant reduction of symptoms. So my bet would be that he probably has a gastrinoma, some lesion like a neuroendocrine tumor, maybe a gastrinoma, which has involved the pancreatico-gastric area. And that is why, and also probably some metastasis for which things are looking bad. That's my diagnosis.
LBK? The hepatologist? Who are you? gastroenterologist, your comments on this? No comments. Okay. Shanti? Shanti, any comments? Differential? Can we move on? Rama, what was the working diagnosis when the patient came? Who was the person who was seeing the case when the patient came to the hospital? So we can have the differentials at that point of time. What was the working diagnosis when the patient came to the hospital?
Sorry, I'm clouded by the final diagnosis, so it's hard to say.
Okay. What came to your mind that time? I think we can move on. Be postgraduates, any differentials? Postgraduates? Okay. Yeah, you want to say something?
Thank
you. Good morning, everyone. So I would continue with the investigations and management of this patient. First of all, I would like to thank all my mentors, faculty, and my colleagues for helping me in preparing this case. So, as baseline investigations, we could see from this slide. I would highlight all the abnormal values alone. His total count was 14,000 with a predominant neutrophils of 75%. Urea was slightly on the higher side, 47. Creatinine was 1.94.
What date is this? This is the
last admission, ma'am.
Last admission.
So CRP was 11.9 and ESR was 42. So from the LFT we could see that albumin was 3.2, which was slightly lower for this patient of age. So this was the CCT done in August 2018. We could see the stomach. There is a submucosal lesion sitting there with the focus of calcification. So the CT report was microlith in the left kidney, non-obstructive changes, focal heterogeneously enhancing wall thickening with ulceration and calcification in the posterior wall of the antrum of stomach along the lesser curvature. So gastric wall lesions, what do we consider? There is a big list of lesions, submucosal lesions to be considered. Considering the ulceration and the calcification in this patient, I would bring down the list to benign causes of leiomyoma, schwannoma, Crohn's disease or an amyloidosis, and malignant I would like to bring about adenocarcinoma, gastric lymphoma, an NET, gastric or a carcinoid, and a rare possibility of leiomyosarcoma. So these are the common differentials and these are the rare possibilities in this case. So we move on to discussion. Clinical diagnosis was gastric tumor was made and surgical gastroenterologist consultation was obtained and patient underwent a laparoscopy which was converted to a laparotomy. So 7 into 5 centimeter mass in the greater curvature extending over the posterior wall up to the lesser curvature was noted and the mass was adherent posteriorly to the mesocolon. So a partial gastrectomy with Wilrod type 1 anastomosis was done. Surgical pathology will be discussed later. So after August discharge with a partial gastrectomy, again in October 2018, he returned to the hospital with abdominal pain, mainly in the left upper quadrant with bilious vomiting and weight loss. So this abdominal pain was in the left upper quadrant, continuous, unrelated to meals, dilating type of pain and not radiating. It was associated with occasional episodes of non-bilious vomiting. Weight loss was around 12 kg in the past 3 months. There was no history of any back pain, GI bleed, jaundice or altered bowel habits. Per abdomen examination was soft, non-tender, no guarding or rigidity. Baseline labs, amylase and lipase were normal. So in a patient with 2 months post-partial gastrectomy with a Wilrod type 1 anastomosis, presenting again to us with left upper quadrant abdominal pain, unrelated to food with bilious vomiting and weight loss. What are the possibilities we would consider? So a persistent or a recurrent peptic ulcer disease, probably a H. pylori treatment failure, or a partial gastrectomy with a remnant antrum secreting more gastrin leading on to recurrent ulcers, and inherently increased gastrin secretion as in gastrinomas, acid reflux after a Wilrod 1 causing all symptoms, or a post-gastrectomy syndrome, a drug-induced gastritis, and anastomotic stricture site narrowing, which is unlikely in this patient as he had bilious vomiting, subacute small bowel obstruction due to adhesions, pancreatitis despite normal amylase and lipase values. And splenic infarct to be considered in this case is quite unusual because it is more common in the early postoperative phase. So an upper GI was done which showed a submucosal lesion in the esophagus with grade C esophagitis, postoperative stomach with narrowing of the gastric lumen at the anastomotic site. A long wedge-shaped ulcer was noted along the greater curve parallel to the anastomotic site, and a clean base duodenal ulcer was also noted. So these are the images of the ulcer. So differentiations for gastric ulcer, that is recurrent gastric ulcer in the background of partial gastrectomy. We have already discussed a few: incomplete antrectomy, H. pylori, gastrin hypersecretion, drug-induced, Crohn's disease, tuberculosis and amyloidosis. And also we should consider rare possibilities like systemic mastocytosis, viral infections, a vasculitis or a vascular insufficiency leading on to ulcerations, and 10% of gastric ulcers occur without a reason being identified. So HP from this anastomotic site ulcer showed ulceration with mild chronic active inflammation and submucosal fibrosis. So additional information we would like to know from this ulcer would be from this biopsy would be H. pylori was demonstrable or not, whether there were any inclusion bodies, whether there was presence of granulomas, whether there was presence of mast cells. So this admission as ECT was done which showed narrowing of gastroduodenal anastomosis with dependent food debris within the stomach, and the volume of head, proximal body and uncinate process of pancreas was reduced with smooth surface and enhancement lesser than the rest of the pancreas. So a halo appearance was noted around between the head of pancreas and the adjacent gastroduodenal anastomotic site, suggestive of a pancreatitis. So at this point of time, what all add-on investigations we would require is a serum gastrin level, a serum stool H. pylori antigen, a fasting lipid profile, differential count in the form of eosinophils, IgG4 levels, serum calcium or parathormone, ultrasound neck to road parathyroid adenoma, and a 2D echo. So the further course, he was given pantoprazole, sucralfate and other medical management was done. Patient improved symptomatically and was discharged. In December 2018, the patient was readmitted with persistent epigastric and left upper quadrant pain for the last 1 month duration, more since the last 3 days, and occasional vomiting. So upper GI scopy was again done, showed a partially healed residual gastric ulcer and a healing duodenal ulcer. These were the endoscopic images of the ulcer which we have visualized previously. So differentials at this point, a partially healed ulcer despite PPI should be a refractory H. pylori, gastrinoma, Crohn's, tuberculosis or a vasculitis. PET-CT was done which showed evidence of partial gastrectomy, gastroduodenal anastomosis with the minimal patchy metabolic activity at the anastomotic site, which is likely to be inflammatory related. No other significant mural thickening or luminal narrowing, and an upper thoracic esophageal thickening with mild metabolic activity, and bilateral kidneys were enlarged with perinephric fat stranding and diffuse increased metabolic activity, likely an infective or an inflammatory reason. So no other metabolic activity elsewhere in the body. So this patient continued to have persistent pain in spite of opioids, and following which he was treated with erecta spinae block, and as pain persisted, he was again done an RFA of the dorsal root ganglion along with celiac plexus block. Again in January 2019, patient presented with abdominal pain relieved by vomiting. So this time CT showed a retention of oral contrast in the stomach, which was suggestive of gastroparesis or a gastric outlet obstruction. And after discussion with surgical gastroenterology, a combined decision was taken, and he was proceeded on with a gastric antral resection with truncal vagotomy and gastrojejunostomy. So his symptoms improved and he was subsequently discharged. So these are the entire summary of the course of events in this case, starting from July 2017 till January 2019. One thing I want to highlight in this case is everywhere we see a gastric ulcer which is persisting throughout the course of illness. And in October 2018, it turned out to be a recurrent ulcer rather than a mass alone. So components in this case to be considered for a multisystemic involvement would be a refractory gastric or duodenal ulcers, which as gastroenterologists we would be interested to look upon, with the gastric mass, and esophageal leiomyoma, appendicitis requiring an appendicectomy, a bronchopneumonia which improved with steroids, and an acute interstitial nephritis or a pyelonephritis probably which improved with antibiotics, an episode of pancreatitis, and metabolic syndrome with obesity and diabetes mellitus. So what are the systemic disease I would consider in this case would be a IgG4 connective tissue disease, an IgG4 related disease, a gastrinoma plus syndrome as in MEN1 syndrome, causing hyperparathyroidism related pancreatitis, and gastrinomas could explain the recurrent ulcers. Amyloidosis, which is a rare possibility, sarcoidosis explaining its lung symptoms and the ulcers, a small vessel vasculitis like granulomatosis with polyangiitis, that is vaginous granulomatosis, causing lung involvement as well as pancreatitis as well as this gastric ulcers. Systemic mastocytosis. This is actually a variant of cutaneous mastocytosis. Without cutaneous lesions, it can present as only systemic involvement. It is called as indolent systemic mastocytosis. A hypereosinophilic syndrome leading on to lung non-infective pneumonia-like presentation, and a recurrent eosinophilic gastroenteritis causing recurrent gastric ulcers. Crohn's disease, of course, upper GI Crohn's is less than 3 to 4%, but we still do consider. And primary immunodeficiency like a CVID, which is very rare in this case. So further investigations I would ask for this patient is based on the differentials and ANA profile, C-ANCA or P-ANCA, IgG4 levels. This is after the biopsy specimens. So we review all the biopsy reports and then we would work up further. IgA level, a serum tryptase level for systemic mastocytosis, rheumatoid factor, fasting gastrin levels for gastrinoma, a gastric biopsy review to look for H. pylori, presence of granulomas, presence of inclusion bodies, appendicectomy biopsy we want to review, a gastric mass biopsy we have to look at the biopsy reports, an absolute eosinophil count, BAL eosinophil counts to look for hypereosinophilic syndromes, serum ACE levels to rule out sarcoidosis, a bone marrow biopsy for systemic mastocytosis, and a cystoscopy plus biopsy as he has been having this perinephric fat stranding with the wall thickening of ureters persistently. And probably a fundus examination could give us a hint on vasculitis. On follow-up, the patient regained weight and remains asymptomatic.
That's a very nice presentation, well done. The previous slide, can you just shortlist and give us 3 important differentials at the end of all this?
Ma'am, sorry ma'am.
3 important differentials.
Yes ma'am. So 3 important differentials I would consider in this case would be a gastrinoma plus syndrome, a systemic mastocytosis, and a IgG4 related disease.
IgG4. I think vasculitis, I'm not certain. Any opinion from the Ashok now? Ashok. Any differentials you'd like to? Remains the same? Gastrinoma. Aligament?
At the end of history, we thought of benign peptic ulcer disease, tumor, we thought of neuroendocrine tumor, which is obviously gastrinomas, gastrin-secreting neuroendocrine tumor, and mesenchymal tumors. So if it is mesenchymal tumor, after surgery, patient should be all right because the tumor is out and patient should be all right. Since patient have recurrent ulcers, gastrinoma scores more than mesenchymal tumors. Benign disease, benign peptic ulcer is not there. We should also consider upper GI Crohn's, I think, because anastomotic ulcer with gastroparesis-like symptom, gastric outlet obstruction is coming soon. Though it is rare, among the benign condition, we should think of upper GI Crohn's.
NPK?
The recurrent ulceration, I think the most probable diagnosis will be a gastrinoma plus syndrome. I'm a little hesitant to think of isolated Crohn's with so much of ulceration without involvement of large bowel. In experience, most of the times our gastric Crohn's was granulomas found on a biopsy when we did a colonoscopy on these patients. But looking at it, going on for 3 years, and patients' ulcers seem to have come down well after antrectomy. His antrectomy was done recently. So probably the most thing will be a gastrinoma syndrome.
The response to steroids, I was just thinking of IgG4 multisystem. Any comments on that? Respiratory symptoms have subsided.
Inhaled steroid is given for some days. Initial respiratory symptom got subsided antibiotics, patient got discharged, came back with wheeze.
One other symptom came down with steroid, no?
Inhaled steroids for the cough.
After his bronchopneumonia, he presented with persistent cough, ma'am. So that time he was started on inhalational steroids.
So Banu, I think we're shortlisting it to one of the neuroendocrine tumors, and I think gastrinoma will be the bet, most likely. And second, Alangamai says Crohn's. The third, I think, is mastocytosis, systemic mastocytosis. Eosinophil count is normal?
They've not mentioned, ma'am. So far.
Absolute
not mentioned, ma'am.
There is no eosinophil count. The differential count they have given, there is no eosinophil count.
They have mentioned only on neutrophils and lymphocytes, so probably it was normal. They have
differential is normal. There are no comments from the audience. We request Banu to.
One more, ma'am.
Yeah.
I haven't seen a case, but when I read for all these things, I read inflammatory pseudotumors, mesenchymal, inflammatory myofibroblastic tumors, IMT. They are pseudotumors. They can also present like submucosal lesion with the mucosal involvement, and they can be asymptomatic, or they can present exactly like a peptic ulcer disease, and they can present like refractory peptic ulcer disease, and they can also recur at the anastomotic site.
But response to PPI?
Response to PPI will be there because it's an inflammatory condition, but not completely responding. So I read that. I haven't seen a case since I read a lot of things related to this. I came across one IMT.
Yes, ma'am. Yes. One more comment. This pseudotumors are also being reported in IgG4 related diseases. So probably the submucosal lesion could be explained by that.
Request, I think, Dr. Banu?
I think two important things which to me suggest a gastrinoma. One is response to PPI. The second is after the vagotomy, he seems to improve. So these two features suggest to me that more likely we are dealing with. So these are something to always keep in mind. Response to PPI, either with diarrhea or recurrent ulcer, or especially diarrhea, you should always think of gastrinoma.
In between, there's one history with severe weight loss, no?
Yes, ma'am. After the partial gastrectomy. Yes, ma'am. After the partial gastrectomy, he presented with abdominal pain, vomiting, and weight loss, ma'am. During the post-operative course, within 2 months, he has lost 12 kgs.
With Roth 1, you will not get so much of a weight loss.
Yes, ma'am.
Yes, Abhi?
I too agree it's a gastrinoma, and there's a hidden primary. Did you consider a gallium PET scan? DOTA PET?
DOTA PET.
No, ma'am, we don't have report of, only PET scan report we have.
Okay.
What's your take on the patient?
I think it's a gastrinoma, and there is a hidden primary, and I was thinking a hormone-based localization would be helpful.
Okay, I think this time is running out. Dr. Banu, I'd like to, the final verdict from you now. Dino, you did a wonderful job. It was good. Excellent.
It's not opening. Oh. Good morning, everybody. As a pathologist, as a final diagnosis, it's interesting to see the various discussion that is going on. And first, I would like to say I came into picture during the section where I made a diagnosis. I think I saw the esophageal biopsy was reported by the pathologist as just a small smooth muscle bundle. So with that, we can't give a diagnosis of leiomyoma because it could be even a normal muscular layer from the esophagus, because it is reported because in view of the submucosal lesion, the possibility of leiomyoma cannot be excluded. And so when the patient underwent a gastric wedge resection, and the grossly we found a globular submucosal lesion measuring about 6.5 into 6 into 4 centimeter, Cut surface has a grayish-white appearance with small foci of calcification. And you can see the microscopically on the left hand, there is a wall of stomach with a marked submucosal fibrous, is there any pointer, please? Fibrous expansion with lymphoid aggregates. On the right side, you can see a lot of lymphoid follicles with the prominent germinal center. And there is again the lymphoid follicles with prominent lymphoid follicles with prominent germinal center. There's a lot of fibrosis. It's not a very classical storiform, maybe a faint storiform pattern. And here it's a fibrosis extending through the muscularis propria, extending up to subserosa. And you can make out a diffuse inflammatory cell infiltrate throughout the wall of stomach. And also there is a fibrosis and muscular hypertrophy. And I'm sure you can make out the cords and clusters of plasma cells here in the background of fibrotic stroma. And also some areas, there's quite a bit of eosinophils were present. We did the IgG4 immunohistochemistry. It's about 35 to 40 immunoreactive cells per HiPA field. So microscopic finding to summarize, there's a marked fibrous expansion extending through the muscularis propria to the subserosa. Diffuse infiltrates of predominantly plasma cells admixed with the lymphocytes and the eosinophils, and several lymphoid follicles with reactive germinal centers. There were small foci of calcification, disorganized muscle coat with the hypertrophy, faint storiform pattern of fibrosis. We did not find any evidence of obliterative or non-obliterative phlebitis. So final diagnosis that we made, gastric IgG4 related disease presenting as a mass lesion. We asked the clinician to do a serum IgG4 level, which was really elevated. It was 4.36 gram per liter. And so IgG4 related disease is an mediated fibroinflammatory lesion. It first described in patients with sclerosing cholangitis associated with autoimmune pancreatitis type 1. Later in various other organs, liver, bile duct, salivary gland, retroperitoneum, lymph nodes and lungs. We are actually seeing in a lot of cases, even CNS, we are finding this disease. There's a diffuse or partial enlargement of the organ. Histologically, one will find a dense lymphoplasmacytic infiltration with increase in IgG4 plasma cells on immunohistochemistry, a storiform pattern of fibrosis, and obliterative or non-obliterative phlebitis. There's increase in serum IgG4 level. In GI tract, it is very rare. In fact, immediately after this case, within a month, we had another case. Actually, in the last 40 years of my pathology practice, this is the first time I'm seeing 2 cases of IgG4 related disease in the GI tract. I've seen in other organs, but not in the stomach. And so it's very rare. It can present as a diffuse wall thickening or as a polyp or mass-like lesion. So presence of at least 2 histological features is required for confident diagnosis of IgG4 related disease. In fact, in olden days, we used to call it as an inflammatory pseudotumor even in the buccal mucosa when there is a plasma cell or plasma cell granuloma. After the advent of IgG4 related disease, you almost find it in many organs. Recently, we had in the ophthalmic case also, that is also from the GI unit. In most cases, a dense lymphoplasmatic infiltrate and a diffuse or storiform pattern of fibrosis are seen. Additionally, clinical serological parameters are essential. Serum levels of 135 milligram per deciliter or 1.35 gram per liter, or radiological evidence is required to confirm IgG4 related disease. You can look at this article, it's very nicely given for various organs, the number of plasma cells. Because it varies, you have to really take into account all the other parameters because various organs, the number of plasma cells, IgG4, for example, in a biopsy, even if you say 10% is considered as significant, but you need to correlate with the serum and other clinical parameter to call it. Just by saying plasma cells alone, you cannot call it. You have to do a combination of various parameters to diagnose this condition. And then later on, this patient had multiple follow-up biopsies. I was just asked to present these findings also. The biopsies, I am just putting only the important one, December 2018 and January 2019 from anastomotic. The first one did not show H. pylori immediately after that, but after that we continue to see the H. pylori associated mild to moderate chronic active gastritis. And one of the biopsies, I found a lot of plasma cells. Because of the background history of plasma cell related, I asked the clinician to look for the plasma cell again. So it was IHC, it was a 10% plasma cells. Serum IgG4 level, in December 2018 was 2.71 and in January it was 2.53. Still it is elevated. Sleeve gastrectomy was done February 2019, which also again showed H. pylori associated mild to moderate chronic active gastritis. And vagus now was nothing. We also found a mesenteric nodule. It was just a solitary papillary mesothelioma. And omental biopsy, I think the patient has undergone somewhere outside. We have asked to review that, which showed only a fibrosis, chronic inflammation, giant cell reaction, fat necrosis, and with focal calcification. And there was no lymphomas. Clinician wanted us to do a CD20, though we said it is not there, but it was just a few lymphocytes were there. This is just to show you the H. pylori associated. You can see the lot of plasma cells even in this part. And here you can see a lot of sheets of plasma cells. So it showed 2.53 serum and IgG4 was 10%. And this you can see a pit abscess, the neutrophil aggregates within the foveolae. And I'm not sure whether we can make out here this HND with H. pylori. The next sleeve gastrectomy also had mild to moderate chronic active gastritis. You can see the neutrophilic infiltration within the epithelium and also in the lumen. This is a James Hurst illustrating the H. pylori organisms. And the mesenteric nodule, it is again an incidental finding. It's a well-differentiated papillary mesothelial lesion, which they call it as a benign mesothelioma. The calcitonin showing a mesothelial positivity. It's usually you can find them in incidental finding in laparotomy, which is due to reactive mesothelial proliferation, not related to asbestos exposure. I think that's all the, thank you.
Thank you, Madhu, for the wonderful presentation. Dr. Aragami, your comments and learning points from this case.
So that means isolated gastric IgG4 disease. Must be reportable case, I guess.
Already reported.
There is no nodes, there is no salivary gland, there is no biliary obstruction, there is no straightforward pancreatitis except for one imaging of some halo around the pancreas, which was also not highlighted as a pancreatitis pain. So isolated gastric IgG4 disease, extremely rare. Nice case.
We've seen gallbladder mass presenting as IgG4, operated as GB cancer, turned out as IgG. So masses we are seeing. Pseudotumors. So that we have seen. So I think one thing that I thought was this response to steroid was only two, I thought, eosinophilic or it was IgG4. So it was that concern. Other thing is so many eosinophils, but peripheral smear is normal.
Did not show
counts. How often do you get this?
IgG4 is you can get a moderate amount of eosinophils in the tissue. So tissue eosinophilia doesn't mean you need to really look at it with the eosinophilic acid and everything. You have to look at serum IgE and all that. But eosinophils can be seen in IgG4 related.
So Dr. Rama, teaching learning points from this case.
One question, when after the surgery, we got the report of IgG4 disease. What was the reason for severe recurrent anastomotic ulcer? We could have treated the IgG4 like this.
So firstly, let me congratulate the DM and the DNB residents. They really hit the nail on the head. With their first diagnosis being IgG4 related disease. So I think the point that was made, right, the first presentation was that this is a multi-system. So he talked about ureteric thickening. So very often we sit with our radiologists, and every now and then our radiologists will say, I think this is IgG4. Most of them we chase, most of them turn out to be negative, but I think you always have to keep your mind open. And this issue of inflammatory pseudotumor, probably you have to look at all the inflammatory pseudotumors. Previously it used to be reported in liver also. Whether they are IgG4 related, we don't know. But so the learning point is just that when there is a multi-system disease, when it involves retroperitoneal, when it involves the biliary tract, whether it involves the GI tract, the kidneys, all of this, we do need to consider IgG4 disease. Coming back to what Dr. Aragame asked about why it recurred, we initially discussed with our rheumatologists and we put them on tapering steroids. and then we tapered it off. So at that point of time, we are not very sure whether to give azathioprine or something else in the longer term. The reason we asked for CD20 at one point of time was to see whether, because it was so recurrent, whether rituximab needed to be given. So these were reasons for following up the patient. I think this is just good to sensitize the audience to the increasing incidence of IgG4 disease.
Thank you, sir. What is the patient on now?
I am not sure what the patient is on now, but perhaps someone in the audience that. No, he was on azathioprine, but I don't think that he's taking anything right now.
Regarding Allegamys...
sorry?
No, go ahead, sir, please.
No, so it's been a long time since we've seen
treatment.
him.
Sure. So,
Recently went to him to collect to his CTs, but I don't think he's on it.
Actually, we followed up with him, sir. He was on steroids, a little bit of azathioprine. Now he has stopped azathioprine. As of now, he is at present not on any medications.
Regarding your take that isolated gastric IgG4 without things, sometimes I think literature describes that when you see IgG4 disease, you also look at the multiple organ involvement as a diagnosis. But recently we had a biliary stricture, isolated biliary stricture. We just wanted we were a little worried whether we're doing an operate on these patients. But we do see sometimes isolated organ involvement and coming as an IgG4. So a lady, middle-aged, came with a biliary stricture, turned out to be IgG4. Only the ampullary biopsy showed IgG4. Ampulla was absolutely normal in these patients. Just to reiterate that sometimes it just comes as an isolated disease.
Thank you. Thank you very much, Rama and Banu, for taking up this case. And round of applause for the two postgraduates who did a wonderful job. And for Allegamys taking us to this session. I thank my co-chairs for this session. Thank you.
Thank you, speakers. I request Dr. Jayanti to present a memento and honor her speakers. I request the speakers to be on the dais. Dr. B.S. Ramakrishnan. I request the speakers to be on the dais. Dr. Bhanubadi Ramakrishnan, Dr. Kondal Rao, Dr. Dinu Abhirami, Dr. P.L. Allegamys. Thank you, speakers. Thank you, chairpersons. The next session, Gastro Upgrade Session 1. I request Dr. V.S. Shanti, Dr. Usha Srinivasan, Dr. A. Aravind, and Dr. R. Ganeshan to chair the session. I request all the chairpersons to take the seats on the dais.
Good morning all. Next we'll move on to the gastro update session. First, IBD 10 Commandments by Professor B.S. Ramakrishna sir, please.
Good morning, everybody, and thank you for the opportunity to be here. I think true to his style, Dr. Ubal Das titled this talk as IBD, the 10 Commandments. So here we go. Can I have the first slide? Right. So 10 commandments, it's a little heroic task, but I'm just going to give you a little takeaway, what we should do for IBD in 2023. So first, thou shalt diagnose properly. So ileocolonoscopy with segmental biopsies from terminal ileum colon is the first line investigation, ECO guidelines. What I find with many of the patients who kept getting referred to us, that ileocolonoscopy, they just take biopsies from lesions. Very important to recognize that you need to take biopsies segmentally, because even uninvolved areas can give you differential diagnosis, say, between Crohn's and tuberculosis. Cross-sectional imaging. Again, I'm just going to run through this fairly quickly. CT and MR enterography are really what we use now. With CT enterography, the one thing that we find is a lot of CT studies are done as contrast CTs with positive oral contrast. What you have to realize is that for CT enterography, you should never give positive oral contrast because you will not get mucosal detail. You need to give negative oral contrast. So CT enterography, we use it as first line in patients, in adults who we are viewing the first time, because resolution of CT is better than resolution of MR. MR enterography is useful for follow-up or as first-line investigation in children. And MR enterography is particularly useful for differentiating between inflammation and fibrosis as a cause of strictures. Sometimes you can make out, based on the diffusion-weighted imaging and the T2 images, you can make out the difference between malignancies also. What about gastroscopy? Gastroscopy is not necessary really in adults with Crohn's disease, but in children, it provides a diagnosis in about 15% due to the presence of focally enhanced gastritis in incisura biopsies. And enteroscopy and biopsy will come into play when you don't have histology from the small bowel. So commandment number 2, thou shalt immunize the patient. Now again, even us, we very often observe this in the breach because we don't really foresee the time that these people are going to be on immunosuppressants. We don't ask them about immunization. As a routine practice, and I'm sure I can see Epen here talking about, because liver disease, they routinely do this, and we should be routinely doing this in IBD. Please do remember, no live vaccine should be given while on immunomodulators or biologics. So if you see an IBD patient for the first time, one thing is to ask about a history of chickenpox. If they've never had chickenpox, then give them the live varicella vaccine before you start them on immunosuppressants at some point of time. So obviously they should receive hepatitis B, pneumococcal vaccine is advised. Shingrix vaccine has just come into India. And so it is recommended in adults over 50 and those on immunosuppressants, flu vaccine and COVID as appropriate. Commandment number 3, thou shalt not give false counsel. Why do I say this? Because from the time the first biologics were introduced, or biologics were first introduced in India, patients used to get referred saying, you know, my doctor told me I'll have 3 injections of biologics and I'll be fine. And that's it. They think they can have 3 doses of infliximab and then they are all right. And you know, then the financial investment in infliximab stops. But that is not true. So what we have understood is that biologics need to be given lifelong. What happens when you stop a biologic? After 1 year, 50% relapse. After 5 years, 80% relapse. The good thing is that the 20% who, the 80% who relapse do respond probably again to biologics. But still, it just means that there's a continuing need for paying for biologics. I mean, this is important for most of our patients who really cannot afford the long-time investment that this requires. So we have some lessons from the STORY cohort, which is from France and Belgium, multi-center. So basically, they looked at people in whom biologics were withdrawn. And the best candidates for biologic withdrawal are those with inactive disease, both clinically, biochemically, and endoscopically. Those who are
on co-treatment with immunomodulators, that's azathioprine. Those who are doing well even with a very low trough level of biologics. That means they don't really need biologics to stay okay. And this constitutes only approximately 15% in the story cohort. But what the story cohort, you follow them up later, and there's a meta-analysis. Basically, it showed that this prediction model shows poor discriminative ability to predict relapse. So you cannot tell in an individual patient that we will stop biologic for you and you'll be all right. Tell them we do not know whether it will come back. You have to be prepared to pay for more biologics. And also remember the real world experience. This is from around the world, a Swiss author, Rogler. Basically, Crohn's disease, 50% do not need steroids. 25% remit with steroids. 15% require immunomodulators, and 10% need biologics. And it's the numbers are even less for ulcerative colitis. This is a real-world experience. Number 4, thou shalt drain abscesses. So active small bowel disease, where there is an abdominal abscess, ideally we manage with antibiotics and drainage, and ideally percutaneous drainage is preferred. At not too long in the past, maybe 10, 15 years ago, this was followed by surgical resection in about 40%. But now what we are finding is that many of these patients, you can totally avoid surgical resection by continuing biologics. Number 5, thou shalt surveil. And so this is essentially because we do come across the occasional ones where you do miss out a carcinoma, and for that particular individual, life is different. So what our experiences, although there are international guidelines on surveillance in UC, Indians seem to be less prone to colon cancer. In fact, many of the colon cancers that we've seen in ulcerative colitis patient have been diagnosed first off. They are operated for colonic cancer, and then it turns out that they have ulcerative colitis. In Crohn's, do remain alert to the possibility of small bowel adenocarcinoma in anybody with refractory symptoms, particularly small bowel obstruction, and remain alert to hematologic and other malignancies in patients on immunomodulators. So when you classify dysplasia and IBD, there are the echo statements last year on IBD and malignancy. Use these, describe the size, shape, surface, surroundings, and whether there's high-grade dysplasia or low-grade dysplasia. And increasingly, the treatment of dysplastic lesions, which are 2 centimeters or less, is endoscopic. Surgery is, when endoscopic expertise is not available, then surgery is there. So really, and these are the statements, how long you need to surveil them. Thou shalt exclude infections. So infections, and I'm sure all of you do this, we are seeing a lot of patients. We are increasingly seeing C. difficile infections in our patients. This is something, for years we've been checking for Clostridium difficile toxin in our patients, not only IBD patients, but also generally anybody with hospital-acquired diarrhea. And I never used to find it. But recently we've been seeing an upsurge of these infections. I don't know whether it's part of the epidemiological transition, that what was very common, for instance, in North India, in Mumbai and in Chandigarh, we're seeing a lot of it now. So this is part of the ECO guidelines again, that you need to look for these. And maybe Dr. Jaswant might smile here, thou shalt consider early surgery. So the LYRIC trial, which was done, laparoscopic ileocecal resection versus infliximab for terminal ileitis in Crohn's disease. So the LYRIC trial, what it showed, and I'm just giving you the summary of the 5-year follow-up on this. So originally in the LYRIC trial, 69 patients underwent surgery, 65 were on infliximab. Now, when you 5 years down the line, what happened? The patients who underwent primary surgery did not require a second surgery. 18 of them were on biologics. The others were on other medication, presumably aminosalicylates and immunomodulators. The ones who originally received only infliximab, nearly a half of them underwent surgical resection later. And the ones who did not undergo surgical resection continued to be on biologics, either the same biologic or they were changed to a different biologic. Another thing which is becoming common is this term treat to target. So what treat to target means, and this is not only for IBD, treat to target, say for instance in hypertension, anything, or diabetes. You define a treatment target. You can say, okay, I want this guy to be free of clinical symptoms. I want this guy to be endoscopically normal. I want this guy to be histologically normal. So you apply a tight control based on monthly visits or non-invasive monitoring and treatment adjustment to achieve this target. So that is what is treat to target. And so you can look for symptomatic response, which is here. Then you can look for normalization of CRP. You can look for reduction in calprotectin, endoscopic healing, and histological healing, which is final. Again, a lot depends on what you think is optimal. So when I was training as a gastroenterologist, the feeling was that Crohn's disease, you do not treat endoscopically. You treat the patient's symptoms. So if you treat the patient's symptoms, that was enough. It changed completely to this thing where you said that you need a deep remission, and that involves histological changes as well. But so we don't know what the necessity for this is in many patients. Thou shalt persist with treatment. So one of the things is that, again, people who do not treat IBD very often, they give up on a particular drug after a couple of months because they feel it is not making a difference to the patient. Or the patient goes to another doctor and says, this guy doesn't know what he's done to me, what medicine he's using, so he goes somewhere else. And very often this results in changes in medication. What things have shown us, and this is again reflected in the best of ACG that we listened to recently, they showed that, I mean, we know with azathioprine it takes up to 6 months to get a full response. With biologics, this has been repeatedly shown that you keep taking it for a longer time, you do much better. And the best of ACG, what they said was, this is also true for JAK inhibitors. So you just persist. Handhold the patient, tell them, you will be all right, just believe me, and take them through this. And lastly, thou shalt attend IBD CMEs. So we talk about microbe-directed therapies. What's new on the block is JAK inhibitors, S1P receptor modulators, which are soon coming to India, hopefully, which seem to make a huge difference. And in fact, what we heard was that maybe about 30 or 40% of patients in the US now are on small molecules. They are no longer on biologics. Combining biologics is another big trend. You don't give just one biologic, you want to hit them hard. You use biologics which work on 2 different targets. And of course, the buzzword, particularly among regulators, is you should use patient-related outcome measure. The patient tells you, I am happy, that is what you use for treatment. So with that, I'll stop. Thank you.
Thank you, sir, for the excellent presentation. Thank commandants and everybody. I request the audience, we can have some questions. We have some time.
Sir, in a situation where there is a fibrostenotic stricture, it's a fibrotic stricture, patient is absolutely asymptomatic on azathioprine. Do we need to resect at that point in time for fear of malignancy, or you think you'll resect when there is an obstruction?
Okay, that's a good question. So asymptomatic stricture, so firstly, to decide if it is predominantly fibrotic or predominantly inflammatory, we will use MR enterography. I'd look particularly at the T2 and the diffusion weighted images. If it's predominantly inflammatory, you're going to give treatment for that. If it's fibrotic,
yes,
the question is, should you wait? Again, to an extent, on MR, you can differentiate, you can suspect malignancy. The problem with, if it's a tight structure, unless they are very fastidious about their diet and avoid anything which can go and get stuck there, some of them do end up with perforation of the bowel. And when that happens, the possibility is that it actually probably was a malignant stricture. So so I cannot give you the answer to that. It's just that it varies from patient, because it's not a very common situation, but when it happens, it varies from patient to patient. And things like PET scan are not going to give you assistance here, because they don't really light up, a malignancy here doesn't really light up on a PET CT. So the answer is, it is based on the individual.
And regarding the lyric trial, how prudent is to do for terminal ileitis, laparoscopic resection, and what do you think will be the patient acceptance for a terminal ileitis?
Okay. So the patient acceptance, I would suspect, is not going to the patient to say you try medicines first. I mean, given the knowledge of our patients. But in the situation in Europe where they were, and I don't know how they were counseled, they went for that first. But having said that, I have to tell you that in CMC, for instance, our surgeons always used to tell us, you are sending your patient to us too late.
Thank you.
Maybe Dr. Jaswant or Dr. Kannan will have some comments on that. Or Dr. Ratnaswamy is here.
Rama, you said that when describing the abscess, the biologicals will avoid a surgery. But you said early resection in the next.
No, I didn't say, I said it might avoid. Increasingly what we are doing is, we are staying away from the resection part. You know that we have resected abscesses before. I remember the very first time that when we started in SIMS, and that girl that you operated upon, so most often you tide over the initial thing, drain, and then they resect. But it's changed now, because of late, I have not had anybody who's been resected. They all seem to do reasonably well with biology, because the patients say, even when you bring up the topic of surgery, they say, can we wait?
Some comments from you. One is this adenocarcinoma of the small gut in Crohn's. I mean, in all my years that we have been seeing small bowel Crohn's, I haven't yet seen one. So one is, what is your experience? Is it less common in India as compared to the West?
Adenocarcinoma ileum in Crohn's, 3%. That's the statistics. Jayanti will remember a patient that she referred, a professor of English who had a medical nephew or uncle, I don't remember what. For financial reasons, whenever I told her that she needed surgery, she wouldn't do that. One day, she just perforated and had to be taken off for surgery. It was adenocarcinoma. She died. And this is, so I've seen a few.
No, Rama, my question was, this 3% might be a Western figure.
3%?
3% a Western figure probably. What I mean is it uncommon in India? I mean, an occasional case you may see, but maybe it's not 3% in India.
It's probably not 3%, definitely.
Second is that when you resect the terminal ileum, in disease of the terminal ileum, although in Crohn's they say disease is restricted to the same place, it doesn't spread. Have you, in your experience after resection, seen a movement in other parts of the small gut, jejunum, etc.?
Certainly. After resection, we do keep them on treatment to ensure that the treatment does spread to the disease does manifest in other parts of the small intestine. But the thing is, so the other thing about the lyric trial is that we have to remember that Western ileal Crohn's disease is different from our Crohn's disease. We see mostly ileocolonic, I'm sure you'll agree. Ileum and colon together. Strictly ileal is unusual. Western ileal Crohn's disease is related to the NOD2 gene mutation and to tobacco, so smoking. So smokers with NOD2 gene abnormalities get ileal Crohn's disease. Maybe it's only restricted to that part.
Will an a resection of the small and large intestine be helpful in our case as compared to ileum alone?
That's a difficult question. I do not know the answer to that.
Go to the next topic. The time is over. I call Dr. Palnivel. This topic is GERD.
Good morning, everyone. I would like to thank the organizing committee for this invitation. So I'll be talking on what is new in GERD. I would like to base my talk on the recent guidelines that have come up in last 1 or 2 years. The clinical update, clinical guidelines and consensus paper from European and American neurogastroenterology and motility societies. So you all will know that Montreal consensus defines GERD as reflex of stomach contents into the esophagus, causing troublesome symptoms without complications. So GERD has typical symptoms and atypical symptoms. Typical symptoms would include heartburn or regurgitation or both. In patients who have classical GERD symptoms, empirical proton pump inhibitor once daily before a meal for 8 weeks is recommended. In patients who do not respond to this trial, diagnostic endoscopy is recommended after stopping PPAs for at least 2 to 4 weeks. In patients who have non-cardiac chest pain without typical heartburn or regurgitation, the recommendation is for objective reflex testing and not go for an empirical PPA therapy. Earlier, barium esophagogram was done for assessing esophageal clearance and also find anatomical factors, assess anatomical factors, anatomical defects. But esophagogram alone cannot be recommended as a diagnostic test for GERD. So when is endoscopy recommended as a first test in GERD? In patients who have typical symptoms of GERD with dysphagia or other alarm symptoms like upper GI bleed, iron deficiency anemia, loss of appetite, loss of weight, or presence of a GI cancer in a first degree relative. And in patients who have increased risk of Barrett's esophagus, endoscopy is recommended as a first test. If the endoscopy is normal, then reflex testing of PPA therapy is recommended for patients with suspected GERD. Whereas on endoscopy, if severe esophagitis in the form of Los C or D is seen, then reflex testing is recommended on PPA therapy. GERD is also associated with extraesophageal symptoms like cough, asthma, laryngitis, globus-like sensation, persistent sore throat. So in them, evaluation for non-GERD causes should be done before ascribing these symptoms to GERD. So in patients with isolated extraesophageal symptom, they need objective reflex testing. They have to be proven to have GERD before starting them on PPA therapy. So empirical PPA therapy, again, is not recommended for isolated extraesophageal symptoms. And guidelines recommend against diagnosis of laryngopharyngeal reflex based on laryngoscopy alone. Because it has been shown clearly in studies that even healthy volunteers can, laryngeal irritation is very common and laryngoscopic findings are very common in normal healthy volunteers. So only based on laryngoscopic findings, diagnosis of laryngopharyngeal reflex should not be made. So this table would tell us why empirical therapy is not justified. So if you look at patients with proven GERD, the number needed to treat be it a typical symptom or an extraesophageal atypical symptom, is small. Whereas in patients who have unproven GERD, who don't have objective evidence of GERD, if they have an isolated extraesophageal symptom, then the number needed to treat is so large that empirical PPI therapy is not recommended. Refractory GERD refers to persistent troublesome GERD symptoms despite an optimized PPI therapy. So in clinical practice, as high as 40% of patients who are started on proton pump inhibitors for GERD symptoms report inadequate relief. And refractory GERD significantly affects the quality of life, and it is one of the most common reasons for referral to a gastroenterologist. The type of clinical practice actually dictates the scenario of refractoriness of symptoms in GERD. In primary care or a general practice, patients who present with typical symptoms of GERD are started on empirical PPI therapy, and when they do not respond, when the symptoms do not respond to PPI therapy, they are said to have refractory reflex-like symptom. On the other hand, patients who have typical symptoms GERD, when upfront they undergo reflex testing and are proven to have GERD, and when started on PPI, if they do not respond, these category of patients are said to have refractory GERD symptoms. So then when can one call them, when can you call them to have true refractory GERD? When patients with refractory GERD symptoms undergo reflex testing and they are shown to have a pathological acid exposure, then these category of patients fall under true refractory GERD. It's very important to understand the differences. So the recommendations, optimization of PPI therapy is the first step in the management of refractory GERD. And in patients who have refractory GERD symptoms, who already have proven GERD at baseline, they need to undergo reflex testing on PPI therapy. Whereas in patients who don't have a baseline documented GERD, recommendation is for reflex testing of PPI therapy. And in patients who have refractory GERD symptoms, and if regurgitation is the predominant refractory symptom, then surgery is recommended for these patients. Optimization of PPI therapy is very important. We should ensure patients are taking the PPI medications at the optimal dose and an optimal time in relation to meals. PPIs work effectively when taken 30 to 60 minutes before meals. Standard dose PPI taken twice a day or at a higher dose has been shown in some patients with refractory GERD to reduce the gastric acid content better than once a day administration. And proton pump inhibitors have also been shown in studies to have pharmacological variation. Like a proton pump inhibitor like esomeprazole raises the intragastric pH to more than 4 for several hours when compared to other PPIs. Similarly, these proton pump inhibitors are susceptible to cytochrome P450 metabolism, the least susceptible being rabeprazole and pantoprazole. In patients with refractory GERD symptoms, an alternative or a potent acid suppressive agent can be considered. It's not yet available in India, potassium competitive acid blockers. They rapidly and more effectively reduce the acid content at once daily administration. So dietary and lifestyle modifications that are recommended are weight loss in overweight obesity patients. For nocturnal symptoms, avoiding eating meals within 2 to 3 hours, avoid tobacco products, smoking, trigger foods that can trigger the symptoms of GERD, elevation of head end of the bed, or preferring to sleep on the left side. Although these lifestyle modifications are prescribed, the level of evidence is low except for weight loss in patients with GERD. It's important to understand that proton pump inhibitors are excellent in healing of esophagitis. H2RAs are inferior when compared to proton pump inhibitors. Discontinuation of PPI or switching of PPI to the lowest effective dose or on-demand PPI is recommended in patients with GERD who do not have evidence of erosive esophagitis in endoscopy or Barrett's esophagus. However, PPIs need to be continued indefinitely, or surgery is indicated in patients who have severe erosive esophagitis. Adjunctive medications used in GERD, baclofen is a GABA receptor agonist. It reduces the number of transient lower esophageal sphincter relaxation. It is not recommended in patients without evidence of GERD. And this drug needs to be administered thrice a day, and it has got drawbacks of somnolence and drowsiness, hence it is usually not preferred. Again, prokinetics is not used in patients with GERD unless there is a coexistent or underlying gastroparesis. Sucralfate is generally not recommended for GERD except during pregnancy. Surgery for GERD. Surgery is advised in the long-term management of patients with proven GERD. Magnetic sphincter augmentation can be considered as an alternative to lap fundoplication. Again, the level of evidence, moderate quality of evidence is available, and there is a strong recommendation. In patients who are obese and who have GERD, where there is an indication for surgery, Roux-en-Y gastric bypass needs to be done. Lap fundoplication, there is recurrence of GERD symptoms in patients who are obese. And it's also important to understand that if sleeve gastrectomy is done in these patients, there can be worsening of GERD. Transoral incisionless fundoplication can be considered in patients who do not want surgery. Another question that frequently pops up in clinical practice is concern on long-term PPA use. So patients may not take PPA. So physicians treating patients should address to the patients that it's the most effective medical treatment available for GERD. Although some observational studies have identified an association, high-quality studies do not show the increased risk except for increase in intestinal infections. So I'd like to summarize that the few changes that have happened when compared to earlier guidelines, emphasis on stopping PPA for 2 to 4 weeks before diagnostic endoscopy, this to increase or maximize the yield of diagnosis of GERD and to evaluate erosive esophagitis. And surgery is recommended for patients with severe reflux esophagitis as a long-term management. Especially surgery works well in patients who have regurgitation. That's right. Thank you.
Palani, you stressed again and again that we should stop PPA for 4 or 5 weeks before doing a diagnostic endoscopy. But if the patient is a non-responder and we essentially rule out other disorders, why do we need to stop for 4 weeks? Are we not losing an important period in an effort to rule out malignancy and other serious illnesses?
So if there is an alarm at the baseline, we will be subjecting them to endoscopy. The rationale for stopping PPA is at least 2 to 4 weeks is to increase the yield of GERD, and we all know that PPA causes healing of esophagitis. So in patients who have baseline esophagitis grade C or grade D, if after PPA we do an endoscopy, we may miss the erosive esophagitis. That's the rationale for advising 2 to 4 weeks stoppage of.
I'm Angatraman from Chennai. See, the last slide you said the PPA and the long-term efficacy. I am totally contradicting that because the recent guidelines which is released 3 months ago in the month of December, which categorically says PPA cannot be given more than 3 years. All the adverse effects has been listed. The international guidelines has changed. Government of India has formulated that it cannot be used for more than 3 years. Guidelines of India is also released. I think the last slide has to be updated.
Thank you. Thank you, Dr. Pioneer Mohan. Next lecture is on manometry by Dr. Trichy from Apollo Hospital. Manometry nowadays is widely available. Majority of the government hospital setups have manometry. It is not only useful for diagnosis but also for some therapeutic purposes. Over to Dr. Trichy.
Thank you, sir. Thank you to the Tamil Nadu chapter for giving me this opportunity. This is a topic that is dear to my heart. So, my topic is esophageal manometry, an update. Yeah. Just before we go to the latest updates, a small history of esophageal manometry. We know that this has been around for more than 4 decades, but it's been refined very well with the Klaus plot since 2000. after which it has steadily made strides to reach where it is today. And with each upgrade and new modifications, we strive to achieve a more uniform diagnosis, strive not to make overdiagnosis, and strive to treat patients better. So this is the original ancient 2D manometry that we did have at our hospital when I started training. Of course, now all this has changed to this lovely and easily comprehensible color plot, which is the high-resolution manometry. For the benefit of postgraduates, this is a physiological peristaltic swallows. And you can see that this is what happens in sequence in a normal swallow. The upper band representing the relaxation of the upper esophageal sphincter, followed by the esophageal body peristalsis, and relaxation synchronous to the swallow of the lower esophageal sphincter, and the after contraction or the return to original pressures of the lower esophageal sphincter. Now these metrics, which are there since the inception of the Chicago classification, are constant. Distal latency, the DCI, IRP, these are all constant even today with just interpretational variations. This is a busy slide just to show you how the Chicago classification is almost synonymous with esophageal manometry. With the advent of the Chicago classification early in the 2000s and its modifications to as recent as 2021, we can see that the guidelines and recommendations have been modified to achieve much more detailed and clear diagnosis with the intent of removing or expelling false positive. Now this is something that postgraduates should be aware of. The Chicago version 3, which has been used till up to 2021. This was formulated in 2015. And here if you see what are the main features of the Chicago 3 classification, it mainly had 4 subcomponents. That is disorders associated with the EJG outflow obstruction, major disorders of peristalsis, and of course minor motor disorders of peristalsis, the integral part here being the IRP, which decided whether the EJG was involved or not in the motor abnormality of the esophagus. And when the IRP remained normal, of course, the other diagnosis. I will not go into detail on this because we're all aware of this Chicago 3 classification. These are all some of the diagnosis that we arrive on with high resolution manometry, and these can be interpreted in light with Chicago 3 as well as the modified Chicago 4. A normal peristalsis, a type 2 achalasia, a hypercontractile or a jackhammer esophagus, and 4, an ineffective esophageal motility. So what is new in Chicago 4? What makes it different from Chicago 3? If you see, let's revisit the parameters that are constant in both Chicago 3 and Chicago 4. But with variations in interpretation. The IRP constant in usefulness for diagnosis, but we know that we have to look at IRP both in supine as well as upright position, because as a rule most centers yet perform manometry in the supine positions. Very few centers perform primarily upright manometry. So as of now, even as per Chicago 4, most metrics are calculated based on a supine manometry, not upright manometry. So if you see, there are variations of the IRP, and there's a fall of the IRP, this is physiological, in the upright position as compared to the supine position. Why this is important is now this has become a diagnostic criteria, especially in the diagnosis or non-diagnosis of hitherto conditions like the esophageal gastric outflow obstruction. False positives are eliminated using these changes in IRP. The DCI, of course, which is an evidence of the magnitude of the contraction, whether it is ineffective, normal, or excessive, remains the same. Thresholds remain the same, 4.5 seconds for the distal latency and 450 to 8,000 for a normal DCI. So the previous hypertensive contractions, 5,000 to 8,000, have been eliminated as they have been found with almost same frequency in normal populations as well. So only over 8,000 is pathological for a hypercontractile esophagus and less than 450 in the appropriate conditions for ineffective esophageal motility. These are the characteristics or the diagnostic criteria for panesophageal pressurization. Now these are what are new and marks Chicago 4 as different from Chicago 3. The utility of multiple rapid swallows and a rapid drink challenge. So what do we elicit on a multiple rapid swallow and what is its intention? Mainly when you give rapid swallows in a gap of 2 to 5 seconds, you effectively abolish the esophageal body contractility. This should ideally be followed by a normal peristaltic wave, which is equal to a physiological peristaltic wave with DCI more than 450. This implies whether there is a peristaltic reserve that is preserved or not preserved. So an impaired deglutitive reserve bodes not very well for the patient, and this helps to unmask esophageal dysmotalities. Rapid drink challenge is also similar to the multiple rapid swallows, and here it is important because in the rapid drink challenge, if the IRP remains more than 12 millimeters of mercury, and if there is a pan-esophageal pressurization of more than 20 in spite of this, then a patient can be diagnosed with an EJG outflow obstruction rather than just an elevated IRP in supine position. So there were a lot of unnecessary poems or balloon dilatations for patients with an EJG outflow if you use IRP as a sole criteria. So for benefit of postgraduates, these two maneuvers have been found to be useful to remove the false EJG outflow obstructions or even false achalasias or achalasia variants. If there is still a doubt of esophageal dysmotility in patients who seem to have normal peristalsis on liquid swallows, then solid swallows, the Western guidelines say custard, we say curd. So we can use curd, custard, anything of a semi-solid consistency. And this in both supine as well as upright positions. If they are bringing about IRPs of change, then we know that there is a possibility of an outflow obstruction. Response to drugs not used commonly. The ones that have been mentioned are amyl nitrate and cholecystokylin analogs. So please look at this flow chart, very well summarized, Chicago 4. So if you see here, there is no large peristaltic break, small peristaltic breaks, there are no minor disorders of peristalsis. Either there is abnormal peristalsis involving the EJG, which is achalasia primarily, or EJG outflow obstruction, or other disorders of peristalsis which have been grouped into a single group. Either there is no contraction, or there is hypercontraction in the form of a DES or a hypercontractile esophagus. Ineffective esophageal motility again has to be kept in mind, keeping patient symptoms for both hypercontractile as well as ineffective motility. If there is no symptoms in the form of dysphagia, chest pain, heartburn, and just associated findings which are not reproduced in both positions, this diagnosis cannot be entertained. As always, these are outliers, and to eliminate these outliers is what Chicago 4 has been attempting. So in cases where even manometry fails to give you a diagnosis, additional testings like TBEs and FLIP has been found to be very useful to confirm or refute the diagnosis. So this is in summary, ladies and gentlemen. Chicago 4 helps to make more uniform diagnosis of outflow tract obstructions or disorders of peristalsis, either ineffective or hypercontractile motility disorders. These are the additional maneuvers used. And please remember, there are criteria required for final diagnosis of unsure conditions such as EJG outflow and ineffective motility. And again, revisiting the slide, you see how we progressed from 2002 to 2023 with better diagnostic criteria and better diagnosis for the patient. These are my references. Thank you.
Thank you, Dr. Trichy, for this presentation. One question from postgraduates, please. Dr. Shafiq, punctual GI disorders, please.
Good morning. Good morning, everyone. I'm Dr. Shafiq from Tirunelveli Medical College. Greetings from Tirunelveli. My topic is assigned this functional upper GI disorder, the current update, the past 2 to 3 years. What's new in FGID? Even the definition itself has been redefined. Now it's not a FGID no longer. It's called as DGBI, that is disorder of gut-brain interaction. Basically, this FGID is comprising of mainly 6 GI symptoms: abdominal pain, dysphagia, dyspepsia, diarrhea, constipation, and bloating. So you know about the Rome Foundation award from 1994 to 2016, and we're expecting Rome 5 2026. So what's Rome 4 criteria, which is the latest, how it differs from the previous one? Mainly it is now is multicultural. Before it was mainly focused on Western system. Now the Rome 4 criteria, which involves about 27 countries from 126 experts, they have joined and framed this Rome 4 criteria. So different groups, different religion, different race, the food we eat and what we practice, many taboos, different countries. So all being focused on this. So this Rome 4 is mainly based on the symptoms, that is classification based on symptom groupings, not the syndromes. So it relates to patient's interpretation and reporting of real-time experience. So what the patient feels, which is abnormal. So that is the main thing. So this has revolutionized in the Rome 4 in forming new chapters. The new chapters, for example, there are reflex hypersensitivity syndromes, cannabinoid hypersensitivity syndromes, so many new chapters, and there are also overlap. You can see there are functional heartburn, functional dyspepsia. This also overlaps with IBSD, IBS diarrhea. And another most important is the symptoms should be minimal frequency occurrence should be there. It is so-called bothersome. What is bothersome? Bothersome is nothing but the symptoms should interfere with these daily routine activities. So it's, as I said earlier, it is a disorder of GI symptoms relating to any of these disturbance, like motility disturbance can be there. There may be disturbance in visceral hypersensitivity, gut dysbiosis, or in duodenal or mucosal immune functioning, or in central mediated response, CNS processing. So any of these defects can produce FGID. So FGID is classified into 5: esophageal, gastroduodenal, bowel, centrally mediated gallbladder, anorectal. I am focusing mainly on the functional upper GI, that is esophageal and gastroduodenal. So this is again classified into esophageal, chest pain, heartburn, dysphagia, and globus. And gastroduodenal, the main thing is functional dyspepsia, which is an umbrella term, which is again classified into EPS and PDS, that is epigastric pain syndrome and postprandial distress syndrome. Apart from this, they have combined both nausea and vomiting as a chronic nausea and vomiting syndrome and cyclical vomiting syndrome, etc. So this is an umbrella term which comprises of the 4 important symptoms. That is the diagnostic criteria: bothersome postprandial fullness, early citation. These 2 comes under PDS, and bothersome epigastric pain with epigastric burning comes under the EPS. So this is the criteria for EPS. You can see the epigastric pain and burning along with supporting criteria like pain induced by ingestion of meal. But if vomiting is present, then you should consider some other disorder. Similarly, for postprandial distress syndrome, bothersome postprandial fullness and early citation, along with postprandial epigastric pain can be there, burning can be there, bloating can be there, but vomiting is there, it should be considered as a different disorder. So the prevalence as such, all these studies, FGID been done only recently. For the past 3 years only, this FGID been given more importance. So the prevalence studies been done, worldwide prevalence done in 2020, which shows about 73,076 adults have been surveyed, both internet and household, females outborn male. In this you can see the number of FGID was comparatively very low in India. Indian studies are very low. And you can see among this esophageal and gastroduodenal disorders, functional dysphagia and dyspepsia are more prevalent and overlap around 12%. And number of citations, articles, everything, when you see from 2002 to 2022, you can see there is a progressive increasing number of citations, reviews, articles. Slowly the more number of studies been taken place in the past 2 to 3 years. Pathophysiology, this is not like any other disease. It has a multiple perplexing pathological mechanisms like gastric sensitive dysfunction, alteration in gut-brain neurosignaling, duodenal low-grade inflammation, and duodenal mucosal barrier dysfunction. I tried to concentrate on two important studies regarding the pathophysiology. One is the impact of duodenal mucosal vulnerability in development of mainly EPS, not PDS, EPS. What it says is when the duodenal mucosa is exposed to more acid environment like pH 3 and pH 5, there is more of low-grade inflammation, especially in patients with EPS. So that is the cause for the epigastric pain. So when you see the trans-epithelial electrical resistance, which is measured when the patient's duodenal mucosa is exposed to lower acid, the patients with EPS will have a lower resistance when compared to controls and PDS. Another study is the bile reflex gastropathy is one of the most important cause for functional dyspepsia. These studies, they have ruled out the common causes like pyloroplasty, history of any Billroth constructional procedures. They have included only the normal patients when they compared the three groups. One is bile gastropathy, non-bile gastropathy, and no gastropathy. The more of bile reflex gastropathy is associated with FD. Because what they say is there is more number of gastric luminal irritants which causes reflux of all these alkaline juices, pancreatic juices into the stomach, which causes chemical gastropathy. And this is aggravated by patients who have already done cholecystectomy. Cholecystectomy patients, what happens is the patients will have inadvertent release of contents into the duodenum. They will impairing the duodenal motility, so that there will be a leakage of these duodenal contents into the stomach, so causing more of an injury. Coming to the management, there are one important trial is the Mantra trial. What they have proved is, compared to gastroenterologist alone treating the patient, when you do combine people like physicians, dietitians, and hypnotherapists, you can have a very good result. So this multidisciplinary care appears to be very superior, especially in case of improving the symptoms and quality of care. And the treatment-wise, there are two more studies with PPI. The PPI, as we all know, that the role mainly is due to acid suppressing effect, but it's not. It is because of its anti-inflammatory effect, which has important role. It reduces the duodenal eosinophilia and reduces the permeability in patients with FD. And but PPA, or the difference between PPA is more of very useful in the EPS patients rather than the PDS patients. Whereas this acosamide, the study, what they say is the acosamide 100 mg TDS for 4 weeks, it improves patients with FDS, PDS patients than the EPS patients. So, but there is limitation in this acosamide study, because when the patients are having hyperacidity, then the acosamide may not work properly. Similarly, there are a lot of studies with probiotics and add-on therapy with clinidium chlorodiazepam. So these all antipsychotic drugs are all only as an add-on therapy, but not as a main drug. So it also improves the symptoms, quality of life, and also symptoms. And other drugs like herbal medicines, acupuncture, etc. I come to the most important perspective in case of GID is the understanding the biosocial model. That is the most important thing, because these patients exposed to yearly life stressors or genetic factors will have an effect on the gut. So the gut reacts to the environmental and yearly stressors. Same time, it is also have a bidirectional effect on the brain. So they will have changes in the pathological and psychological and CNS changes, which also have an effect on the outcome on the quality of life. So when you have patients with mild symptoms,
can you conclude?
Yes, sir. So mild symptoms we can manage it with drugs like neuromodulators, but other drugs like cognitive behavioral therapy. Recently we have virtual reality therapy also has come. It has been discussed in ACG 2 weeks back, and also yoga, so many things. To conclude the session, this British Society of Gastroenterology guidelines says first to treat with patients with FD, we rule out H. pylori, then treat with acid suppression, then you go for prokinetics, then the last is the gut neuromodulators and all those hypnotherapy, etc. The only difference in the Japanese classification is they have included the herbal medicine along with the first line therapy, second line therapy. Thank you very much.
we are behind schedule, we'll go to the next topic, early gastric neoplastic lesions, how to pick, by Dr. Ashutosh Mohapatra.
At the outset, I would like to thank Tamil Nadu TNISGCON chapter, Dr. Rabi and Dr. Opal for inviting me. Without wasting time, let's start. It's for the PGs only. I will focus on 6 key words. And at the end of the slide, there are 2 slides which will be exciting quiz and prizes are there. So remember 6 key words before I start this session. One is color, that is reddish or whitish. Second is surface, that is elevated, flat or depressed. Third is demarcation line. Fourth is gastric atrophy, intestinal mucosa, intestinal metaplasia, spontaneous bleeding, and last but not the least, RAC. I repeat, color, reddish or whitish. Second, surface, flat, elevated or depressed. Demarcation line, gastric atrophy, intestinal metaplasia, spontaneous bleeding. Then you say, last, RAC. That is regularly arranged collecting venules. Okay, let's start. So look at these images. Some images are very familiar, some images are not so familiar. Okay, left top corner is gastric atrophy and right one is xanthomas. Others are not familiar to me, only 2 years back. Last 2 years, I am familiar with these images. So case 1, 60-year-old male with complaints of dysphagia. At least from the history you can tell this is nothing related with early gastric cancer. Are you sure? So this is nothing related in a patient of 60-year-old presenting with dysphagia that has nothing to do with at least early gastric cancer. Okay. So how I examine the stomach? I examine the stomach thoroughly. I take at least 7 minutes to all my patients who are more than 40-year-old and who have pre-malignant lesions of the stomach, who have high risk factors for stomach. Second, I always give that gastrica liquid that is called simethicone and NAC dispersible tablet we used to give previously. Now we are giving Endoview to all of our patients. And we follow systematically SSS protocol of Kansi-Yao. And always use a soft black hood. So this is the SSS protocol. I'm not wasting time. If your professor asks you next time, where is the ulcer? Don't say antral ulcer. Say it is in the anterior wall of the antrum or posterior wall of the antrum or lesser curvature of the antrum or greater curvature of the antrum. That should be. And incisura is a place where you are going to miss the posterior wall of the incisura while doing. Next time you go to your endoscopy room, please move your hand little right so that you will not miss the posterior side of the incisura. I'll show in all my videos. There are 7 videos. I'll show you. So coming to RAC, this is regularly arrangement of collecting venules. What is RAC? If you find these dot-like structures, don't tell it is erosion. These are RAC. If it is present in the distal stomach, then with 95% accuracy, you can tell that this is H. pylori uninfected. What is H. pylori uninfected? That means if you search in this group of patients for well-differentiated carcinoma, even advanced gastric carcinoma, you are unlikely to get. You are a fool if you waste time in this group of patients. So if RAC is present, do not waste your time in endoscopy looking for an advanced gastric carcinoma even. So I do not check for WhatsApp status of my patient. I always check for H. pylori status. How you are going to check for H. pylori status? Are you going to take urea breath test, biopsy, serology? No, no, no. So then how? When you put your endoscope, think 2 things. Is it H. pylori infected or H. pylori uninfected? What are those features? Features I told already: gastric atrophy, intestinal metaplasia, nodular gastritis, xanthoma, hyperplastic polyp. These are the features of H. pylori infected stomach. And H. pylori uninfected is fundic gland polyp, hematinin attachment, red streaks. Can you please run the video? Coming to our first case. So this is a advanced esophageal malignancy. There is no doubt about it. Now you see gastric atrophy, absence of RSC. Look for the lesion. This is, don't get fooled by benign erosion. This is a benign erosion. So look for any color that is reddish or whitish. Always look for color change and surface. Color, surface, color, surface. That you are going to diagnose early gastric cancer next month for sure. Look for, so this is a abnormally reddish mucosa compared to your background mucosa. Look for always for the background mucosa. So this is reddish mucosa, flat lesion. On NBI, we are using always in our clinical practice 290 series Olympus scope, 290 series endocytoscope, 290 series zoom scope. So here you can see another lesion in the same patient. So synchronous lesion, surface is depressed, and we do water immersion to magnify the image. You can see clearly there is a demarcation line with irregular vascular pattern in this image. So this patient is having 3 malignancies, 3. 2 in the stomach, 1 in the esophagus. Next. So I am not in a histopathologist, so it came out to be early gastric cancer. Can I have water? So what are the pre-malignant conditions of the stomach? One is gastric atrophy. I'll finish before time. Gastric atrophy. If you see gastric atrophy in a patient, do not waste your time. Please look at the atrophic mucosa. Suppose atrophy is present in the proximal body, search for gastric adenocarcinoma in the atrophic area only. Do not search in the antrum, because that gastric cancer always develops in the background of atrophy, intestinal metaplasia, dysplasia. Gastric cancer never ever develops in the normal mucosa. So this is intestinal metaplasia. So these are pre-malignant lesions. This is called light blue crest sign. This is discovered by Dr. Noria. I spent at least 2 months in Japan for advanced imaging. He was there with me. This is xanthoma. These are the risk factors. Risk factors. If you next time you find a xanthoma in your endoscopy, do not say endoscopy is normal except xanthoma. Don't write this report. This is not acceptable report. Write if atrophy is present, if RSC is present, if intestinal metaplasia is present. Do not send biopsy. Very few people are very fond of sending biopsy. We never send biopsy nowadays if I see atrophy and intestinal metaplasia. So what is this? This is, as name suggests, this is called white opaque substance. This is not so familiar to me before 2 years. So if you find white opaque substance, think that something is harboring nearby. Always look for well-differentiated adenocarcinoma patient if you find white opaque substance. In last 2 years, we searched, we spend at least 20 to 25 minutes, sometimes 40 minutes in our patient for upper GI endoscopy. I found out this one. This is called white globe appearance. This is a novel marker for, again, for early gastric cancer. So what are the salient points for endoscopic detection of early gastric cancer? There is no rocket science. Remember again those features. One is spontaneous bleeding, color change, and surface, tortuous fold. RSC you will tell last. And pale mucosa. Any pale mucosa. Don't say in anemia there is pale mucosa. That will be generalized pale mucosa. Always look at the background mucosa. You see color change, slight surface change, spontaneous bleeding, thickened or irregular fold, and disappearance of vascular network. Please pay attention to these 6 findings. Next month you are going to diagnose early gastric cancer. So recommended steps for early gastric cancer: when you enter your endoscope into the stomach, divide into 2 groups, H. pylori infected or H. pylori uninfected. If H. pylori uninfected, always look for a pale area, because undifferentiated cancer is common in H. pylori uninfected stomach. And if it is H. pylori infected, look for a lesion, look for the surface pattern. This is called VS classification, very famous classification. Look for the vessel irregularity and demarcation line. If demarcation line is present, if any one of these features is present, this is cancer with 95% accuracy. So this is the famous VS classification. You can see the demarcation line. These white line, these yellow lines correspond to the demarcation line. After 15 days of training, you will be an expert of early gastric cancer diagnosis. This is our real life scenario. Scope used is 290 endocytoscope. You can see a small type 2C lesion on NBI. That is a well demarcated line, and it came out to be a early gastric cancer. So this is our study. Institutes involved, 3 or 4 institutes were involved. I did it in my clinic. So is it common to find early gastric cancer in India? Answer is yes, yes, yes. It is more common in India. It is more common than Japan and South Korea, believe me. In eastern part of India, I cannot tell about south part, but in eastern part of India, it is more common than Japanese. So this is our study. Look at this video. Run the video, please. Little fast. Okay, you can see, this is the lesion. Can you forward it little bit? Forward. Another, little more, little more, little more, little more. Okay, this one. So you can see spontaneous bleeding. Bleeding, even a single point of bleeding, early gastric cancer. Next video, I'll show you. Run it. This is CLD. Don't say esophageal varices grade 2, no other abnormalities noted. You see, this is a patient of chronic liver disease having early gastric cancer again. Forward, please forward it. Madam, forward it. So this is radius. On NBI, there is a demarcation line. We collected in 2.5 years, more than 20 early gastric cancer. And all our ESD were done at AIJ Hyderabad, because at that time, I didn't know how to do ESD. This is 2021 study, I think. So spontaneous bleeding. So this is a diffuse early gastric cancer, undifferentiated cancer. You see, before I put the endoscope, the stomach is bleeding. Don't say it is erosion. Okay. So this is undifferentiated cancer, cursed through vessels, pathognomonic of early gastric cancer. Last slide, I think time is running out. If you answer this question, you will be given a to and fro ticket to Odisha by aeroplane. No, I'm not joking. I'm serious about it. So, this is a pale mucosa. Tell me what is the diagnosis. Let me run the video for 1 second. This is a pale mucosa. You can see, this is called what? Pale mucosa. Because background mucosa is reddish. Only small white pale mucosa about 5 to 8 millimeter in size. Tell me, now the diagnosis, tell me. Do not Google. Do not Google. If you Google it, you can got it. No. No. So diagnosis is tree-like appearance. This is maltoma. So pale mucosa has 3 diagnoses, no 4 diagnoses. One is undifferentiated cancer, maltoma, and adenoma. So we did all eye scanning, take-home points, check for H. pylori status, do not check for patient's WhatsApp status, infected or uninfected. RSC, look for gastric atrophy. If gastric atrophy is present, look for well-differentiated adenocarcinoma there only. Do not look for areas without atrophy. When you find one cancer, do not say CA stomach. Please do not write CA stomach. Please search other parts, because if you do distal gastrectomy, after 2 years, 3 years, another guy will find an early gastric cancer in the proximal stomach. So I think I've told everything about early gastric cancer. Thank you so much.
Thank you, Dr. Ashutosh, for the interesting slides and the videos. And now, today we have learned we should spend more time in the stomach and should not miss the subtle findings, so that we don't miss early gastric cancer.
Do you do biopsy before doing subjecting patient for ESD, and when do you do it?
We do, when we suspect a lesion, we have to take a biopsy. Without biopsy, we cannot do. Sometimes biopsy will come at low-grade dysplasia or high-grade dysplasia, but if it is focal low-grade dysplasia, you can go for ESD also, because it has been shown that even if you do ESD in low-grade dysplasia, there will be upstaging in 25% cases. But if a lesion is found, you have to take biopsy. Even with the best of the endoscope, best of the pathologist, best of the imaging person from the Japan, they cannot predict with 100% accuracy that this is an early neoplastic lesion or non-neoplastic lesions. Because I used to chat with them almost every day for 365 days. I used to send all my images through WhatsApp, and we transfer every day. In 95% cases, they are accurate. In some 5% cases, they will also tell, we are not sure, this may be neoplastic, might be non-neoplastic. You have to take biopsy. But we do not take biopsy in intestinal metaplasia nowadays, or for that matter in atrophy.
Once again, I thank all the speakers in the gastro upgrade session.
Thank you.
And next, we'll have a tea break for 10 minutes. I think there's a change in the program.
As we are running short of time, we will be continuing with the session. People who would like to refresh can go get their tea and come back into this room. And we'll be going on the session, and participants participating in the best endoscopy videos, kindly submit your videos in the preview room. And the hands-on workshop stations are ready. Please approach the representative stations for utilizing the facilities. And we'll be moving on with the next session. The next session would be Gastro Upskill Session 1. The chairpersons of the session will be Dr. O.L. Naganathan Babu, Dr. V. Hema Vijayalakshmi, and Dr. E. Kandasamy Kumar, and Dr. C. Krishnan, and Dr. S. Kavita. I request all the chairpersons to take the seats on the dais.
Good morning. Now we'll move on to the next session, the gastro upskill session. First talk will be delivered by Dr. B. Mahadevan on my travel into third space.
Very good morning. Thank you, chairpersons and dear friends. It's my great privilege and honor to be here and deliver this talk. Thanks the organizer for giving me this opportunity. So I have 15 minutes to discuss what is my travel into the third space endoscopy. We all know that third space endoscopy or a submucosal endoscopy, I would say it's a revolution in the field of modern interventional endoscopy. In fact, it allows the physician to enter into the surgical field. In fact, I would say there is an interface between the surgeon and the physician. You know that third space is not a space, it's a potential space between the mucosa and the muscular layers of the GI tract. What we are doing is basically we are expanding the space with the saline colored with methylene blue or indigo carmine, and we make an incision into this space and expand the space and we work on it. The basic principle in POEM or any submucosal endoscopy, we work very closer to the muscular layer so that we want to preserve the mucosa. But in ESD, we just work just above that, we want to preserve the muscular layer. So in submucosal endoscopy is the most rate limiting step in submucosal endoscopy, because when this is the one which decides about your time factors and we don't want any injury to the mucosal layers. When you look at that, this is the vascular network of mucosa and the submucosa. If you work more superficially, you come across a lot of vessels and you take long time to dissect and waste your time. So the advice is to go deeper, more deeper. You'll get large vessels, but you can minimize your time and your submucosal endoscopy is more effective. My humble beginning of endoscopy was started way back in 2006. Probably everybody knows this from Madras Medical College. Thanks to my teachers for teaching the fundamentals of endoscopy. Then we come across many mentors. In 2014, my POEM encounter in animal model program, which was organized by RB in 2014. Many of the senior faculties were attended. And later I joined in Global Hospital. My mentor, Dr. Ravi, and he gave me the platform for the third space endoscopy. And later, I just moved to Shanghai for a short period of time. Professor Zhou is a man of RB water jet, and he can close any defect with resolution clips. And next is a Hu Bing. I had a short visit to Chengdu also. He is man with dual knife. He can do any procedure with the dual knife itself. In Eastern Asia, most of this third space endoscopy program started with ESD, then followed by third space endoscopy. But in India, the other way around. We started with the POEM. We were very comfortable doing POEM procedure. Then we move on to the ESD procedure. So in this presentation, I'm not going to talk about the theoretical aspects. I'll just show some videos which I've commonly encountered. Some of you might have seen my videos earlier. So POEM was not possible without these two gentlemen. And the POEM was expanded to many other fields like Zenger's diverticulum, STIR for subepithelial tumors, and G-POEM for gastroparesis, and PREM for Espung disease. There are 4 fundamental steps for POEM procedures. One is a mucosal incision. What you need to do, you have to create a blob with the methylene blue colored saline mixed with the methylene blue. So generally after methylene blue, I prefer to use a dual knife. So this is the most favorite one. So what you need to do, you have to make a very superficial incision, then you have to start dissecting with the coagulation current. There won't be any bleed. Sometimes you get stuck up with only incision with a lot of bleed. So once you deepen the incision, then easily you can enter into the submucosal space. So this is how you can do it. You can do it in other instruments also, like hybrid knife. So I'm not going into the detail. So this is one case which taught me all wrong things which I did in the early part of my career. So this is mainly because of the instrumental failure actually. So we started using a new instrument, it was failing. Then we started using this old hybrid knife. So the whole thing was messed up. I could not able to complete this POEM. So we just started with the anterior POEM, just we completed. Most important thing is you should assess the esophagus prior to the POEM procedure. Sometime without noticing it, on the day we just noticed that a lot of mucosal erosion, so fluid was not staying. Finally we got to find a place, then we could complete the POEM. Rarely, sometimes you come across esophageal candidiasis. This particular patient, we just decided to do POEM, and the day patient came directly, we intubated. This candidiasis was there, actually we could not able to proceed. Tunneling, I need not to go in detail. So most important identification of OG junction, you know that all about this technical part. Spindle vessels, aberrant fibers, and perforators, and double scope technique, all these things will confirm it. The other important thing which has not been mentioned anywhere, but what I feel like whenever you have created a tunnel, and when you go and inflate, there is a spastic segment. Beyond that, if you have enough 2 to 3 centimeter gastric spacious gastric submucosal tunnel, then that is more than sufficient. But there are no literature for that, and provided if your tunnel is in a straight scope. And myotomy should be very important. You should take a circular myotomy, and this is one such case actually, like incomplete myotomy, the same case. And after that, again, OG junction was not opening. You need not to get panic, you have to go back and dissect, then your procedure will be completed. So before closure, you need to secure your hemostasis, make sure your OG junction is open, then finally you have to clips. The most important thing is adverse events. We are worried, most of them are insufflation related. So one of the most important thing is the extra low flow tube you should have. This particular patient had bradycardia hypotension. We noticed that because technician not changed the extra low flow tube. This one is patient developed extensive subcutaneous emphysema because someone has pressed the air. This patient had subcutaneous emphysema almost there for almost close to 1 month. You can see this X-ray film where you can see the stomach. Air was there in and around the stomach. You can come across bleed. You don't need to get panic. You can always coagulate. And sometimes cap will get dislodged also. So the next case is a 73-year-old female. She had a progressive dysphagia and a regurgitation. And this was an endoscopic image. So you can see a large diverticulum that she had symptomatic, almost close to 6 to 7 months. And this was the gastrographian study. You can see the pouch. So this is again done in a very same way in a like classical POEM. What you need to do, you have to inject methylene blue just over the septum. And what you need to do, you have to dissect on either side. You make an incision over the septum and start dissecting. And this is a dissection which is going on along the esophageal side. So if you initial dissection may be a little difficult, but then you can carefully dissect on either side. So now the dissection is completed. So while inspecting, this is the septum, what you are seeing here. And this is on the diverticulum side, you can see the mediastinal structures. This is on the esophageal side. Then finally, you need to cut the muscles, the cricopharyngeal bar with a triangular tip knife. So you need to carefully dissect, not to injure the esophageal side of the mucosa. Most important thing is success of this Z-poem is you can go deep up to the bottom of the diverticulum and even up to the part of the esophagus, so that the chance of recurrence or failure is very less. This is not possible with this ENT surgeon which was doing with a rigid thoracoscopy, a rigid esophagoscopy. So after cutting the septum, you need to secure the hemostasis if any bleed is there. Then once everything is confirmed, this is a mucosal defect. You need to apply these clips carefully and to avoid any mediastinitis. If multiple clips have been placed to just close the mucosal defect. Finally, you need to inspect on either side of the mucosal closures. Initially on the esophageal side, everything is perfect. When you come back, this is on the diverticulum side. So this is post procedure. So before and after, you can see the response when after gastrografin. You can see the clips, multiple clips were there. So everything is possible only with the teamwork. So we have our anesthetist. It's not possible without our colleagues and postgraduates, and not but the least our endoscopy staffs. So without them, it's not possible. You need to have a good team to pursue your third space endoscopy. If you have your right skills, right attitude, and right bit of clinical knowledge, then you can be able to succeed in your third space endoscopy. Thank you for your kind attention.
Thank you very much, Dr. Mahadevan. Extremely delighted to travel into the third space. That is remarkably very rapid, and you have given a great comfort and assurance that even if you do a perforation during our routine endoscopy, we can say we have done. I tried some third space, so that later on you can convert. I find some obstruction in the cricopharynx or in the OG junction. I tried a third space. Such is the confidence you have given, and it was a wonderful thing for the new budding gastroenterologists like us that we can try our third space. Very remarkable. Congratulations to Dr. Mahadevan.
Thank you, sir.
Mahadevan, I'm glad, I'm very happy also that you have done so much. Two things. One, I've seen a lot of videos in Sankar's poem, ENT surgeons can really go deep. Some of them have gone far into it. But only thing is, this common in old people where they have a cervical spondylosis where they cannot extend the neck. In those people, they cannot. Otherwise, they can really go very deep. And if you watch some of the videos in YouTube, you will know. The other thing I want to say is that in submucosal dissection, you said you need to stay close to the mucosa. So in fact, submucosal dissection, we do it for early cancer. If you leave too much of submucosa to the muscle side, don't you think you will leave some of the small tumor cells into the submucosa?
No, sir. Actually, in my earlier slide, I mentioned that in poem, we work very close to the muscle. We don't bother about injuring the muscle also, even minor injuries. In ESD, we have to balance between the muscular layer. We have to go in the middle of your submucosal space. We have to have some amount of submucosal tissue.
But we should be careful not to injure the muscle, but then the submucosa has to come out. That is, only if you get the whole submucosa, the pathologist will be able to tell how deep the tumor has infiltrated.
Actually, it is a potential space, but when we inject that much, so we can get enough space, sir. But we have to balance.
Yeah, I'm glad for you. I'm happy.
Thank you, sir.
Next we will go on to the panel discussion of upper GI bleed, tips and tricks. The moderator will be Dr. N. Rajesh and the panelists Dr. Arun, Dr. Sheshadri Venkatesh, Dr. Arul Prakash, Dr. S. Shanmuganandan, Dr. Arul Selvan, Dr. Raja Yogesh.
Good morning, everyone. I would like to thank the organizers for giving me the opportunity and for the wonderful arrangement. The next half an hour or so, we will discuss about the upper GI bleed, what are the tips and tricks. We have eminent panelists, 6 members. We have Arun, Seshadri, Arul Prakash, Shanmuganathan, Arul Chilvan, and Raja Yogesh. First slide. So, you know the upper GI bleed, the management is, the resuscitation is the foremost important thing. If the patient has a moderate massive bleed, you have to resuscitate. Meanwhile, restricted transfusion is the guidelines. So we have to target the HB between 7 and 9. Don't give over transfuse, especially in a case of portal hypertension. It may lead to, again, rebleed. Medical management is almost equally important. High dose PPA in case of ulcer bleed or vasoactive drugs in varices bleed shown to reduce the morbidity and mortality. And early endoscopy rather than emergency endoscopy is the guidelines, especially in the case of varices bleed, go less than 12 hours of admission, and if it's a non-varices bleed, less than 24 hours is enough. No need to do in less than 6 hours. So we'll discuss about the endotherapy. Coming to the first case, alcoholic cirrhosis, child B with a MEL score of 22% with moderate GI bleed. After initial resuscitation with the prokinetic and the terlipresine, scopy was done. This is the endoscopy. It's not. Yes. So what you are seeing is a junctional varices, esophagogastric varices, OGV1, high lesser curvature, varices bleed. So, Arul Silvan, so what will you do? Whether do a sclerotherapy or a banding or glue for a junctional varices OGV1.
Okay, so bleeding OGV1, usually we'll go with either glue injection or sclerotherapy because banding in this case is a bit difficult. It is just beyond OG junction. So we can go with glue injection or either sclerotherapy. If active bleeding is more, can go with sclerotherapy, which is very easy and can get even more time to get things and control the bleeding, either paravariceal or intravariceal injection of sclerosant can be given.
So went ahead with the sclerotherapy, is a site of bleed. We have done a sclerotherapy with sodium tetradecyl sulfate. Can you combine a sclerotherapy along with the banding? Arul Shelvan?
Yes, once the rebleed rate of after sclerotherapy is more, so once sclerotherapy control bleeding, can go ahead and can do banding after control of bleed, okay, and band other varices also.
Okay, thank you. This is another patient. So there is some problem in the video. This is another patient, the esophageal varices with the hemocystic spot at the OG junction. So this is a spot. So how do you apply band? Arul?
Hemocystic spot or red whale sign is a signs of bleed is more, and we need to go just distal to that hemocystic spot and reach the OG junction and start doing endoscopic varicose band ligation from the OG junction, and just below the cystic spot to ligate the varices.
So here the band is applied, the suction is applied at the hemocystic spot, so leads to misfiring of the band. So you have to go beyond, then do a band. That is important thing. This 70-year-old female, it's a large volume upper GI bleed. It's the first time presentation as a bleed in a cirrhotic patient, child's B with IN of 1.4. This is the endoscopy. This is a large fundal varices. Just when I touch the varices, it started bleeding. So the large varices, fundal varices bleed. Arul Prakash. So whether to do a glue injection or you prefer go for endo-US guided coil in this patient?
So
what are the techniques?
Yeah, fundal varices bleed is very dramatic and they may lose blood very fast. Based on the setup we have, we should decide. If you have a setup where you have an access to endoscopy and glue, you should better go with that. But recently, in last few years, US guided coil embolization had dramatically improved the outcome in terms of adverse events and the ease. So technically speaking, it's very simple. You can put an EUS, see the varices, and you can trace the feeder vessels, and then we can apply a coil gently. And in the recent years, we have done for multiple patients, and we didn't encounter any procedure-related complication in terms of failed bleed control. But whether you are going to apply coil alone or along with that you are going to inject glue is a decision we have to take. Because glue always has a little tendency to travel and get occlusive symptoms in a later time. When you have an access to just endoscope, and you can go ahead with the traditionally explained sign, we can catheter sign and pull sign we can see, and then we can inject glue.
So injected glue, once you remove the needle, again started bleeding, again your re-injection is done. After re-injection, once you remove the needle, again it started bleeding. What is the amount of glue, how much you can inject? So how much, is there any amount, volume, and what is the technique, each sitting, each injection, how much you inject, or you inject with the lipiodol or straight glue?
I don't think any one of us are using lipiodol so frequently, but there are certain places where they use, but we are using only glue. The amount depends on the size of the varices. The larger the amount, you are going to get more into a complication of glue traveling out. So it's only through the assessment of the size of the varices. In this particular situation, US guided coil helps a lot because you can assess the size of the varices, and you have to choose a coil which is 20% more. Like if it is 10 millimeter varices, you choose a 12 millimeter coil and you fill it, and the coil has this feathers inside, and it gets a hemostasis. So there is no set amount for maximum varicose glue injection, but we have to remember more the volume, more there is a risk of complication.
Do you palpate always to fill fees? Do you palpate the varices?
Yes, yes.
Whether it's obliterated always?
Yeah, that's a good sign.
Yes. So we have palpated the varices, there is...
Just one question.
Yes.
You were just discussing about this fundal glue injection, you just did it without a EUS.
Yeah, this patient we did it, so we didn't...
There was no success with that.
So it's not always, you cannot extrapolate one case into all cases. In this patient, I was lucky that I injected after 3 injections of glue. Actually, I was exhausted of glue and still is bleeding. I put a zinc-taken black tube, and the next day we are taken for a repeat endoscopy. There was a
My question is, what is the time limit you give? You just plain glue injection or EUS with glue? Is there a particular, is already injected glue? Can you do it in the same session? Or do you give a time gap and then do it?
There are instances where we have done US coil when there is no visibility at all. You just go see the vessels through the US and put a coil, and we have come out very safely. I mean, this is the positive side of US, but there is no, if you don't have an availability of an US, you can try this, and I think, as he said, if it fails, then go for the next, do a SP tube and then block and see it again. So there should be some way out of it.
Is there any way coiling comes out of the varices and
Many times we did had. So it's like choosing and how fast you are doing that. The coil can get stuck at the needle, and when we are not deployed fully, it can come out. But we didn't have any much problem after that also.
Thank you. The next case, 27-year-old male, extrahepatic portal obstruction is a known hypercoagulable state on warfarin. INRS 1.9. Screening endoscopy showed grade 3 varices with the red signs. Patient is already on primary prophylaxis with the beta blockers. So, Arun, so what will you do? Will you do as a banding here because patient is already on warfarin with INR of 1.9, or you continue with the beta blockers alone? What is your
Actually,
take home?
the amount of data available is limited in this this area, but there is no mortality benefit or reduction of rebleed by withholding anticoagulation in such patients. So, and in this patient, the INR is less than the therapeutic.
Less than 2 point, yeah, that's
so,
true.
We don't need to
worry about that.
warfarin here. The data available is mostly with low molecular weight heparin, which can be safely continued through the
Yes. If it is INR is less than 2.5, you can continue because patient is hypercoagulable state. The question is, patient has the red signs. Whether do banding here or not? Prophylaxis, primary prophylaxis.
Yeah,
No.
banding can be done.
Okay.
Banding for primary prophylaxis, banding is of a second choice only. Carvedilol or non-selective beta blockers are the first choice. But if the varices are high risk
Yeah, high risk, red signs are there.
more than 5 centimeter,
So-
red signs and child C patient, then
Go
if,
ahead with
and a patient has an intolerance to
Beta blockers,
non-selective
then we
beta
go for-
blockers, then we can consider EVL for primary prophylaxis.
Actually banded the patient, and the patient continued with the warfarin, and unfortunately patient presented with the bleeding on the 6th day with a torrential bleed, and after resuscitation early endoscopy at INS 1.8. This is a post-band ulcer, and it's 11 o'clock, it's actively bleeding. And while doing endoscopy, patient went in for hypotension. I removed the scope. So what next? Post-band induced bleed. The patient is INR of 1.9 on oral warfarin. What next, Arun?
So, post-tibial ulcer bleed is a life-threatening complication. First thing is that we should recognize the gravity of this situation and always prepare for a rescue tips, which can be a definitive intervention. So, while we are waiting for tips, we can do other strategies. Two main strategies. One is tamponade. Tamponade can be either with SP tube or Danicella stent, or or endotherapy. Endotherapy actually a repeat EVL can be done below the ulcer level, or nowadays hemoclips have been tried as an intervention, which appears to be very promising. So this can be tried while waiting for tips. This patient has an INR of 1.8. So whether FFPs can be used. Actually, the recent data suggests that giving FFP does not change outcomes.
Yes, if FFP is not useful in even if it is a coagulopathy, go for PCC rather than FFP. That is the recent guidelines. And we placed the Sengstaken Blackmore and bleed control. Actually, we stopped the warfarin after 24 hours of a removal of Sengstaken Blackmore tube. There is no rebleed, but patient developed internal jugular vein thrombosis after stopping the warfarin for 6th day. So that is the scenario. So always don't stop anticoagulants, continue the anticoagulants, keep INR around 2. The important point here is the portal hypertension is the pathology here, not the coagulopathy. So always continue warfarin or anticoagulate the patient if the patient is a high-risk patient for thrombosis. 63-year-old male, it's a known case of ethanol cirrhosis post-EVL. Patient had developed melena for 2 months. It's a mild anemia with the thrombocytopenia. The endoscopy showed a GAVE. So Raj Yogesh, so how do you manage this patient? What are the options?
As we all know, GAVE is not related to the level of portal hypertension, and so medical therapy with beta blockers and other therapies which are more useful in portal hypertension related bleeds do not work here. So the ideal option would be depending on the distribution of gave. If it's going to be a diffuse gave, banding would be a less ideal choice, whereas if you have a linear, the typical watermelon stomach, I would resort to banding. If it's going to be a diffuse gave, APC would be a better choice of modality here.
So how do you do APC? What are the settings? What is the advice for the post-graduates?
APC would be an ideal modality if it's going to be a superficial bleed, for example, with smaller AV malformations, telangiectasias, or patients with GI cancer with a diffuse surface ulcer bleed, where APC would be useful. Ideally not indicated for an ulcer with a visible vessel or a spurting gastric ulcer or a oozing gastric ulcer, where APC might be more detrimental. In these cases, you might need a method of coaptation, and with APC, coaptation would not be possible. You need a heater probe or a bipolar electrocautery. And a few points is that as a beginner, we generally have a tendency to move the catheter in and out to reach the lesion. That should be avoided. Rather, keep the probe at a fixed distance from the tip of the scope and move the shaft as well as use the knobs to reach the lesion. Another point that we found it useful is to use a distal cap. Using a distal cap gives us that much amount of distance between the scope, between the probe tip and the mucosa. And it would ideally help in maintaining a non-contact method of coagulation. If a cap is used, we can ideally keep the probe and even drag the scope along the mucosa while still maintaining safe distance between the tip of the probe and the mucosa. Watch out for abdominal distension, which is very much common. And make sure that if there is going to be a contact, if it's not prolonged, then we are safe. If it's prolonged contact, then it can result in more complications like full thickness coagulation, perforation. Sometimes we do come across a submucosal emphysema where the argon plasma escapes between the mucosa and dissects the mucosa.
Thank you, Yogesh. So next case, 50-year-old male is upper GI bleed, mild to moderate, hemodynamically stable. This is the endoscopy. Sheshadri. So what do you do? This is for us to be.
Yeah.
Whether you wash and see or wait and see.
So it's a forest 2B also with a clot. So there are two options, as Dr. said. So either wash and see, remove the clot and see, or so the first option, wait and watch. You can go for it. You can keep waiting, but suddenly you will run into problems. So what do you do at the time? So the concept now is to change. It's remove the cover and act immediately. So forest class 2B ulcer, we have the logic says the culprit is under the clot. No? So you remove the clot, there's a visible vessel, you tackle it immediately rather than wait for the event to happen and run into problems, right? So appropriate is to remove the clot, look for the vessel, and appropriate endotherapy as is there. And only thing is you can have spurters when you remove the clot and you dilate the clot. So be ready, have your surgeon in place, have your intervention radiologist also, call him, keep him ready in case you're not able to tackle the bleeder.
So we are injected, then again washed, we are able to remove the clot. Now the 2B becomes 2A. There is no need for endotherapy here. Only PPA, patient improved. This is a 40-year-old male, post-PTCA, 3 months ago on dual antiplatelet, moderate upper GI bleed with the tachycardia, the forest 2A. You can see the pyloric channel ulcer with the visible vessel. So, Seshadri, whether you continue the antiplatelets or you stop, or if you want to continue one antiplatelet, which antiplatelet you continue, what endotherapy you do, whether is there any need for platelet transfusion?
So, this patient has had a recent coronary intervention. So the thing is, the first thing is, the most important thing is to see that the patient is already on 2 antihypertensives. So the coronary stent is always happy with 2 antihypertensives, right? So but we are not happy with the 2 antiplatelets. So we have to get control of the bleed. So we need to act. So the first thing which we have to do is early resuscitation and endotherapy. Once we get control of the ulcers with the endotherapy, then we think what you're going to do with the antiplatelets, right? So endotherapy for ulcer, if it's forest 1A, 1B, or 2A, or 2A or 2B, we know that you're going to do the appropriate endotherapy. And if you're going to give injection, you apply a mechanical therapy also. Don't stop with injection. And once hemostasis is achieved, the next question comes: what antiplatelet to continue, what to stop? Okay, so we have to continue aspirin. The guidelines say that you continue aspirin and stop clopidogrel, and restart clopidogrel after at least 3 to 5 days of getting proper hemostasis. In case there's no hemostasis, your patient is having a rebleed, get proper hemostasis with either interventional radiology and then restart the clopidogrel. Don't stop both the antiplatelets, because the mortality due to cardiac events is much more than the mortality due to bleed. So it's very important to keep at least one antiplatelet. The recommendation says continue aspirin.
Thank you. So we have done a clipping, a resolution clipping is applied, and patient improved.
So that's to finish the ulcer bleeding and endotherapy. Against stress, do not stop with just one. We need two modalities if there's an injection, one strong modality and one weak modality. Injection is a little weaker, put a thermal or a clip. While clipping, you ensure that you get adequate tissue. Both the limbs should catch adequate tissue. If it's a large squatter, put a clip at least close by and come, so that the interventional radiologist can help. So 2 is also helpful for us sometimes.
Thank you, Seshatri, for the entertaining talk. So the 38-year-old male, CBD stone, 1.3 centimeter, after his sphincterotomy, sphincteroplasty, this is a bleed. So after sphincterotomy and sphincteroplasty, this is a bleed. So, Shanmugan sir, so what are the precautions you take to prevent post-EST or EVL bleed? How to manage this type of bleeds?
First of all, the patient-related factors. We should be aware whether he is having any underlying cirrhosis or chronic kidney disease or with hemodialysis, whether they are on anticoagulation, and appropriate protocols for the duration of stopping anticoagulation should be done before planning the procedure. And as far as the procedure is concerned, follow the basic rules. Do not, when you are planning a sphincteroplasty, better do a small endoscopic sphincterotomy followed by a large balloon dilatation. Not a large sphincterotomy followed by a large. That may prevent extension of cut and prevent a potential bleed. And what can be emphasized is the basic of cutting in the 10 o'clock, 11 o'clock direction, because what they have found is the likelihood of encountering a major arteriole is less in that direction. And third thing is he can, when you are encountering a bleed, the same balloon, these are all usually very low-grade bleeds which stop on their own, and we can inflate the same balloon and keep it as a tamponade. Or we can even use a biliary extraction balloon that can stop it. Still not stopping, we can continue the procedure. Balloon tamponade is an option. Injection treatment, yes. We can have 1 in 10,000 adrenaline in the backup. Thermocoagulation, yes. But with what is the question? The same sphincterotomy, if it's there in situ, we can just direct the sphincterotomy usually towards the apex of the cut and try to coagulate it. Or sometimes we can even use a heater probe to use for coagulation. Important point to be noted is avoid the pancreatic orifice at all costs, because we'll land up with a second problem.
Complication.
Inadvertently coagulate the pancreatic duct orifice.
Yes, thank you, sir. So most of the time it is a self-limiting, and you can continue the procedure, and by the time you remove the stone, the bleed stops. And the major vessels are not in the 11 o'clock direction. Thank you. So if you want to go to second round, if there is no time, we will finish. This is another patient with upper GA bleed. This is a visible vessel at the 6 o'clock position, the fundus region. So what we are doing is a heater probe coagulation, applying a heater probe. The principle is a coaptic coagulation. You have to compress the vessel first, then apply the energy source. You have to keep it for 8 to 10 seconds. If you remove this, the depressed lesion, whitening of the lesion, it indicates the complete occlusion. Then you can take a biopsy. It turned out to be a lymphoma. So you can do endoscopy and banding in a pediatric age group. It's a 3-year child, banding done. This is a final case. For audience, it's a upper GI bleed, post-PTCA, dual antiplatelet, severe chest pain, but cardiac evaluation normal. Any diagnosis? Anyone? Very good. This is submucosal hematoma, esophageal apoplexy. It's a tear. So don't band here. So stop the antiplatelets. With the medical management, patient improved. This is another patient, young patient, presented with upper GI bleed. Any diagnosis? This is oropharynx. This is epiglottis you are able to see. There is a globular mass, just base of the tongue. See the lesions, cystic lesion. Any diagnosis? This is a spot, bleeding spot, just in front of the epiglottis. Diagnosis? The ultrasound showed absent thyroid in the neck. Diagnosis? Ectopic, that's a lingular thyroid. So this patient managed with just TSH is more than 100, managed with L-troxin, patient improved. So not always you can do not always required. Sometimes without endotherapy also you can manage it. This is a final case. A patient, I tried to put a duodenal ulcer and clipping, but it started bleeding. The visibility is lost. So we are torrential bleed, subjected to surgery, duodenotomy, underrunning of the ulcer. If we have an interventional radiologist, go for interventional radiology, otherwise surgery. So ladies and gentlemen, resuscitation before endoscopy is the most important thing. Early endoscopy within 12 to 24 hours of admission gives a better outcome. Always EVL is better than EST, even in a pediatric patient. Glue injection without lipiodol for fundal varices bleed. If it is a large bleed, fundal varices, go for a coil with the endoescalator coil plus lipiodol, this one glue. Thermal or mechanical therapy along with adrenaline injection. It's not a monotherapy, it is a combined therapy for ulcer bleed, for a forest 1 and 2A. On antiplatelet treatment, continue with aspirin, stop others. Patient on warfarin, keep the INR 2 to 2.5, not more than that. If there is any failure, rarely, it may require interventional radiology or surgery. Thank you.
Actually, it's really fascinating to see the technological advancements in endotherapy. So 2 decades back, we were doing a lot of DVAS and shunt procedures. Now, what is the role? Our role is now becoming a salvage role rather than a prevalent. Have you ever referred any case to surgeons?
So that's what last case I saw.
But you will have the surgeon's backup, no?
Yes, sir, we have always surgical backup. So always the surgical backup is important, sir. That gives a more confidence to the endoscopist.
Liver transplant continues to remain, our domain surgery until the hepatocyte transplant comes.
Thank you, Dr. Rajesh, and it's a wonderful presentation. And especially it will be a very good feast for the intervention gastroenterologist. And one point to make is when you do ERCP and endoscopic sphincterotomy, the initial bleed, it is always to start with the coagulation than for cutting, rather than cutting and then the coagulation. So it's our personal experience. And once you put a stent, you start bleeding. Once you put a stent, and generally we observe that the bleeding gets stopped.
But we always don't start with coagulation. First cutting, then usually if we have endotherapy, nowadays we have endotherapy, we do, but don't start with coagulation. It produces more pancreatitis. So always if you don't have endocut mode, first cutting mode, then go to towards the end, go for coagulation.
So generally identifying the vessel, the pattern of the vessel around the ampulla. If we are safe in cutting a particular place, the avascular region will be always good. But in our study, we have did nearly 600 cases of endoscopic procedure. And in our observation, you should start with coagulation. That particular area will be coagulated. Then cutting it be
No, sir. No, but that is, see, if we have a scientific forum, we should not teach the other way.
The risk of
Pancreatitis is more, yeah.
coagulation. So,
Sir, yes, sir. Ravi.
You covered too many topics. Two things I want to stress. One, the clips are effective only if you capture as much of tissue as possible. So if you have done a local adrenaline or some injection, you would catch a X amount of tissue, and then after some time the effect of adrenal goes, there is a collapse of tissue, and these clips might fall out. So it is better if you do it before local injection. One. Number two, you said you asked somebody that whether you palpate after
injecting
glue. I mean, that is a practice which one need to very carefully do it, because sometimes if you press too much, you can dislodge the whole glue, and if the extra hepatic portion of the veins is very big, it will get dislodged and go to the lungs. So it should be done very gently, so that if the mouth is very small, it may not happen, but if the communication is very big, then it will get dislodged.
Thank you.
Cutting with in?
No, sir. So for cutting the sphincterotomy, whether you use first cutting current or coagulation current, we generally use a mixed blended current endotherapy. It's that's what Madam is asking.
The endocut, every time you press a pedal, there is a coagulation to start with, and it cuts. And in that gap also, there is a small amount of coagulation happen. But if you use specifically coagulation, there is another risk. If you use too much coagulation, it will result in pancreatitis, which is much more common complication than bleeding. So you need to be careful in that. If you are cutting close to the papilla, where the pancreatic duct joins, then you should use less coagulation. Maybe if the papilla is very long, and if you are cutting more proximally, you can use coagulation.
Sir. Thank you, sir. So I thank all my panelists for the wonderful discussion. Thank you, sir.
Our next session would be Best Endoscopy Videos. To chair the session, I call upon Dr. R. Ravi, Dr. R. Ramasubramanian, Dr. Ashok Chakko, Dr. Abby George Simon to chair the session. I request all the chairpersons to take the seat on the dais. To present the video, the first comes Dr. Madhura Prasad. Announcement: the registration for tomorrow quiz program for PG students. Kindly register. Each college can represent 2 members for the quiz. You can register. You can register yourself to Dr. Arun.
You can go ahead. Presentation time is 4 minutes and 1 minute for discussion.
TNISGCON for this wonderful opportunity. I present here a prospective single-center trial on deep submucosal resection of duodenal neuroendocrine tumors with over-the-scope clip. So neuroendocrine tumors are increasing. Are we detecting them more on endoscopy, or is that really a change in tumor biology? Endoscopic methods of removal is preferred in duodenal neuroendocrine tumors because surgery in this location, the morbidity is very high, EMR and ESD has been done. But we have to always think about what depth are we going to go to, but we still have to prevent a perforation. In this instance, a FTRD device where there is a clip safely securing, preventing a perforation seems very attractive. But the FTRD available device, the cap is 23 millimeter additional length. It is difficult to position just beyond the pyloric ring at D1. Hence, an OTSC with a 6 millimeter additional length seems to be okay to position and suction, clip it, and then we use a snare to snare it off. And we did an EUS guidance before we start. We included all patients with localized moderate-sized duodenal neuroendocrine tumors who were biopsy-proven, who needed resection, and we excluded those who were unfit for anesthesia. We used a 12 or 14 millimeter T-type OTSC clip and an oval snare. We had 13 patients who were selected, but during the procedure, 2 patients got excluded, and the EUS showed extra tumor beyond the muscularis propria. And the median size of the tumor was 1.4 centimeters. There were 9 male and 2 female patients with 61 years of median age, and there were 4 other areas where duodenal or gastric neuroendocrine in some patients. So if you see here, there is a large duodenal neuroendocrine tumor. We are focusing on narrowband imaging, and then here you can see EUS showing this tumor very clearly away from the muscularis propria. So what's important is this is loaded just like a banding, this OTSC is loaded like how a band is loaded, and it's important to suction it completely and a slight push against the wall without too much of pressure, and a slight push is required, so 2 people are needed while deploying the clip for safety. And we need a readout just like how we do banding for varices. We need a proper readout before we deploy the clip. And here the clip is seated very clearly, and we use a small snare to snare it off. And this snare can be difficult to position because of the curvature of the clip, but here it has been successful and we remove the complete tumor. Similar, another case, I'm not presenting all videos, just only 2. So here, this is also in D1. You can see also it's a little large. So we use a 12 millimeter clip. We have to use an OGD scope, and 14 millimeter we use a double channel or a colonoscope. Here also you can see the clip being and then the snare being snaring off the top of the lesion. There you can see the lesion is completely excised. So there was en bloc resection in 100%, R0 resection in 90%, full thickness resection was there, not there in any, but there was deep submucosal resection in all 100%. And adverse events, there was no bleeding or perforation, some transient throat pain was there. Ki-67 index, all of them were G1 grade 1, all were synaptophysin and chromogram A positive. At a median follow-up, you could see the clip in place at 6-month follow-up, but there was some sort of tissue here, but on biopsy, it was negative for neuroendocrine, it was just a tissue ingrowth. And here, this is a similar study which was done published in Endoscopy International Open, but they had chosen smaller tumors in duodenal neuroendocrine tumors, smaller ones, 10 millimeter versus 14 in our study. There was delayed bleeding in some, but there was no perforation in their study also. And they used endocut Q and same T-type clip. I don't know why they had delayed bleeding, but all in all, they were also that was also done safely. So moderate sized duodenal neuroendocrine tumors can be safely resected by deep, even up to the level of deep submucosal resection after firing an OTSC clip and then resecting above it with good R0 rates. This is what we'd like to conclude. Thank you very much for your patient listening.
Thank you, thank you.
A good presentation. Thank you, sir.
Just one question. Did you do a daughter-top PET CT because there could be carcinoids in other areas?
Yeah, actually, some of these patients had in the same duodenum D1 itself another lesion, smaller ones. So we did do Dotanok in some of them, but not all of them. So one of them had a gastric, and 3 of them had duodenal. So they are still on follow-up, and we have told them for surveillance. So.
How did you confirm it's an R0 resection?
So R0 resection, like on macroscopically, initially what we saw was the entire tumor seemed to have on en bloc resection, but for R0, the pathologist confirmed R0 resection. So once we had a talk, and then whenever we were sending specimens, they confirmed that there was some submucosa below the lesion before the cautery artifacts. So that's how we confirmed.
So some of them look very superficial carcinoids, neuroendocrine tumors. You could have used a band ligation and cut it below. Why these ovoscope clips are quite expensive?
That is what we used to use before. So we always used to band the lesions, and that also gave excellent response. Many of these people, just with banding, it falls off, and so we gave them an option, and these were slightly larger in size, that they couldn't fit into the band. Those were the people we selected for OTSC actually.
Is there a worry post-snaring that the clip will get dislodged?
The clip may not get dislodged, but if the clip misfires, I think it will be troublesome because it's difficult to remove the clip. It's not a very easy clip to remove, and surgery also becomes very difficult to do after you do all these procedures, I think. So, but clip, it falls off once the tissue grows below the clip, then it falls off. So that's what we follow up for 6 months, and it had fallen off only in 1 patient. So out of 11, so only in 1 it had fallen off. The others, it was still secure in place.
Thank you.
Thank you very much.
Dr. Madhura.
Thank you, sir. Thank you.
I call upon Dr. Arun Prakash for his presentation.
This is not the slide. Reflex on. No, just now download.
Arul, shall we ask the next person?
Just take this out.
Is Dr. N.A. Rajesh ready? Are you ready with the presentation? Yeah. So you can do the next presentation. By the time Arul, you can get ready the video.
Yes, sir.
Rajesh.
Good afternoon. I present a case of gastric ESD in a patient with cirrhosis liver. Our patient is a case of NASH-related child B cirrhosis. He was incidentally diagnosed to have early gastric cancer. The challenge in this particular case was this patient was having a low platelet count and coagulopathy with INR of 1.5. His endoscopy showed small esophageal varices, and white light endoscopy showed elevated lesion with central depression. It's a type 2C and 2A, which is well delineated with chroma endoscopy with methylene blue. Narrowband imaging showed demarcation line with loss of microsurface and microvascular pattern. So we started ESD with marking the periphery of the lesion using soft coagulation. Once the periphery is marked, submucosal elevation was attained by injecting diluted methylene blue, and we proceeded with circumferential mucosal incision using dual knife with endocut I, effect 3. Since the challenge was low platelet count and coagulopathy, we had time and again ooze from the mucosal site of incision, which was most of the time managed by vessel sealing with dual knife itself. However, as we were almost completing the mucosal incision, we had significant ooze from the incision site, which could not be controlled without exchanging the accessories. And here we had some difficulty, and this bleed was managed with little struggle using coagrasper. So once circumferential mucosal incision is done, submucosal dissection was begun, which was facilitated by injection of again diluted methylene blue in submucosal space. So we at our place prefer endocut I for even submucosal dissection, and the reason being this reduces the procedural time and also reduces the thermal damage to the muscularis propria. So whenever there is a lot of subcapillary vessels, and then we switch over to forced coagulation to coagulate the superficial vessels. So we are carrying out the submucosal dissection, and the lesion is around 60-70% dissected now. So we use only single accessory, that is the dual knife for entire dissection. You can see the intact muscularis propria layer, and the lesion is almost out now. And this is the final cut, removing the tumor from the patient. So this is a retrieved specimen which was around 4 centimeters and 2 centimeters. And post-ESD endoscopy showed complete resection of the tumor with intact muscularis propria and no bleeding from the base. Histopathology showed crowding of glands with hyperchromatic nuclei and very little stroma, and the margins were clear, and the tumor infiltration only up to lamina propria. The relook endoscopy done at 1 month showed healing of ulcer by scar formation. Unfortunately, this patient presented 5 months later after ESD, and he came with acute and chronic liver failure and succumbed to sepsis last month. Thank you.
Hello. It's a good presentation.
Thanks.
Did you do EUS?
No, this patient at our place we only have a linear EUS scope, which is very difficult to position in this place to do evaluation. Of course, did good contrast enhanced CT and PET CT to rule out locoregional lymph nodes.
Did you do that? And what
Yes.
were the findings?
CT and PET CT both did not pick up the lesions. It was normal actually.
Rajesh, nice presentation. Patient had a liver disease, and do you think it is worth however it has a high complication rate, ESD, in patients with liver disease and coagulopathy, do you think it's worth taking a risk of in a patient who doesn't have a malignancy?
Yeah, this patient was only 57 years old, and he had a child score of 7-8, and his survival looked promising at that point of stage, and it was very early gastric cancer. And at presentation, his platelet count was 30,000. We even tried L-Trombovac, kept him for 5 days. Platelet didn't improve. Transfused on the day of the procedure and took him. But patient was had good performance state, and this was the call which we had to take. And surgery will be a highly morbid condition for this patient. And even we were not very sure whether it is a type C lesion or type 2C. That decision also was done when we injected the submucosal space and there was a mucosal lift. Then we proceeded with ESD.
Thank you.
Thank you.
Arvind Prakash, are you ready? Next, Dr. Dinu Abrami, Dr. Vishnu Abhishek.
You can play already.
Greetings everyone. This video is on a case of esophageal leiomyoma managed with perioral endoscopic tumor resection. A brief history. Our patient was a 50-year-old gentleman with nil comorbidities who presented with intermittent dysphagia to solids with associated dyspeptic symptoms. Baseline investigations were unremarkable. Endoscopy revealed a subepithelial lesion extending from 24 to 30 centimeters with significant luminal narrowing. A CT evaluation was done which showed a 3.4 into 2.5 into 6.7 centimeter lesion arising from the esophageal wall and no regional lymphadenopathy, and the adjacent structures were free. An EUS evaluation was also done which revealed the same hypoechoic mass lesion arising from the muscularis mucosa layer of the esophagus, and an EUS guided biopsy of this lesion was done with an FNB needle. Histopathology revealed a spindle cell neoplasm with no nuclear atypia or necrosis, and immunohistochemistry was strongly suggestive of a leiomyoma. Considering this case, as the patient was symptomatic with a more than 5 cm lesion, it warranted excision. So the possible options of endoscopic versus a thoracoscopic excision was offered, and patient finally underwent a perioral endoscopic tumor resection under GA. The proximal extent of the tumor was at 24 centimeters. A submucosal cushion was created using methylene blue admixed with normal saline at 20 centimeters, and a submucosal incision was made. The submucosal incision was followed by submucosal tunneling with the injection using methylene blue, and the tunneling was done using a TTG knife and an endocut cautery. The submucosal tunnel was extended downwards until the tumor was visualized. Once the proximal end of the tumor was reached, dissection was continued on either sides of the tumor using the same TTG knife and endocut cautery. At the end of dissection, the tumor was completely free from the adjacent esophageal wall layers from the proximal to distal end. We could also make out there was a mild expansion of the tumor because of release of tension. And this is the appearance of the tumor after complete dissection. An endotour removal of the tumor was attempted using a snare but failed. So we decided on dividing the tumor into two halves using a TTJ knife, and then proceed with the removal of the tumor. So the tumor was divided into two halves. Of course, this was the difficult part of our procedure. It took most of the time of our procedure, and followed by which the proximal half of the tumor was removed with the help of a snare. In a similar manner, the distal portion of the tumor was also removed with the help of a snare, and the complete tumor removal from the submucosal tunnel was achieved. This was the appearance of the submucosal tunnel at the end of tumor resection, and a complete hemostasis was achieved all along the tunnel surface. The difficult part was preserving the integrity of the muscular layer and also closure of this mucosal defect. The mucosal defect was approximated using hemoclips by line and clip method. Following approximation, this is the appearance of the mucosal defect, and following which a rice tube placement was done. This is the resected leiomyoma specimen in 2 halves. Post-operative course, a total procedure duration of 6 hours. A repeat CT was done the next day showing minimal pleural effusion with no contrast leak. Patient was started on NG feeds after 48 hours and oral feeds on day 4 and discharged. On follow-up after 1 month, this is the endoscopic appearance with the residual hemoclip and complete healing. On review of previous literatures, a leiomyoma of 7 cm, as in our case, removed by stir has not been reported previously. Thanks for patient listening.
Thank you.
So maintaining integrity of muscle is important. Something like that the presenter said.
We were to dissect around the tumor. At the time, taking the entire scope with such a lesion and getting in between the lesion and the muscle was slightly problematic, but we had to preserve the muscle also. If we cut open the muscle, no problem, we can always close it. But during the dissection, I didn't want to open up the muscle, otherwise the patient will end up with a huge amount of capnomediastinum.
Why do we need to close? It is an offset incision. Why do we need to close the muscle, even if it is open?
We didn't close the muscle. The challenge was to preserve the muscle layer during the dissection. Inadvertently, if we open up the muscle, then again leakage of the CO2 into the mediastinum we have to stop the procedure for high CO2 levels, and then that will be the challenge. The presenter said the challenge is to preserve the muscle layer. We didn't cut it, so that's what the challenge is.
Nice presentation.
Thank you, sir.
What distance away from the tumor did you make your incision before tunneling?
I had to just 5 centimeters, sir.
5 centimeters. And you marked the distal end and then went in?
No, I didn't mark the distal end, sir. Because inside the tunnel, once the tumor end is reached, it's going to be evident, so I didn't mark the distal end, sir.
How long did you take to complete your procedure?
The dissection took just 1 hour, but the challenge was to get the tumor out. We were trying methods to get the tumor out, and while we were trying to take out the tumor out, the incision got a little widened, so we didn't want to cut open the incision to the entire length. So we cut open the tumor into half using the knife. So the scope had to be bent in this direction, and then we had to dissect it into 2 halves. At that time, the snare was used to remove. And also clipping took some more time. The line and clip took more time because some of the mucosa was ragged. When we tried to remove the entire tumor, the incision somewhat became ragged. So approximation took a little bit more time. The dissection took only 1 hour, but the rest of the procedure took more time. So totally it took almost 5.5 to 6 hours.
Quite a challenging procedure, I think.
Sir?
It's quite a challenging procedure.
It was a challenging procedure, yes, sir. But the post-procedure, I showed the video to my CTVS surgeon. He also agreed the recovery was with less morbidity for this kind of tumor. And this was the largest so far yet reported submucosal tumor dissection.
For closure of the incision, you used clips.
Yes, sir.
Some people use sutures.
Yes, sir.
So do you have any experience with both, and which
no, sir.
do you prefer?
Suture turns out to be, we are trained in suturing, but that turns out to be so expensive affair. And I've never tried a suturing device in the esophagus because there we have to work with a very narrow area, and I've never tried Apollo endostitch device in the esophagus. No experience on that.
Vishnu, congratulations again.
Thank you, sir.
I have 2 queries. One, did you have to extend the incision to remove that tumor? And when you break open the capsule, the tumor expands.
Yes, sir.
Then is there a line where you don't resect by endoscopy? Because there are a lot of postgraduates here. You are an expert, but one should not try probably more than 5 centimeters.
It was a surprise for us also because there was a capsule around the tumor. Once we started dissecting, and when we took out the tumor, it actually measured 12 centimeters. 12. And when it went to the pathologist, when he measured it, it was like 8.5 centimeters. But in CT, it was 6.9 or something like that. 6.9. So the tumor kind of shrink after when it went to the pathologist. The line is like, we are also improvising. Like when we tried to remove it, the incision was almost like 4 centimeters. It kind of became more oval. Having seen retrospectively whether we could have incised little lengthier, yes, we could have. Yeah. But then we do not know about the closure. And if we incise more, tunneling would have been difficult, sir. Like even in ESD, if you open it fully, the dissection paths become more difficult.
On hindsight, to remove that tumor which was not coming, you had to break it open. Whether it was useful to open the incision a little bit and then remove in toto, or?
It would have been, but I would have been damaging more mucosa, so I didn't want to do that, sir.
Ganesh, actually the size which is limited for excision is 3 centimeter breadth. It is not even, the length can be any length, 7 centimeter, 8 centimeter. It is not, the difficulty is not taking it out from the submucosal space. This difficulty is taking out at the cricopharynx. If it is more than 3 centimeter, it won't come through the cricopharynx. And then they take it to the stomach and cut it into pieces, and then you can remove part of it for biopsy.
He cut it in the tunnel
If
itself.
it is long, 8 centimeter long also, it did not come out of the tunnel, so he cut it in the tunnel. Thank you, Krishna.
Thank you, sir. I thank Dr. Mahadevan for the guidance and thank Dinu for the video. Thank you so much.
Dr. Vinod. Dr. Arun.
Apologies for the delay, some technical issue. I just changed the topic and then, so I just wanted to share an interesting clinical situation. I mean, apart from the procedure, it's between reflex and non-efflex. Like either it's reflexing back or it's not moving forward. That's the topic here, regards from our institute. It's about a 33-year-old housewife who was symptomatic for 3 years with persistent chronic cough, heartburn, bloating, and regurgitation, which can be easily written off like a dyspepsia. And it was for some years. She was evaluated elsewhere and underwent endoscopy, ultrasound, and was treated with PPA with very partial response, and it happened again. She came to us and she underwent a manometry and 24-hour pH study. Manometry showed a hypotensive LES and 24-hour pH impedance, positive Demester score with high reflex episode, and there was a good symptom correlation with cough and heartburn. So it's a little straight, looked like an reflex-related symptoms proven by pH and manometry. So we planned GERD-X. After giving an option, they chose GERD-X, and we were got ready. But before that, we wanted to do an endoscopy ourselves. Then what we saw is there was food stasis in the stomach. And now the question is whether to proceed with GERD-X or not. Because when you have a paresis, I mean, dysmotility of stomach, if you do a fundoplication, TAF, then there is a possibility of treatment failure. She will persistent to have the symptoms. Hence, we went ahead and did gastric emptying studies, and we can see that it's suggestive of gastroparesis. At 4 hours, there was 10% staying in the stomach. And then thereby we planned gastric POEM, that is pyloroplasty by endoscopic technique. We choose 5 centimeter away from the pylorus, injected voluminous amount of fluid into the submucosa. Our colleagues who are doing POEM will understand it's technically not very different from esophageal POEM. Only the problem is gastric mucosa is really thick, and you have to, and the route you can deviate to any side because you have a large stomach, so you can, the tract may go a little deviated, so you have to come back and go again and again. The technical challenges are you have thick blood vessels, and the submucosal space and the fibers are really thick compared to esophagus. So we continued dissection. So you can see the large vessels here, which has to be controlled by coagrasper, and we have to proceed further. The only problem is when you reach the duodenal part, we have to be more careful because duodenal mucosa is very thin, and if your probe touches that, then the whole procedure is gone. So you will be creating a mucosal damage, and so here we have handling large vessels. and we continue the incision. You can see the arc over there. That is the pylorus muscle. What we can see is a semilunar area there. So you can see it now. This is the pylorus sphincter. What we see above is the duodenal mucosa. So we have to cut 0.5 centimeters above that pylorus ring, and then maybe 1 to 1.5 centimeter below. That is enough for a good G-poem. Technically, it's not different, as I said. The problem is, again, comes with the closures. So we used an IT knife to be safe because we should not injure the other part where the mucosa we are facing there. We are cutting with IT knife now. So finish the procedure, and we can see a big rent. Technically, it's very challenging because thick mucosal folds cannot be approximated by simple clips. Many people are using suture devices, but we don't have that option. It's too costly, and it's difficult to, but we manage with clips. What you require is more clips in piggyback fashion, like we have to apply it very closely. So we can see that it's done, and we passed into the duodenum. It's more free, but even, I mean, we cannot see an obvious endoscopic image of improvement, but still, on follow-up, at 6 months, surprisingly, her symptoms all improved. She doesn't have cough anymore, and we did an study, again, gastric emptying study, which showed a normal one. The learning part is here is, GRD is associated with gastroparesis. Everybody should remember. It ranges from 10 to 30%. We had I happened to see a thesis from MMC, which done a few years back, where they reported around 10% of GRD having gastroparesis. It's underdiagnosed, and it may be the cause for treatment failure if you go for a fundoplication. G-poing is a very rewarding procedure, and it's not practiced widely for some reason. I think this will highlight. This is the reason we presented this procedure. Thanks for patient listening.
Thank you, Arul.
Yes, sir.
That was interesting. What did the follow-up look like? There was significant clinical improvement?
Yes, absolutely, sir. She's still on follow-up, but she's
length?
not coming. The problem for her was persistent cough predominantly and bloating. But now she's not on any PPI.
The reason I'm asking is, when you give botulinum toxin, that has been tried, but the duration of improvement is not significant. It's been a bit of a failure. So what is the duration of follow-up?
So we did it somewhere around March. Still now she's symptomatically better. If I asked for some reports for this presentation, I contacted her. She's doing absolutely fine.
1 year?
Yeah, till now, sir.
The cough was due to an incompetent GE junction.
Sorry, sir?
The cough was due to the incompetent GE junction. Do you plan to tackle that at some point later?
Now she doesn't warrant that. And if she's not having a complaint, probably we thought we'll just observe her. So initially we thought it's just a reflex, but I think gastroparesis is confounding. The reason why we presented is many people who have reflex may have an associated gastroparesis, which has to be looked into in more detail.
I agree that you have to do the poem part, G poem you have to do. Do we need to tackle also the...
If persists, probably we do a pH metry again, impedance, to see whether there is acid or non-acid reflex. If it warrants, we can go for a fundoplication.
Dr. Arul, a good presentation. I have a question actually, as Dr. Ebi has mentioned that you meant for planning to start treating for GERD and then end up in doing G-poem. And you mentioned that there was a stasis, gastric stasis, that makes you to think of going ahead with the gastric emptying, because gastroparesis is such a common problem, but we are not investigating. Is there a sufficient indication to go for G-poem in this case?
I mean, at the end, now I'm accepting that. But her problem was predominantly this bloating and cough, which I felt it's inappropriate if you see food stasis in the stomach to go and tighten the OG junction. She will have definitely post-procedure bloating sensation. I don't think she's going to improve. And we have a documented evidence of gastroparesis. So hence I thought, I mean, it's the best option to go, and we succeeded in that.
Did you try conservative methods of treatment like medical measures for gastroparesis?
She was on, no sir, she was on medications, PPA and prokinetics for a longer time. As I said, one point of time she was like, thought as a functional, and even the family members was forcing her. So she was desperate of all this thing. So she wanted something permanent, and apparently there was some holidays there with them. So they wanted to finish in that particular time. So we gave options, like you can be on medication and see. But she has been trying for a long time, so she...
Was she diabetic?
No, she's an young, otherwise healthy lady.
The one last comment actually, sometime you can do a balloon dilatation.
Yes.
The patient is responding, then G-poem.
Yeah. Previously, surgeons used to do that. I didn't believe that, but now I should start believing that you can do it. But balloon dilatation is, you saying you can do a balloon dilatation for achalasia. So you are seeing the muscle and you are cutting, whereas in pyloroplasty, using a balloon, you are blindly doing that. Then we have to go back and do a balloon dilatation for achalasia.
Thank you.
Thank you.
Dr. Veena?
A 40-year-old male presented to us with CBD calculus and cholelithiasis. Patient underwent ERCP followed by lab code. He came to us for stent removal after 4 weeks. Ultrasound abdomen at the time showed a retained CBD calculus. However, CT showed the calculus adjacent to the stent, suggestive of a cystic duct calculus. We have advised him a revision cholecystectomy. However, patient doesn't want any more surgeries. He wants to do some endoscopic therapy. So we have went ahead with ERCP and stone removal through spyglass. We have cannulated the common bile duct. The vent gone through the CBD and intrahepatic biliary radicals. Then we selectively cannulated the cystic duct. You can see the remnant gallbladder. Then we have used a spyglass to locate the stone. We cannot put a balloon as there is no space proximally for the stone to come out. Here we are introducing a spyglass through the wire into the cystic duct. You can clearly see the cystic duct here. Now we can see some stone remnants with the stone proximally. We are using a spyglass DS scope from Boston. Then we have removed the guide wire. We thought of putting a basket, but we have decided to remove it with the snare. We felt that the stone was not impacted, so it can easily come through the snare. Now the snare is open. We are trying to catch a stone with a snare. Now we have got the stone using a snare. Then we gently pull this stone out into the duodenum. We have encountered some difficulty in retrieving the stone from the ampulla, but with some maneuvers, we have got the stone out from the ampulla. This is an endoscopic picture of the ampulla post-removal and the stone picture. Then we cannulated, did an occlusion cholangiogram, and everything was clear. Thank you.
Thank you, Veena. Why you didn't use normal wire and balloon for extraction?
Uh,
When do you use it?
The stone, I mean, the surgery was done 1 month back, sir. I mean, the stone was in the proximal, I mean, remnant gallbladder. So inflating a balloon, we thought like there may be a cystic duct blowout. So I mean, there is no space for this balloon to go proximally to the stone. So we have decided to go for a spyglass and a snare technique.
Thank you, Vinod. For short of time, I think we need to move on. Not there, Dr. Rabindranath.
Greetings everyone, I am Dr. Rabindranath. We shall see a case of difficult CVD calculi treated with laser lithotripsy. 49-year-old female presented with jaundice, fever with cells, pain, abdomen and hypotension. She was diagnosed to have choledocholithiasis causing cholangitis. MRCP showed multiple gallstones and multiple bile duct stones, largest of 2.2 centimeters. So she underwent ERCP and pus was extruding from the papilla. Cholangiogram showed grossly dilated biliary system and multiple filling defects and a large impacted calculi in mid-CVD. Mechanical lithotripsy attempted but failed. So in view of cholangitis, patient was drained with biliary stent and patient improved with the standard of care. The patient underwent repeat ERCP after 2 weeks for CVD stone clearance. This time, balloon sphincteroplasty was performed and balloon trawling yielded multiple small calculi with biliary slits. But still, there was the large impacted calculi in the mid-CVD. Patient underwent cholangioscopy spyglass DS showing an impacted calculi. Using luminous laser, chromium YAG laser, lithotripsy was performed. 550 micron laser fiber was used. The light beam focused on the calculi. Stones are fragmented. After adequate fragmenting and dusting of the calculus, multiple successive balloon trawlings. The ductal clearance is confirmed with the cholangioscopy. We can see the fragmented calculi. So after the confirmation of the clearance, a plastic stent was placed in the bile duct. No procedural complication noted. Impacted stones in CVD and larger stones greater than 15 mm are important factors for incomplete extraction of the CVD calculi. With the advent of cholangioscopy, we have two lithotripsy techniques. EHL uses shock wave emission technology. Laser lithotripsy works by focusing high power laser on the stone. The concentrated power of laser creates a plasma of ions and electrons that forms waves which fractures the stone. Chromium YAG laser from Luminous is being extensively used in urinary tract stones, is approved by FDA for bile duct stones now. Systematic reviews that we can find says ductal clearance is 95.9% for laser lithotripsy compared to 88.4% in electrohydraulic lithotripsy. Conversion to surgery is lesser with laser lithotripsy. A prospective trial showed laser lithotripsy was not inferior to that of laparoscopic common bile duct exploration for large common bile duct stones. Clearance rate was equal, though some cases required recurrent laser lithotripsy sessions. Complications were lesser, shorter hospital stay. So advantages of laser lithotripsy are higher stone clearance rate, lesser procedure time, lesser fluoroscopy time, lesser median hospital stay, and post-procedure complications are comparable or lesser than conventional methods.
Thank you.
Thank you.
Doctor,
for
what
your
is the
valuable
setting?
time.
What is the setting you use for lithotripsy?
Sir, it is 0.5 joules actually. That there is a technician routinely uses the same for the urology stones. we have used 0.5 millijoules actually.
But what is the frequency?
It is 2100, sir. Actually, frequency, they have a prefixed setting for the stones. They are routinely using for the renal calculi. That guy actually, he has calculated how much total energy to be used, etc. Yes, sir.
Thank you, Doctor. We
Yes.
move on. Dr. T.K. Anand.
I'm Dr. Sadgun Rao, DNB registered from Apollo Hospital, sir. Dr. T.K. Anand could not make it to the podium in time, so I'm representing him on behalf of this, sir. So, this is regarding 74-year-old male presented with painless jaundice, itching, and weight loss. And on endoscopy, we found a noduloproliferative lesion at D2 with luminal narrowing, and scope could be negotiated beyond. So the biopsy showed a well-differentiated ampullary adenocarcinoma, and then it was found to be metastatic disease because there were 2 pulmonary metastatic nodules, and the biliary system was dilated on CT and the bilirubin was 12, and we planned for a palliative chemotherapy on this patient. So we tried a transpapillary drainage by ERCP, but ampulla was distorted and we could not cannulate the ampulla. And the other options we have was percutaneous drainage and endoscopic ultrasound guided both Rendavu and intrahepatic and extrahepatic procedures. But we, after discussing with the patient, and we opted for endoscopic ultrasound guided extrahepatic biliary drainage. Initially, we tried to access the bile duct from antrum, but we could not get a good window because of the vasculature and an intervening bowel loop from the antrum. So we tried from videos. Okay. So we came from, we went to the D1 duodenal bulb station. We could see the dilated bile duct along with the gallbladder and cystic duct. So from duodenal bulb, we used Boston Scientific 1 centimeter hot axios system, and we punctured the bile duct. We punctured the bile duct, and the first step was deployment of the internal flange of axios system. Once it was done, then the next step would be deployment of external flange. But before that, with the deployed internal flange, we try to oppose the both duodenal bulb wall and CBD wall. We confirm the position of internal flange, and then we deployed the external flange. We found the free flow of bile from CBD into the duodenal bulb. And this is in difficult ERCP times. This is EUS guided choledochoduodenostomy. And there were no periprocedural complications, and after that the patient was given chemotherapy, but he survived till 6 months till now. Thank you, sir.
What is the type of stent you used?
Hot axios Boston Scientific stent, sir. 1 centimeter lumen diameter and 1 centimeter length of the.
It opposes the bile duct to the duodenum?
Yes.
Opposed?
This is a lumen opposing the metal stent, sir. Yes.
you leave a plastic stent inside that? Double
No.
picture?
No, sir, we did not leave a plastic
When
stent
the
inside.
duct collapses, the internal wall will go and hit the other wall.
Yes, sir, but even in the case series where the US guided choledochoduodenoscopy was done, they didn't advise the plastic stent to be deployed. The only issues were post-procedure, there were lumen obstruction due to the food residue. This they noted, but we didn't find such issues.
Thank you.
So,
Thank you, Doctor.
Thank you, sir.
Dr. Kandasamy.
Good afternoon, everybody. I'm really happy to be here for the second time in a row, the Tamil Nadu chapter of TNISGCON. In our department, we have, I'm presenting this procedure of pyloric stems on stems. And actually, this patient, 49-year-old, were presenting with gastric outlet obstruction due to malignancy, gastric carcinoma, which is inoperable. So, initial procedure was I planned a pyloric stent, self-expanding metal stent, which is a evolution stent, which is 12 centimeters in length. I deployed a guide wire across the stenosed part, and the stent was first self-expanding metal stent was deployed across the narrowing, and the stent was deployed, and the position was confirmed by C-arm. It is well expanded, and the patient was symptom-free for nearly 5 months. And later on, again, he came back again with subsequent stent occlusion. So we tried all the other maneuvers of dilating the stricture part, but it failed. And endoscopy confirmed as a tumor ingrowth into the primary stent. So we planned for the next, no other option for dilatation of this occluded stems. We planned for another stems on a primary. Secondary stems was deployed. Again, the guide wire is placed across the primary stent, and again the duodenal evolution stent, which is about 9 centimeter length with a 22 millimeter diameter, which is deployed again into the primary stent, and safely it was deployed, and the patient is given only a minimal sedation of IV midazolam. And the second self-expanding metal stent was deployed safely. Yeah, there we go. Yes. So again, immediately that is the distal portion, that is the occluded portion, the stasis. You can see the fluid coming out of this opened up expanded metal stent. So in a resource-limited setting, in a government institution, it's kind of procedure give a lot of morale boosting for the interventional gastroenterologist. You can see the fluid coming out from the distal portion of the expanded stems. So thank you very much for giving this opportunity.
Nice presentation, yes, Professor Kandasamy.
Thank you, sir.
My only question is, when you think a patient can live for at least 6 months or more, would a surgical bypass be more prudent?
Actually, the patient is not fit for surgery, and the surgeons are not ready to operate upon this. And another thing is the patient was actually the stent, the slide has quickly passed on. Actually, initially underwent a feeding jejunostomy, and this whole thing is infected. Entire anterior abdominal wall is, there is abscess formation is there. We have to give a lot of antibiotics for getting resolved, and subsequent operating upon this laparotomy is impossible. So we have to, only option available is endoscopic management.
So generally, if pyloric stent is done for CA stoma, the average patency is only for 3 months.
Yeah.
And in fact, they advise you to relook after 3 months, and if there is an obstruction, elective stenting can be done. But anyway, your setting is resource limited place. You can do it only on. Thank you.
Thank you, sir. Thank you.
Dr. Nikhil Kenny Thomas. Dr. Nikhil? Dr. Gogul.
Thank you, Tamil Nadu ISG, for giving me this opportunity. I bring warm greetings from Net India Hospitals. A 61-year-old obese woman with a BMI of 44 was admitted with 6-month history of recurrent upper abdominal pain and dysphagia. She had a laparoscopic adjustable gastric banding procedure in 2004 for obesity elsewhere. This is the endoscopy showing at J maneuver the eroded and migrated gastric band lying hugging a cuff of mucosa at the level of cardia. She had endoscopy elsewhere. They tried to remove the band, but despite repeated attempts, it could not be removed. And she was referred to us for further management. A CT scan showed a ring-shaped foreign body attached to the gastric cardia. A video also shows the ring-shaped foreign body, the band actually, which is almost extending up to the level of serosa. We tried to catch the band, but it kept slipping. We searched the literature. There is a dedicated device available which is called the gastric band cutter, which needs to be imported and a bit expensive. So we thought we would use a guide wire to cut the band with the help of a mechanical device, the Sohendra emergency lithotripter. Before I show the video, a short animation of what we did. This is a migrated gastric band attached to the cardia region. We passed a guide wire in front of the band so as to loop it. We used a lithotripsy cable and a mechanical lithotripter to cut it, and this is how it appeared. So this is endoscopy video of the procedure. This is a migrated and eroded gastric band which is hugging a cuff of mucosa at the level of cardia. We passed a guide wire in front of the band. Keeping the wire in situ, we removed the endoscope, and then we went again, used a biopsy forceps to pull the guide wire so as to make a loop, which is verified by a J maneuver. You are seeing the loop there. Both ends of the guide wire was then secured to the emergency mechanical lithotripter through the lithotripsy handle or the lithotripsy cable which you are seeing there. So as we tightened, the lithotripsy cable went up to the level of the gastric band, which is verified at fluoroscopy, which you are seeing on the right side, and also with endoscopy, which you are seeing on the left side. You are seeing the metal cable which has gone up to the band. We also verified it when we are removing this bolt. This is the handle. So as we tightened it, we cut the band. This is how the cut end appeared. We removed the lithotripsy cable. The next step was to dislodge the band from the stomach wall. We used a snare. In the antegrade position, we couldn't get a hold. So in the retrograde position, we caught hold of the band using the snare. We tried to pull it, but it did not get dislodged. So we had to push the endoscope up to the level of antrum so as to dislodge it. On the right side, you are seeing the dislodged gastric band lying in the antrum. We then pulled the dislodged band out. A check endoscopy was done subsequently. There was no evidence of obvious perforation except for a bit of this band which is adherent. We pulled it out. The whole procedure was done under carbon dioxide insufflation, and we also had the surgical backup in case the patient developed perforation during the procedure. Subsequent day, she underwent a CT scan with oral contrast. There was no evidence of leak. Thank you very much for your patient listening.
Thank you, Chairperson. This is presented for the rarity because LAGB is not practiced nowadays, and the improvisation we used to remove the migrated and eroded band.
Obviously, patient was asymptomatic. Why did you do a CT scan?
Patient was symptomatic.
Asymptomatic after removal.
After removal.
Why did you do a CT scan?
Just want to document it, sir, to make sure that all the parts has actually come out while pulling that eroded band out.
Thank you, doctor. Thank you. Dr. Tirumurthy.
Thank you, sir.
This is one of our one large duodenal neuroendocrine tumor that we have done ESD. That is why I am going to present. Our case is a 62-year-old male. He presented with a vague upper abdominal pain and chronic constipation in one of the elsewhere in one hospital. Evaluated, endoscopy done. There was a large 2 to 2.5 centimeter well-differentiated neuroendocrine tumor, grade 1. CCT abdomen done outside. That was a lesion in the D1 as well as non-enhancing hypodense lesion in the liver. Further, he came to Cancer Institute where Dotanac scan was done. That has showed the duodenal lesion Krenning score of 75. It is more suggestive of neuroendocrine tumor, whereas liver lesion is Krenning score of 1. It is not suggestive of neuroendocrine tumor. And the case was discussed in the tumor board, and the surgeon decided the liver lesion is only, it is not suggestive of neuroendocrine tumor, and the duodenal lesion is too small for a surgical resection. So it was decided to go for a endoscopic resection. This was the lesion in the anteroinferior wall of the duodenum, close to the D1-D2 junction. We did with a dual knife J. We started with the endoscopic cap and dual knife J. As per the standard methods of ESD, first we have done a marking 5 mm away from the lesion all around. The main difficulty we have faced is mainly the maneuverability, especially with the hood in the duodenum, and second was the peristalsis. So we have used a buscopan to reduce the peristalsis. And sometimes whenever that maneuverability difficulty, we have to remove the cap, and without cap sometimes we have gone, especially on the distal part and other parts. And we have started the dissection as per the standard, this thing, injecting submucosal injection using jello fusion with methylene blue. And we started, initially we thought of dissecting from the distal side, but the maneuverability at the distal side was a little difficult. So we started the dissection from the proximal end. Mainly the positioning the scope and dissecting and moving the scope was a little difficult at the duodenum. And second thing, the duodenal wall is very thin. So we have to this thing. Another difficulty what we have faced is the biopsy was taken once outside, and again the biopsy was taken in the Cancer Institute. Look for the IHC markers and other thing. So because of biopsy done twice, we have anticipated fibrosis in this where the biopsy site was. And also there's a thin duodenal wall, very thin muscle layer that has given us a lot of challenge. While dissecting, because of fibrosis, the muscle layer was adherent. So some places the muscle layer, the muscle layer came out along with the submucosal layer. We had only the peritoneum left in that places. And usually the neuroendocrine tumors, we anticipate a lot of bleeding will occur during the dissection. But fortunately, in this case, we did not expect any bleeding, but we had anticipated the fibrosis. And we have dissected all around. Whenever we went in the distal part, sometimes we have to remove the cap, and we did the dissection. And complete resection was done, and there was 2 to 3, there was a muscle was injured and attached to the submucosal plane. And after the resection, it was a large raw area. It was like a diamond-shaped raw area. Then the bleeding points were coagulated with the coagrasper. And the entire lesion was removed en bloc with adequate margins. This is the raw area after the resection. And we have closed the raw area with the clips, but actually it was in diamond shape. So first, using dental floss and the small clips, we approximated the widest part of the raw area. Then we use the resolution clips to close. We have used 6 clips to close this thing. This is the images of the one. This is a raw area. After the resection, there was a large raw area with the muscle injury, and we have closed it. So biopsy almost 2.8 centimeter in size. And it was R0 resection. All the horizontal vertical margins were free. The follow-up endoscopy, post-procedure, patient had no complications. There was no leak, absolutely uneventful recovery. Patient discharged on 4th day. After 1 month, we did an endoscopy. The site was scarred, and except one clip, all the clips are passed out. There is no duodenal obstruction. Thank you.
You didn't show us the histopathology of the resected specimen.
Histopathology?
Yeah, you should.
Yes, I should.
I'm sorry, was it complete?
Yes, it was complete, sir.
Was the Ka index checked?
It was both horizontal as well as vertical margins were clear of the tumor.
Ka index?
K index 2%.
Thank you. It was daring. We'll move on to the next presentation.
Okay, thank
you. Dr. P.L. Alagamai.
Good afternoon, everybody. Not all patients are affordable for a cholangioscope. Not all centers will have cholangioscope. We don't have a cholangioscope. Here I have a 79 years old poor village lady who came with recurrent cholangitis, treated conservatively outside for many times, and had an ultrasound abdomen documenting multiple CBD stone, and he had a laparoscopic cholecystectomy done 10 years back. Yeah, play. So there is a GJ. As we enter with a sidewing scope, what we see here is a good wide GJ, then a duodenal narrowing. There is a stricture at the D1, D2 junction. We advanced the wire, confirmed with the fluoro, and then dilated the D1, D2 stricture with the 15 millimeter CRE balloon. This has to be done because patient is in cholangitis. Somehow we have to decompress the biliary system, so the duodenal obstruction is not a hurdle. So CRE balloon dilatation was performed. Then we could enter into the duodenum, D2. After positioning the ampulla, a good cannulation was accomplished. It was a smooth CBD cannulation. Once cannulation was obtained, the cholangiogram was taken. Cholangiogram shows an abnormal right hepatic duct. It actually the right posterior sectoral duct opening into the lower CBD. So this is an anatomic abnormality which may be seen in up to 20% of general population. There are multiple stones not only within the CBD but also within the abnormally opening right hepatic duct. Both the ducts are dilated well. So the right anterior branch is free of any stones. So wide sphincterotomy was obtained. Then CBD was cleared with multiple balloon sweeps. The wire was repeatedly entering only into the CBD and it was not entering easily into the right hepatic duct. CBD was cleared, multiple stones were removed, and the final balloon sweep was clear. Repeated attempts were made to enter into the right hepatic duct in order to clear the duct, but the wire was repeatedly entering only into the CBD and not into the right hepatic duct. Multiple accessories were used, the balloon with the dilated balloon as well as a sphincterotome and a cannula. We could not enter into the right hepatic duct. Further sphincterotomy was extended with needle knife so that we could enter into the right hepatic duct. It was appearing so that the RHD was opening into the lowermost CBD just above the ampulla. So further sphincterotomy would help for entering into the right hepatic duct. But however the attempt failed, so we decided to stent the CBD and then try a precut sphincterotomy followed by RHD stenting. So further sphincterotomy was done with the needle knife after stenting the CBD. A good pre-cut was done, sphincterotomy was extended, and we succeeded. We could cannulate the right hepatic duct after extending the sphincterotomy in the side of the stent. The presence of stent gave us a good view of the sphincter, so we could enter into the right hepatic duct finally. So wire was advanced. The stones could not be removed due to the very narrow opening at the end. So sphincterotomy was further extended using a sphincterotome, and then sphincteroplasty was done using a hurricane balloon. So once a wide opening was accomplished, we could do good balloon sweeps. So this is a sphincterotomy followed by good balloon sweeps and clearing the right hepatic duct. So multiple stones were retrieved, lot of sludge and muck retrieved, and the final balloon sweep was clear. So then the RHD was separately stented with a stent protruding out of the ampulla adjacent to the previously placed bile duct stent. So this is the final appearance of the two stents. So they were parallelly placed, and this is the fluoroscopy picture showing the position of the two stents. So I am not sure whether we are dealing with the first C2 anatomy of right posterior duct opening, or whether it is a right posterior duct opening into the cystic duct directly. So here I am showing the cholangiogram of the patient taken during stent removal. So this is a rare anatomic abnormality which was appropriately tackled, and the patient was saved from cholangitis. Thank you. Thank you.
Thank you, nice presentation. But you gave us an impression that the right hepatic duct opened separately into the papilla?
No sir, it is opening at the lowermost end, which could not be cannulated, so I had to cut the ampulla and then enter.
You are using, did you not get an impression that it opened separately in the papilla?
When I did first time ERCP, I thought like that only.
Appearance is different.
So first ERCP, I thought it is opening in the ampulla, sir. During the ERCP stent removal, the occlusion cholangiogram looks like, I think there is an overlap, more of an overlap in the occlusion cholangio.
Thank you, thank you.
Thank you, sir.
I think, Nikhil Thomas, yeah. I think we have come to the last case. We'll end the session and give the mic to the organizers.
We will adjourn for lunch and we'll resume the session back at 2 p.m. Postgraduate students who are in e-poster session, kindly proceed to the e-poster hall immediately. Postgraduate students who are in e-poster session, kindly proceed to the e-poster hall immediately. We will resume our sessions back at 2 p.m. The next session is Liver and Upgrade Session 1. The chairperson of the session are Dr. A.R. Venkateshwaran, Dr. N. Murugan, Dr. L. Thayumanavan, Dr. A.S.A. Jagannathan. I request all the chairperson to, and also Dr. Swati Gaju to take the chair on the dais.
Talking the first talk. Hello. Even if there's one people in the audience, previous Doyne used to say your talk. Now the post-lunch session, after exciting videos, we are grounded low. Whatever flying high, we are grounded to the level. The liver is a basic So cheese giver, or it can be given bread and butter probably. It's none other better than person like Professor Eapen to talk on the newer definitions of cirrhosis. I am as eager as you, like you, to hear about the latest updates. I don't want to stand between yourself and Professor Eapen. Eapen, sir.
Thank you for the kind introduction. The topic for post-lunch session is cirrhosis. Hopefully it is not soporogenic, and I can give you something to keep you awake. So I was not sure what this topic is about. Anyway, I assumed some interpretation, and you'll have to bear with me. So they say if you find it difficult to treat a disease, rename it. And it's happening today morning. Functional bowel disease got renamed, or someone was. So it's a common phenomenon in all parts of medicine. Is that what it is? So some newer terminologies have come in this chapter of the book of chronic liver disease, CLD and portal hypertension. And this is mainly from, I'll be referring mainly to the Baveno 6 guidelines. Now Baveno is one town in Italy where experts meet together and come up with new names all the time and cause controversies. So in this particular series, there are 6 such interesting terms. I'll be focusing only on the first 2, but the ones I'm glossing over are, they've introduced terms like first decompensation, further decompensation, cirrhosis recompensation, and portosinusoidal vascular disorder, which I think to me sounds like it is NCIPH, non-cirrhotic portal hypertension. But that's European English. But I won't go there, and I'll stick to the first 2. So I was asking Kaushal how to pronounce the first one. Should I say CACLD or CACLD? I'll agree with Kaushal. We'll say CACLD. Sounds more dignified. So what is this confusing term of compensated advanced CLD? So preparing for this talk forced me to read through it. So let me share my thoughts with you. The second one is about clinically significant portal hypertension. So some of the students are here, others are still at lunch. So examiners are fond of asking in liver case, is it? And such questions come. So I'll tell you my version of the answers. So when do I say there is portal hypertension at the bedside, in a clinic, in the exam? So it's history of upper GI bleed, sounds like possibly a variceal bleed, splenomegaly and ascites. That's what I'm thinking of when I say in the exam portal hypertension. When do I say cirrhosis? When the person has got peripheral signs of liver cell failure and either a shrunken liver on examination or an enlarged nodular liver. When do we use the word liver decompensation? It's either ascites, encephalopathy. Some definitions use variceal bleed, and some say jaundice in a non-cholestatic disease. So these are sort of the answers which generally, currently the deciding pass or fail in the liver exam. So when would I use the word CLD? In fact, I remember in one exam, some part of India, my co-examiner was extremely angry with the student. Why are you saying CLD? He's not happy with the word CL. But it is true that we all use the word CLD. It's part of our lingo, and now Baveno is legitimizing it. It's come back as CACLD now. So why do we say CLD? So this is my interpretation till I read Baveno 7. So when we say CLD, we are including a non-cirrhotic disease. Now in India, that is one significant proportion. So that is why when we have a liver disease, it's intrahepatic, it's not EHPV, it's not portal vein thrombose, it's intrahepatic. We have 2 classes of either cirrhosis or non-cirrhotic portal hypertension. It's got its own different terminologies. We've been championing NCIPH as a word. So these 2 together is CLD. Now, usually NCIPH is compensated for most people. So now coming to the topic of the talk per se. So the newer terminology with Baveno 7 has used the word CACLD and clinically significant portal hypertension. So this now terminology is getting a bit confusing, and I suspect even for the exam now the questions will get a little more confusing accordingly. So I'll have to take a little while to explain the confusion in my understanding. So 10 years ago, some experts wrote, and in fact one of the authors has now died, Andy Burroughs is one of the authors of this paper, very interesting paper. So they said that we are treating cirrhosis wrongly. So they say that the last line, treating the prescription form for a patient with cirrhosis will become like the form drugs prescribed for coronary artery disease. So you know one pattern of drugs are given for, so there'll be some aspirin, there'll be some statin, there's one package. Cirrhosis will become like that. So they predicted this 10 years ago. So they said, they were pointing out the fact that early cirrhosis, the death rate at 1 year is 1%, while with decompensated cirrhosis is 57%. So the change in paradigm is to prevent complications rather than treat complications, which means try to maintain the patient in a phase of compensated cirrhosis. And they suggest that there are already enough evidence in literature that these 4 drugs will be our equivalent of aspirin, statin, etc. in the coronary artery disease. So 10 years ago they felt it's going to be propranolol, simvastatin, norfloxacin and warfarin. I must say this article stayed with me, and I may tend to overuse these drugs, but for a few patients I am having a go, thinking that maybe it is changing natural history, primarily with propranolol, norfloxacin. Those are the drugs which I have been using. So, Baveno 7 primarily talks about, the last line, the bottom line here, can we measure portal pressures in the outpatient clinic? That's the question. So it's like saying we have blood pressure measured, BP apparatus, and can we use these non-invasive tests, which are liver stiffness measurement, that's LSM, by transient elastography, which usually is done by fibroscan or RF scan, or platelet counts. So using LSM and platelet counts, can we, at the outpatient clinic, make a diagnosis of, can we detect CLD and portal hypertension? So I was just thinking that through. Currently in the outpatient clinic at Vellore, the patients come in, so then they are seen by a nurse who checks their height, weight and blood pressure. Then only they come to the room. While I went to Dr. Acharya's hospital in KIMS, in Kalinga Institute in Bhubaneswar, where that step includes LSM measurement. Then only the patient comes to see the doctor. Will that become the norm for all of us? Is there a grounds for that? That's the question. Now, if that is going to happen, a big change will happen now in practice all over. It's had its own implications. So that's what I think is this topic. So can we use these point of care tests, which are non-invasive tests, for CLD and portal hypertension? And primarily these two. One is the LSM measurement, and 2 is platelet counts, instead of the invasive tests. The invasive tests primarily are HVPG for portal hypertension and liver biopsy to make a diagnosis of cirrhosis. So we know that the number of centers which can do, and even in those centers, the number of patients who undergo these tests are going to be very little. On the other hand, if you open out these non-invasive tests, surely everywhere this will start happening. So that is the proposal by Baveno 7 this time. Now when we do blood pressure recording, and all of us are familiar with this, the reading is 120 by 80 millimeters of mercury. While in the venous system, it is much lower. So on the BP apparatus, it will be like very low, 1 to 20 millimeters of mercury. So that is where the action is. So we have to register that in our heads. So while in arterial BP, it's the map is like 80 millimeters of mercury. Here we're talking about very low levels of blood pressure. And on HVPG, these have been well studied. The normal HVPG is 1 to 5 millimeters of mercury. When it's more than 5, that is categorized as sinusoidal portal hypertension. And when it's more than 10, varices are starting to form on endoscopy, and that is termed as clinically significant portal hypertension, or CSPH. Now this definition is, there's no controversy. It's fine, and we all accept that. And as the portal pressures increase, the outcomes or the chance of complications and chance of death is increasing. So now, the question from Babino is, can the liver stiffness measurement and platelet count replace HVPG? What do you think? I'm not asking for raise of hands, but I'm telling you what the Babino 7 guys say. Must be men and women say. They say yes. They say that the non-invasive test, I'm reading it out from the bottom now, the clinically significant portal hypertension is a HVPG driven concept. However, the non-invasive tests of liver stiffness measurement and platelet counts are sufficiently accurate to identify clinically significant portal hypertension in clinical practice. So that is the statement which has now come out from Babino 7 after analyzing the current data. Second question, can these tests replace liver biopsy? Now, they have brought out rule of 5. So they say the kilopascals, if it is 10, 15, 20, 25, those are the ranges which they say can help stratify patients into risk of decompensation and risk of death. And they recommend that invasive tests like biopsy and HVPG can be done at referral centers in individualized manner. So this is how the recommendation is going. So one can anticipate that very soon this phenomenon is going to change of how we do the outpatient diagnosis on non-invasive tests. Now, if this is true, but we do not know how it will go, but this is a proposal now. Now, this part is a little more confusing to explain. This is CACLD. The other one was easy to understand, clinically significant portal hypertension. So I'm starting with the current understanding. If we took liver biopsy as the way of approaching the patient, so with biopsy plus clinical, under CLD would come chronic hepatitis and cirrhosis. While cirrhosis can be divided into, can be divided into compensated and decompensated. Now, advanced CLD is not based on biopsy, is based on liver stiffness measurement, and they say you can identify severe fibrosis and cirrhosis here. So they say compensated cirrhosis is where they're focusing on, that's what they want to intervene, is advanced CLD, which is compensated, that is CACLD. And that, by this rule of 5, can help us to categorize into no CACLD and highly likely CACLD by these numbers. Now, in a patient who's got CACLD by this liver stiffness measurement, is there portal hypertension? If the LSM is more than 25, the endoscopy is highly likely to show varices. Now, they bring in platelets now. If we have a low LSM and platelet count is low, the chances, platelet count, this must be high, I think, must be high. It rules out, this will be higher, rules out clinical significant portal hypertension, while the LSM being high, the varices at scopy are likely. In fact, now they have specified that for different etiologies. For example, there's a study called the Anticipate study, and they have some cutoff points for different etiologies using this combination of LSM and platelet count. So it is possible that we may be moving towards this in the near future. So then, so here's the second question thereby, do these non-invasive tests, which could be used in the outpatient, can they be used to diagnose cirrhosis? Here, they are a little circumspect. So they say both the terms CACLD and compensated cirrhosis are acceptable but not interchangeable. So they did not say it the same, but they seem to be acceptably, well, not interchangeable. So that's what they have used there. So this is how one diagram looks like, where they're bringing in both the LSM measurements as well as the platelet counts to try and categorize whether the person has got CACLD bar clinically significant portal hypertension. So now my wise thoughts on this. So about use of liver stiffness measurements and platelet count to use to diagnose early CLD in the outpatient clinic. Problem number one, it is bound to increase worry and mental strain in the patients. Already we find patients who are coming far distances and in a hushed voice tell us, I've been told to have cirrhosis. He's not able to bear that information. It's too much. So now we're going to increase it. We are now going to tell them this number is going to increase now, because now we're going to do liver stiffness for everyone in the outpatient. And we have to tell them it is not cirrhosis. Relax, it is only CACLD now. It's even more difficult to explain. So this is bound to be a problem. Now, how do I answer the question? It is cirrhosis. The person is telling in a hushed voice. So I tell them it's like diabetes. You approach it like diabetes. So you can control the problem, and it's a lifelong problem, etc. That's how I try to make them approach it. I think I would take the same stance here. The second problem is what I started with. So when we say CLD, in India, this problem of NCIPH is a problem. This is an Indian disease, and if we use only LSM as a measurement without a biopsy, bar HPPG, this is a problem. Now, this was work which Ashish worked on and published quite a while ago, where in our department, over a 1-year period, the commonest cause of CLD was cryptogenic. And of those patients who underwent liver biopsy, 50% had non-cirrhotic portal hypertension. So it is a fairly common problem with us. So that will be another confusion when we start introducing LSM as a measurement in India. So this is my last slide. So will this change patient management? What difference does it make if I say CACLD or cirrhosis? I think immediately no, it will not change. But it's likely to change. The moment we have some evidence coming out that newer interventions and some drugs were proposed 10 years ago, as I mentioned, which may change the natural history favorably, then this diagnosis would be useful. Thank you.
How far the LSM is reliable? Because done on the same patient, done by the same machine, done by the same technician, the value varies. At one stage it is 20, 23, after a month suddenly becomes 45. So how far the LSM is reliable? And second question is, cirrhosis with, advanced cirrhosis, compensated, suddenly developing portal vein thrombus, acute. Will you prefer no molecule with heparin or warfarin?
Okay. I'll have a go at answering them. So how far is reliable? I must say my experience with LSM is almost like nil. I do not know it as yet. But my viewpoint on it is changing. So what you asked, sir, are very valid questions, and they have been looked at, and there are now recommendations how the LSM should be done, as well as should it be repeated if you are in doubt, etc., and what are the norms to do it. For example, doing it on a fasting state is one example like that. But I'm just making us aware that it's quite likely that more and more in the outpatient clinic, we all may be starting to use it. So there are the recommendations on this to make it reliable and accurate, etc., the readings. Those have to be done. Should acute portal vein thrombosis be given anticoagulation or not? It's a separate question by itself. So if it's possible to give it, I would give it. The challenges are about a coagulopathy as well as presence of varicose bleeding. So those are the things to weigh in that situation. That's my
would you think that having fibroscan is a wonderful thing to happen to hepatology? Why you say so? If you detect a person coming to OPD and he has a fibroscan, LSM is 8, you start looking at etiology, treat etiology, and try to revert it. If you don't revert, it's going to 8 to 10 to 15, and likewise cirrhosis. So this is an opportunity that you can detect disease and reverse it by looking at etiology.
Thank you, Govind. Absolutely, I agree with you. I think that is the whole intent. The Baveno 7 says, let us try to catch this disease early. We all know that even for MBBS exam, massive splenomegaly, one of the differences is non-cirrhotic portal fibrosis, NCPF. But where was that patient when he had mild splenomegaly or moderate splenomegaly? Nobody picked it up. Even the patient didn't realize it. So we have to catch it early. Only problem is, as yet, there are no interventions there. We're only making a diagnosis and telling them, relax, you got early cirrhosis or early CLD, which is bound to increase one mental burden in the society. That's bound to happen. But it's possible. Along with this, some interventions will come. And what they proposed that time are those 4 drugs. They are beta blocker, propranolol, simvastatin, norfloxacin, and warfarin. That is what was proposed 10 years ago in cirrhosis. But some such interventions is likely to come.
Thank you, Dr. Epan. We'll call the next speaker, Dr. Trichy. He's going to deliver a lecture on NASH.
Good afternoon, everyone. Thanks to Dr. Ubal, Dr. Ravi, and Tamil Nadu ISG for inviting me once again to Trichy. I came here, I think, 5 or 6 years back, again for Tamil Nadu ISG. And it's really heartening to see that the hall is full as it was in non-hepatology lectures, and that too in the post-lunch session. So people are getting interested in hepatology, maybe because of people like Dr. Epan. So my topic is NAFLD in 2023. So let me start by disease burden, what all we've learned around this time and about how we can use it in 2023. So this was the latest meta-analysis of the burden of NAFLD in India by Dr. Shalimar from AIIMS, 23,000 adults. Earlier we used to, the teaching was 25% of the general population has NAFLD. But look at this meta-analysis, more than 23,000 people, almost 40% have NAFLD. And in high-risk patient, this is up to 52%. And more worrying is this. These are the people who are going to increase the burden of NAFLD in the society in the decades to come, 35.4% of children. And with the rise in childhood obesity, this is going to be almost 63%, which is huge. So this is a new learning here. Second point is fibrosis is the driver. We've been told day in and day out, histological NASH is the bad NASH. That is the one which progresses to cirrhosis. But recently we've learned that no, it is not NASH, but fibrosis which drives the disease. So this study of 619 paired biopsy-proven NAFLD followed for a median of 12.5 years. 193 had negative events. And the risk of death or undergoing liver transplantations were directly related to the stage of fibrosis. Dose-response relationship, as the stage increased, the risk of these complications increased. Another study which looked at it in a different manner, they divided patients who had at least F1 or F2 fibrosis along with steatosis. So steatofibrosis versus no steatofibrosis, the overall survival in presence of fibrosis was lower. But then when they divided the patient into histological NASH versus no NASH, no difference. So NASH is not the driver, fibrosis is the driver. That's why so much talk about LSM, what we heard in the previous, by the previous speaker. Coming to NAFLD, obviously it has not changed even in 2023, and still I think a couple of more years before newer drugs will be available. But what do we have now? So the principles of management remain the same. It is associated metabolic risk factors in all. We have to treat diabetes, obesity, hyperlipidemia, hypertension. You would fail. Just because you're a hepatologist does not mean you will not concentrate on this, because remember, patients are going to die of cardiovascular more commonly cardiovascular complications than liver-related complications, and patients who have advanced form of NAFLD, that is either histological NASH or advanced fibrosis, you should also concentrate on the liver. Coming to lifestyle interventions, this was one of the study from SGPGI by Dr. Gaurdas's group. 60 NAFLD patients who were made to do supervised aerobic exercise in their hospital for 30 minutes a day for 5 days in a week. 45 who complied to the exercise plan were able to lose their weight significantly, able to normalize their ALT, able to improve their insulin resistance and waist circumference. And this was the largest paired biopsy studies in patients of NASH who were undergoing lifestyle management. Those who were able to achieve at least 9% weight loss were the ones who had resolution of steatohepatitis. Those who had a weight loss of less than 3% were not able to reverse steatohepatitis. Based on this and other studies, they give this pyramid of weight loss. 3% weight loss, you lose steatosis. More than 5% weight loss, some improvement in inflammation. More than 7% weight loss, resolution of NASH. And more than 10% weight loss, 50% patients are able to improve their fibrosis. But unfortunately, only 30% patients are able to achieve or maintain a weight loss of 7%. So for them, if you really want to target liver, you have pharmacotherapy. And in 2023, these are the three concerns. So if you see a NAFLD patients, they have three concerns. They tell you, doctor, I have fat in the liver. Doctor, I have high ALT. Doctor, I have been told I have got advanced fibrosis based on the FibroScan. Although we all agree that histological improvement is the holy grail, but neither the patient nor the physician sees this. We are able to do biopsy in less than 1% patients. So both the patient and the physician also sees these three issues. And there are three categories of NAFLD patients you see. Those who have only fat in the liver, those who have fat plus elevated ALT, and those who have fat plus fibrosis. ALT may or may not be elevated. And incidentally, there are only 3 drugs in 2023 which are available in our setup: vitamin E, the PPAR agonist, and obeticholic acid. And you can also break down the pathogenesis of NAFLD into 3 steps. So the first hit is the liver fat, which progresses to necroinflammation and liver fibrosis. And if you are a follower of multi-hit hypothesis, there are a number of hits in between, like oxidative stress, inflammatory mediators, cytokines, and apoptosis, modified by these nuclear receptors, the interactions with these nuclear receptors, the PPARs and the farnesoid X receptor. So these are the targets which we have to use these 3 therapies. So let me start with the first one, that is the first hit, targeting the liver fat, and we have PPAR agonist for that. We are all aware of this saroglitazar, which is a dual PPAR alpha and gamma agonist. The alpha effect improves the plasma lipid profile. The gamma effect improves insulin sensitivity. And this was the first phase 2 trial which showed that patients who were given 4 milligram of saroglitazar, there was a significant reduction in their ALT as well as a significant reduction in their absolute fat. So much so that about 40% patients were able to reduce 30% fat. And this has been now touted as a surrogate to say that there would be a histological improvement. Those patients who are able to lose on MRI PDFF at least 30% fat are able to have a resolution in their NASH. So no need to do a biopsy, just repeat a MRI PDFF and demonstrate 30% reduction in fat. So this was the phase 3 RCT by Dr. Sareen. Unfortunately not published yet, still in the form of an abstract, 102 patients, 1 year of saroglitazar, and the primary endpoint of 2-point reduction in NASH were achieved more significantly in the saroglitazar group than placebo. However, no mention of reduction of fibrosis. We just learned that fibrosis is the most important thing, but unfortunately, saroglitazar, at least with 1 year of use, was not able to achieve this. Another study from India which looked at, again, LSM, since we are talking so much about FibroScan, and this over 24 weeks of use was able to demonstrate a significant reduction in FibroScan value with the use of saroglitazar. I'll just skip these and come directly to targeting oxidative stress, the second drug which is available, that is vitamin E. We are all aware of this PIVANS trial. Over 96 weeks of use, vitamin E 800 units per day was able to reduce significantly the ALT from baseline, and so was also achieved with pioglitazone. Unfortunately, when it was stopped, the ALT reverted to normal. So, the previous study, and everyone talks about that. People say that, oh, PIVANS study, the vitamin E was not used in diabetics, so we have no data. So now we have this RCT, pilot RCT in NASH patients who have diabetes mellitus, placebo versus vitamin E plus pioglitazone. And both vitamin E alone as well as vitamin E plus pioglitazone were able to normalize the ALT. And not only that, the proportion achieving more than 2-point reduction in NASH were significantly higher both in vitamin E and vitamin E plus pioglitazone group. And this is a very important study, although retrospective, in which vitamin E was used for a long term, at least 5.6 years. In the RCTs, it was used for 2 years. Vitamin E versus placebo, 19 patients each, 5.6 years of use. 2/3 of patients were diabetic, 2/3 were also cirrhotic. So vitamin E, can it be used in cirrhosis? This is also an oft asked question. So this study has used vitamin E in cirrhotics, and that too for at least median of 5.6 years. And they demonstrated that vitamin E was able to reduce hepatic decompensation, able to improve transplant-free survival, irrespective of whether patient was diabetic or non-diabetic. And not only that, all-cause mortality was also reduced in patients who were given vitamin E with number needed to treat of 4.2. So coming to this, a new drug which is available in the market, a different form of vitamin E called tocotrienol. Is it equally effective? We don't have much data, but the chemical structure of this compound suggests, the chemists say, the biochemists say that possibly it is able to exert a more positive effect in terms of its action as an antioxidant as compared to the standard tocopherol. It is derived from natural sources. It is 60 times higher antioxidant property as compared to tocopherol, and it also has some anti-inflammatory action. But we only till now have data from animals in which patients who were, the animals who were fed high-fat diet, along with tocotrienol, the risk of development of fatty liver was low. And an abstract which suggested that tocotrienol-based vitamin E therapy in NAFLD patients were able to reduce the LSM values. But still we need to collect more data before we can say that this drug is as effective or better than the standard vitamin E. And finally, the third problem, that is fibrosis. So that is obeticholic acid. So this was based on this phase 3 Regenerate trial. This was the midterm result. Month 18 interim analysis of placebo versus OCA 10 versus OCA 25 milligram. And patients who were given 25 milligram dose, there was an improvement in fibrosis by more than one stage without worsening of NASH as compared to 10 milligram and placebo group. There was a significant reduction in the liver enzymes, both ALT and GGT. Only adverse events were pruritus and a rise in LDL, both of which are dose dependent. In the higher dose, pruritus develops earlier as compared to in the lower doses. Patients who were in higher dose also had a higher risk of increase in LDL, but this did not translate into any negative cardiovascular event. And I don't know by what mechanism, by the time the patient reached 18 months, the LDL levels came back to their baseline levels. So, or if they were still elevated, patients could be given statins along with obeticholic acid. And this was now confirmed with recently presented data at AASLD 22, in which the Regenerate results were reread by 3 different pathologists. And again, they were able to reach the same conclusion that the 25 milligram dose was significantly better than 10 milligram or placebo in terms of reduction in fibrosis. More than 8,000 person-years of safety data. Again, in this particular study, the most frequent adverse events were at 25 milligram dose, and it was seen to be pruritus, modest rise in LDL, which returns to baseline within 12 months. All other adverse events were balanced between the two groups. I'll just skip this and come to this. So we have these three molecules available in the market as of 2023. What is the relative performance of these three drugs over these three parameters? So saroglitazar has a very good effect on lowering liver fat. Vitamin E also has been shown to reduce liver fat. By what mechanism, I don't know. OCA has no effect on liver fat. In terms of ALT, all three drugs are good in terms of lowering and even normalizing the ALT levels. Only OCA has been shown to improve liver fibrosis. Vitamin E in a retrospective study has also been shown to improve liver-related outcomes, which has not been shown by the other two drugs. In terms of side effects, these two drugs, Saro and vitamin E, appears to be safe, whereas OCA is associated with significant side effects. So what about future? Since we are standing in 2023, maybe a couple of years down the line, we will have newer molecules. So we must be aware of at least these 4 molecules. So we have anti-diabetics, specifically GLP-1 agonist, thyroid hormone receptor beta inhibitors, resmetirom, FGF21 targeting using efruxifermin, and pan-PPAR agonist called lanifibranor. So I'll just take you through the results of these studies. This is semaglutide. This was injectable semaglutide published in NEJM 2021 in patients with NASH, 72 weeks of 0.1, 0.2, 0.4 milligrams subcutaneous daily. And patients had significant improvement in their ALT. In fact, they normalized. And this kind of result we have not received with any drug so far in NASH patients. So resolution of NASH with no worsening of fibrosis, 59%. Almost 60% patients had could achieve this primary endpoint as compared to placebo. Second is lanifibranor. This was a pan-PPAR agonist, 247 NASH patients, 42% were diabetics, 800, 1200 milligram and placebo. And as you can see, all the endpoints, more than 2-point reduction in SAF score, resolution of NASH, improvement in fibrosis, resolution of NASH plus improvement in fibrosis, or were significantly better in the 1200 milligram dose. So these are the drugs to look forward to. I'll just finish last 2 slides. The efruxifermin, long-acting FGF21 analog, 28 milligram, 50 milligram placebo, and more than 1-point reduction in fibrosis with no worsening of NASH. This is also, up till now, has not been achieved by any drug. Improvement in fibrosis in 41% patients. This was presented in AASLD 2022. And this is resmetirom, again showing that significant reduction in liver fat, as well as non-invasive improvement in non-invasive markers of fibrosis could be achieved with this drug. So these are my last 3-4 slides of take-home message. So the most important treatment still remains lifestyle measures in all patients, whether patient has fat, ALT elevation, or liver fibrosis. Those who have just liver fat, normal ALT, no fibrosis, apart from this, nothing else is required. But still, if patient pushes you for reduction of fat, these are the drugs you can use. If you have liver fat with elevated ALT, no fibrosis, you can use either saroglitazar or vitamin E. If you have liver fat with advanced fibrosis, you can either use a combination of saro plus vitamin E or OCA alone, off-label use, or a combination of OCA plus saroglitazar. Thank you for a patient hearing.
Kaushal, you have covered everything. Can we combine OCA with simvastatin to overcome the hyperlipidemia?
Right. So even in that phase 3 trial, they had used statins to be combined with OCA for patients who had a rise in LDL cholesterol. But they mention, even the subsequent studies say that the LDL level comes back to normal even if you don't give statins.
Older question. pain reduction compared to drugs, can you have forget bariatric surgery? Does it spell doom or gives good result?
The question is that
Forget bariatric surgery. I am asking only forget bariatric.
for patients with NASH.
With NASH.
So up till now, it is not recommended. All the bariatric surgery study do show improvement in NAFLD as well as NASH as well as fibrosis, but it still is recommended for obesity, but not for NASH as of now. But I think in future with more studies, this will become one of the treatments.
What about the duodenal ablation?
So I think in the same manner as bariatric surgery, since most of the obesity arises from the hormones which are produced or incretins and anti-incretins produced from duodenum. So duodenal ablation also works in the same manner as foregut bariatric surgery.
Sir, in your experience, what is the duration of vitamin E or saroglitazar that you have followed?
So based on the trials, vitamin E can be used for 2 years, 96 weeks, whereas the longest which saroglitazar has been used in this phase 3 study is 1 year. But along with that, you have to encourage the patient to lose weight. You cannot give these medications lifelong. Statins only to treat dyslipidemia, but statins not to treat NASH. So NASH patients, if they have dyslipidemia, an indication to use statins, yes.
Thank you, Dr. Kaushal.
Thank you so much.
I invite Dr. B and C, where we stand.
Morning itself to joy. Whenever a C is involved, we take only 15 years, 20 years. When they ask the God, when we will get the eradicate the B, God started crying. In my lifetime, I don't think it is the end of the B. I hope joy shows some light on this aspect.
Good afternoon to all. So at the outset, my sincere thanks to Dr. Ravi and the Tamil Nadu ISG Trichy chapter, all the organizing team member, and the Tamil Nadu ISG, the parent body, Dr. Ubaldas and the team. So the topic is now the hepatitis B and C, where we stand. So what I have done here, so what we know about hepatitis B and C and what is new, that's why I divided. So first we will go into the hepatitis B. So we know the Hep B, the immune tolerant, this is nomenclature, we know what we know. The immune tolerant means ALT and the histology will be fine, but the patient he have EAG positive, viral load will be very high. Inactive carrier used to write, that time all EAG will be negative and the DNA level will be low, ALT as well as that histology will show normal, that is we used to write. And this we know, HBeAg positive chronic hepatitis B, HBeAg chronic hepatitis B. So at present, the nomenclature is slightly changing. So we are not going to use the inactive carrier, the word, and also we are not going to use the immune tolerant. So here they are using the chronic infection. So the chronic infection, either EAG positive or EAG negative. So that means ALT is normal, histology also normal. So HBeAg, chronic infection, means that time if the HBeAg chronic infection, there is immune tolerant phase. Same thing, HBeAg negative chronic infection means there is inactive carrier. So only the 4 diagnoses, this is without cirrhosis. So without cirrhosis, whenever in the clinical, the diagnosis based on the patient's lab report, ALT normal, histology normal, and the EAG and the HBV negative mean that is called HBeAg chronic infection. And this is the new what we have to start to write in our practice. So what we already know, this is the hepatitis B virus genome, you know very well. There is that DAN particle means whole virion. So this have the capsule and the core antigen and the DNA. So if you see the right corner, this DNA have the 4 open reading frame and which will produce the 7 proteins. If you look the colors, we can know there are the 7 different colors has been incorporated in the open reading frame.
So these all, in practice, day to day, we are not using. I'm coming to what we know later on. So the open reading frame, this is produced from the DNA particle. So the open reading frame, yes, it will produce the surface antigen. Open reading frame P, it will produce the polymerase, the DNA. Open reading frame C, it produces the core antigen and the E antigen. Open reading frame X, it is for the active replication of the virus as well as the tumorigenesis. So if you look into the DNA, what we know, the surface antigens capsule, the core and the DNA, but it shows the 4 open reading frame which produce the 7 proteins. Again, what we already know, the DNA, whatever in the previous picture, that is called the relaxed circular. But once the DNA enters, that means the hepatitis B virus genome, the DNA enters into the nucleus of the hepatocyte, the relaxed circular DNA is converted to the cccDNA. So covalently crossed circular DNA. Once the circular cccDNA forms, it has the potential to produce the genomes for all the structure of the whole virion. There are 2 types. One is the PG genome, which produces the polymerase, and another is the SG genome, which produces all the protein. So in simplest way, I can say, once the virus enters the hepatocyte, once entered the nucleus, then RcDNA, relaxer is going to cccDNA. But here, the cccDNA, 2 forms. One, it will be in isolated form within the hepatocyte nucleus. Another cccDNA will integrate with the hepatocyte genome. That's called integrated genome. So these all, that's why very difficult to clear the virus. Whatever we are using, that oral antiviral drugs, lamivudine, telbivudine, tenofovir, all are the reverse transcriptase inhibitor, which is happening in the cytosol of the hepatocyte, not at all within the nucleus. There is no drug which will stop the RcDNA. If we control to convert, we can prevent. Under the cccDNA protection, we can stop, we can control the other genome formation. Here, once the full virion forms, that is comes the DAN particle, that is infectious, but we should know that all the cccDNA, not only full virion, sometimes it will causing only the surface antigen, sometimes only the core particles. That's why the HBV DNA will be negative with the treatment, but the HBsAg will be fine, high will be there, and the total HB core antibody also will be high because we are not estimating the core antigen. So we know core antibody is the body immune system acting against the core antigen. So if you quantify the HBV DNA and HBsAg, HB core antigen, always HBsAg quantification will be high because of the excessive protection. Without virion, it is coming out. That is called subviral particle. This we already studied in our undergraduate, either full virion or the subviral particle. The beauty of the subviral particle, as it doesn't have any DNA nucleus, it is used for our vaccine production. The hepatitis B vaccine is totally dependent on the subviral particle, which doesn't have the nucleus. So that so now what this all we already know. So we know the E antigen, we know the quantification, we know the HBsAg quantification and the genome. Earlier I had not mentioned the genotype. Genotype is nothing but the HBsAg production. There is the A antigen, there is the 4 types, that will combination cause 8 genotypes. So if we are talking about the genotype, it is the genotype of the HBsAg, not the genotype of the core antigen, not the genotype of the DNA molecules. Then body immune system producing the anti-E antibody, total HB core antibody, IgM core antibody, and the ALT because the hepatocyte injury due to the immune mechanism release. These all we know. So what is the new we have to concentrate? one is the HB core antigen. We know IgM HB core antibody, total HB core antibody, but we are not measuring the HB core antigen. Second, the pre-genomic RNA. So this already I told, when the CCC DNA formulated within the nucleus of the hepatocyte, it is producing PG, pre-genomic RNA, which is the key factor for the polymerase. Another sgRNA that is producing the other proteins like a core antigen, E antigen, S antigen, but we are not estimating. And the HBV integrated CCC DNA, the open reading frame. This I already mentioned, CCC DNA within the nucleus of the hepatocyte, either it will be isolated or sometimes it will bind with the hepatocyte genome, that is called integrated. This also we are not measuring. These are the most of the studies contributing that what is the relation between the HBV DNA quantification with the HBV pgRNA, HBV DNA quantification with the HB core antigen, and what is the relation between the HB core antigen and the CCC DNA. So we should know here HB core antigen new, it is well correlating with the CCD DNA. HBV, the PG genome, that is also, it is well correlating with the DNA. So what are the clinical? So this is the very important. Here I wish to spend few seconds. The clinical application of the core antigen. So nowadays in our practice, we are not measuring, but it is still in the research. But if you look into the natural history of the HBS, the hepatitis B, first they identified HBsAg. Over the period of clinical implication of E antigen came, clinical implication, the quantification of the S antigen came. So one by one it is coming. Same way at the time has come for the HB core antigen, because here it is E seroconversion. If someone asks when the seroconversion occurs, based on the quantification and the fall of the HB core antigen, we can predict this all based on the studies. And the S antigen seroconversion. And if you go to the CCC DNA activity level and the treatment, suppose we are giving oral antiviral before treatment, on treatment, or different type, either interferon or nucleoside or nucleotide analog. So what is the fall? These all, well, even the transplant levels, suppose the level is very high, there is more chances of getting the reinfection in the graft and the reactivation. So HB core antigen, now in future it will play a major role because already enough studies has been come up. Second, that the pgRNA genome, I said CCC DNA delivering the pgRNA and the sgRNA, the pgRNA here, the paper is clearly mentioned, if there is the in the 4 weeks time of the time, if there is a significant fall, it is there, it is predicting the effect and the HBsAg seroconversion. So what we know the HBsAg seroconversion, normally there is no seroconversion while using the nucleoside nucleotide. There is very rarely 1% or the 3% seroconversion. But here we can use the pre-genomic RNA, we can predict the the seroconversion rate also with the interferon, etc. So now I am coming to that. So the first line therapy, this all what we know. Entecavir is there, tenofovir is there, and others we are not using, but in HIV infection, lamivudine, telbuvudine still play a major role. And what we know, this all, we already know, the cirrhosis, either compensated or decompensated cirrhosis, we are not treating based on the HBV DNA viral load or ALT. Irrespective of the ALT and the DNA viral load, we should start the oral antiviral drugs. And this all, we already know when to switch over also we know. If there is entecavir resistant, we can switch over to tenofovir. If the tenofovir resistant, we can switch over to the entecavir. But when we can use the combination. So this I marked. Combination we have to use if the patient already develop the resistance to the telbuvudine or the lamivudine. That time, we should use the combination. So combination, very rarely we are seeing either in the patient who are dialysis, etc. That time, some of the patient might require the combination of the entecavir and tenofovir. And this SG clearance. So here, this I wish to point it out. Everyone will talk about when to stop the oral antiviral drugs. So earlier used to say HBe antigen gets a zero converted if we know the DNA is undetectable for 2 years or APASL guidelines is 3 years, then we can stop the therapy for that. And the E antigen negative individual, we have to give lifelong. But this is not at all applicable in the presence of cirrhosis. So we have to know in the cirrhosis, either compensated or decompensated, we shouldn't stop any form of oral antiviral drugs. And here, what is new? So this all already we know what is new. What is the usage of pegylated interferon with the nucleoside or nucleated analog? That the dual already explained. Whenever there is a lamivudine or telbupudine resistant, we should give. So what about the usage of the combination at present? There are the 3-arm studies. So they used, one is the de novo combination, means at the first time itself, that group, these are so many studies has done, combination of the interferon with one of the nucleotide or nucleoside. Then they have seen what about the HBS AG zero conversion. It shows the almost 1 to 15%. That is slightly higher than much higher than what in day-to-day practice we are seeing. Another is the add-on combination. Here, first they treated a patient with the pegylated interferon or nucleoside analog. Pegylated means 48 weeks. After that, they switch over. They added the nucleoside or nucleotide. That time also, more or less, HbA1c loss is close to 10%. But third arm is the switch between the nucleoside and the PEG. Suppose the patient treated with the nucleoside analog, when the zero conversion happen or the viral DNA comes undetectable for 1 or 2 years, all the rest of the study, they gave the pegylated interferon for 48 weeks. That showed a very good loss for almost 30%. So what this combination future is going, so there is the combination of the immune modulating effect with the routinely available, the reverse transcriptase inhibitor. We can give the zero conversion. So this, again, I'm coming to if you know the basics, we can understand the RC DNA once enter into the nucleus of the hepatocyte, it is causing CCC DNA. There are several drugs are in pipeline to control the RC DNA, relaxed circular DNA into the CCC. Once the CCC DNA forms, to prevent the RNA formation, there are so many drugs. Once it comes to the cytosol of the hepatocytes, the capsid formation of the viral genome, and the core antigen, S antigen, prevention, so many drugs are in pipeline. Entry level, there is a receptor. Apart from that, body immune system stimulation, either the B cell, T cell, that are hepatitis B virus specific cells, either CD4, CD8 cells, that is the several. So there are so many, these are vaccines are coming up. These all siRNA means small interfering the RNA, several levels. This everything, if you look at that, act on within the nucleus of the hepatocyte, it is acting. So I already told there is no drug so far to act within the nucleus of the hepatocyte on CCC DNA, but there are so many vaccines are coming up. These all the trials are going. So now I will go for and just to want of time, just I am completing. So there are vaccine escape mutant. What is the treatment? Because we know sometimes after giving vaccination also, some of the patients won't develop this. So that time there is a current vaccine. I told that there is only S antigen. There is 3 types, S, L and M. Now what we are using, the NGRX or Genivac, everything is the S-related HBS AG vaccine. So the combination of the L means a large molecules. Combination is helpful. And the statin, Professor Epen told about the statin is useful to prevent the progression of the liver cirrhosis and other thing, the fibroid. Same thing, the recent Nature publication, they mentioned reduces the hepatitis B and C. The cirrhosis, not only cirrhosis, HCC. So we can start to use of the statin, if there is no other contraindication, to all our hepatitis B virus and the C virus patients. And the TAF, there are literature, yes, enough literatures are there. After starting, this is alphanamide, not the routine tenofovir earlier, dipivoxil. Alphanamide inducing the lipid. So we have to check the lipid profile regularly, once in a year also. That time the patient might require the statins. So And for hepatitis C, just the 1 minute, if you allow. Okay. Fine. Hepatitis C, we know the screening test tool we are doing. What are the drawback of the screening tool? We know sometimes it is so false positive or false negative. That is a big drawback. So what is the at present the recommendation is either we have to give a 4 weeks gap and we have to repeat the test, or we have to send it either ELISA technique or sometimes the chemiluminescence immunoassay. So these one or two combination, we have to do that, the things. This another new is the screening tool is available for from oral, the cavity. So the kit has all the NS3, 4A, 5B, whatever we ready to hepatitis C, the antigen will be in the kit. So if we have antibody in the oral buccal mucosa, that shows the positivity. This is the thing. And this I wish to convey very important, I wish to convey. If the patient have the dual infection, B and C, we have to treat the patient before start the DAA, because the hepatitis C, we have to give either tenofovir or entecavir. See, here the patient have the dual infection. If after giving the DAA, there is an activation of the hepatitis B is 38%. And if there is a chance to get the seroconversion, even 52% is the stable. So what the paper says, if we have the dual infection, we have to treat the patient with the oral antiviral drugs, particularly for hepatitis B virus infections. So due to want of time, I'm completing this one. Thank you so much for the kindness.
It's quite elaborate, very nice. And the C is the most important point. We treat C virus, but the HCV continues positive. The antigen test only can differentiate between already treated and non-treated case. That point is well brought out. B, nothing, slight is seen at the end of tunnel. I think we have gone beyond time. Thanks.
Yeah,
very nice, Father.
I have this one question. Suppose the patient got HCV infection in the early stage of fibrosis, only for fibrosis. On giving DAA, what's the chance of reversing the fibrosis? Because I see many cases, in spite of giving this DAA, patient remains chronic disease.
So there are the studies are there, the reversibility of the fibrosis with the oral and like alcoholic hepatitis, how the abstinence is making the reversibility. Similarly, the oral, the DAA, it's causing the reversibility. But at the same time, even SVR achieved, only the advice is we have to screen for HCC, because the HCC will be always will be there, even though reversibility of some fibrosis. The treatment for that is cirrhosis. I mean, that time we have to add on therapy wise. Ribavirin means 3 months. If the patient there is no cirrhosis, means without ribavirin we can give the 3 months. Thank you.
The next section would be Liver Upgrade Session 2. The chairpersons of the session are Dr. Shanti Vijayaraghavan, Dr. R. Ramani, Dr. Prem Kumar, Dr. Bhakta Vasalam. I request all the chairpersons to take the seats on the dais.
The first speaker for today will be Dr. Mitra Prasad on abnormal liver function test. Dr. Mitra.
Good afternoon. At the outset, I would like to express my profound thanks to the entire team of TNISD and Dr. Ubal sir for inviting me over for this talk. So the talk is on abnormal liver function tests. Greetings to you from VGM Hospital in Coimbatore. And so what are liver function tests? They're basically an array of blood tests from which we can monitor the functioning of the liver. So they can be categorized under 3 heads: tests of transport, test of the function of transport, test of hepatobiliary injury, test of synthetic function. So the test of transport would include the serum and the urine bilirubin, the urobilinogen, the bile acids. The test of hepatobiliary injury would be, on the other hand, your aminotransferases, alkaline phosphatase, gamma-glutamate transpeptidase, and 5' nucleotidase. Tests of synthetic function, the most commonly used, are albumin, prothrombin time, and INR. Coming on to the test of the function of transport. So bilirubin. Bilirubin is basically a breakdown product of heme metabolism. So from the blood, it reaches the liver and then is converted into heme from the blood reaches the liver. Heme is converted into biliverdin and then into bilirubin and then conjugated into bilirubin mono and diglucuronides, and then it's excreted in the bile. So the normal value remains less than 1.1 milligram per deciliter, and a predominantly indirect fraction prevails. So the 2 types of hyperbilirubinemia could be an unconjugated or a conjugated hyperbilirubinemia. An unconjugated hyperbilirubinemia is predominantly seen in extrahepatic causes like hemolysis, hyperthyroidism, or in some rare genetic variants like Gilbert's and Crigler-Najjar. And the conjugated hyperbilirubinemia is more commonly seen in hepatocellular dysfunction and cholestasis, apart from the genetic disorders. So why do we need to look at the urine bilirubin? So it is generally detected in conjugated hyperbilirubinemia, but sometimes it could give us a clue. So it's not seen in hemolytic jaundice, and that is why it's called an acaluric jaundice. And it is also not seen in conjugated hyperbilirubinemia when the bilirubin is bound covalently to albumin, the delta fraction. So urobilinogen is another test. So that is increased in hemolysis and absent in extrahepatic obstruction. It actually indicates the continuity of the enterohepatic circulation, and whenever the enterohepatic circulation is disrupted, then the urobilinogen is absent. So test of hepatobiliary injury. This would be aspartate transaminase and alanine transaminase. The normal values are less than 30 in male and less than 20 in female. Aspartate transaminase is not specific to the liver, whereas alanine transaminase is very specific to the liver. Aspartate transaminase is more commonly seen in the mitochondria, and alanine transaminase seen only in the cytosol of the hepatocyte. There is also a zonal variation in the concentration of ALT and AST in the liver, with the zone 1, that is the periportal zone, having higher concentrations of ALT, and the zone 3, the centrilobular zone, having a higher concentration of AST. So that is why predominantly viral autoimmune hepatitis, which affect predominantly the zone 1, have higher ALT, and zone 3, the ischemic and the hepatic venous outflow tract obstruction disorders all have a higher concentration of AST. Also being used are the AST-ALT ratio or the D-Ritis ratio. So the ratio is generally high in alcohol liver disease, and ratio is low in acute viral hepatitis. The other tests of hepatobiliary injury include alkaline phosphatase. There are generally 5 isoforms, but an increased alkaline phosphatase, which is predominantly of liver, bone, or placental origin. So the increased alkaline phosphatase of liver origin seen in cholestasis, infiltrative disorders, or in malignancy, which could be either primary or a METS. Low alkaline phosphatase seen in Wilson's, hypothyroidism, hypophosphatasia, or zinc deficiency. The gamma-glutamate transpeptidase is generally used to differentiate the liver and the bone origin of cholestasis. The 5' nucleotidase not in vogue now, but it could still differentiate a pregnancy-related rise of alkaline phosphatase from a liver-related rise of alkaline phosphatase. The lactate dehydrogenase generally is used to distinguish between ischemic hepatitis and viral hepatitis. So coming on to this test of synthetic function. So the main tests used are the albumin and the prothrombin time. The albumin, though serves a very good prognostic marker, is not of great use in acute liver failure because it has a very long half-life, and there are other causes of hypoalbuminemia that needs to be considered. The prothrombin time, though a very sensitive and a very accurate marker of liver synthetic dysfunction, could also be due to vitamin K deficiency, DIC, or induced by warfarin. Another clue to what the disorder could be is the use of ALT and alkaline phosphatase ratio, or the R ratio. More than 5 would, a ratio of more than 5 would mean the hepatocellular pattern of jaundice, and less than 2 cholestatic. Anything in between is a mixed disorder. So if we actually look at the number of liver function tests, then we are in the dark. We are almost like these blind men looking at the elephant. So what we need to remember is anything in the universe has a pattern. So even our liver gives out all the abnormalities in specific patterns. So let's look at the different patterns that you could encounter in your daily OPD, and which will guide you to an accurate diagnosis of liver dysfunction. So first, coming on to, this is the most common scenario. A patient walks in and there are just raised transaminases and you don't know what to do. So look at the first profile. The bilirubin is normal, the transaminases are marginally elevated, and the gamma glutamate transpeptidase is normal. So if this could come in intercurrent viral illnesses, but if persistent, then you have to think in terms of chronic viral hepatitis or autoimmune. So the second profile, if in the scenario of metabolic syndrome, then you can always think of NASH with a marginally elevated gamma glutamate transpeptidase. The last scenario will be a higher AST-ALT ratio and very high GGT, so that would be more in favor of alcohol-related liver disease. So coming on to the next profile that could occur, an acute, very high transaminase proportion. So if the transaminases are sky high in thousands, but the synthetic function of the liver is okay, the patient does not have encephalopathy, think in terms of acute liver injury. In an acute liver failure, however, the bilirubin might be much higher, but the transaminases will be falling, and there's a significant raised INR, and the patient has encephalopathy. Looking into the profiles in a chronic liver disease patient, in a patient who's already cirrhotic, give me a minute or two more, thank you. So the first profile gives a patient whose liver profile is absolutely normal, but the ultrasound shows cirrhosis. So this could be an early compensated cirrhosis. The second profile shows a probably decompensated cirrhosis with a low albumin and seemingly increasing creatinine. The last profile shows an advanced liver failure. So coming on to the cholestatic profile, so these two, forgive the gamma GGT values, they're in 400s in both. So this profile shows a raised alkaline phosphatase in both, but however the bilirubin is higher in the second profile. So the first could be an intrahepatic cholestasis, but the second could be either and requires further imaging to confirm. The last profile you will be seeing is an isolated hyperbilirubinemia. So the bilirubin usually stays at 4 milligram per deciliter. The AST-ALT are bang normal, and so these patients are more probable to be due to Gilbert syndrome, and this is quite could be alarming if the treating physician is not alerted that the bilirubin can go high in when there are either infections or there are any in fasting or any states of stress. So coming on to the cases, I just wanted to present cases where liver profile really guided us to the diagnosis of the patient. I will finish, sir. So the first was a case of severe COVID pneumonia who came with acute liver failure. The bilirubin was completely normal, but the AST-ALT were sky high, and the patient succumbed. The liver biopsy showed HSV hepatitis. The second case was a case of CLL who came to us with CAM DILI, but again the biopsy showed an infiltration with lymphocytes, so then she had to be put on chemotherapy. The third was a case of autoimmune hepatitis, a long 20-year duration, who came to us with an altered liver profile, and the biopsy rather showed a NASH because she was also a rheumatoid arthritis patient who was on intermittent steroids. So that's just the flowchart of how to approach altered liver function tests in a patient, how they can be a roadmap to guiding towards diagnosis even in indeterminate cases. Thank you, and very sorry for the delay.
That was a nice presentation. This abnormal liver function test itself is a very elaborate topic. Containing it in explaining it in 10 minutes time is a great task, and you have made it.
Thank you so much. Thank you.
Next, I call upon Dr. Uday Jakaria to give a topic on drug-induced hepatitis.
Thank you, chairpersons, and thank you to the organizers for the kind invitation. So over the next few minutes, I'll try and cover what are the causes of drug-induced liver injury in our country, and what are the prognostic markers and the outcome, and try and look and see whether we can do anything more than we usually do for them in 2023. So the bulk of my talk is taken from this article, which is available in our national journal. And Dr. Harshad Devarbavi, as you are aware, is the Delhi person in our country. So this is basically his work, but this is a work actually pan-India. And as you can see, this was a study done in about 30 plus 5 centers, mostly tertiary level. It was a prospective study, and it looked at the causes and outcome. And Tamil Nadu, as you can see, played a prominent role in that. So for the diagnosis of DILI, what the authors took was a bilirubin of more than 2 milligrams, or an AST-ALT more than 3 in an asymptomatic individual, or symptomatic and more than 5 times abnormal ALT or AST, after excluding all the other causes of the same. And severe DILI was defined when the bilirubin was more than 2 and an INR of more than 1.5, with the presence of either ascites or encephalopathy. The patterns of liver injury, we are aware of this. Essentially, the ratio of ALT and alkaline phosphatase in the given equation was looked at, and if you have an hepatitic pattern, it was known as hepatitic or cholestatic, or a mixed pattern. Now, causality or causation, there are many models. What was used here was the RUCAM model. It's quite cumbersome when you look at it, so I've just listed out what are the domains that are looked at. We look at the time of onset of injury to symptoms, the course of the illness, what were some of the risk factors, were there concomitant drugs used, were there other causes other than drugs accounting for the abnormality, any previous hepatotoxicity, known potential for hepatotoxicity of the drug, and if rechallenged, what was the response to drug readministration. And based on that, you have a score which excludes it to highly probable, and this study took all patients which were possible or above that. So the breakup of these patients, about 60% in total, of which about 46% were anti-tuberculous drugs, and that's understandable because 25% of TB in the world is in this country. So I think it's understandable that TB drugs found the formed the bulk of this group. And interestingly, the next highest was complementary and alternative medication. However, we must remember that this was mainly historical and there was no real sort of proof as to what drug was or the component exactly that was involved. Beyond that, you have anti-epileptic drugs and antibiotics and others. So most of these patients, don't worry about what's on the left of your screen. Most of these patients were in their 4th or 5th decades. There was a slight male preponderance of 51%. 67% of them were jaundiced. And in the pattern, the commonest pattern seen at 42% was cholestatic. About, interestingly, 20% of them had immunologic skin reactions, and 16 and 10% actually had presented with ascites and or hepatic encephalopathy. Remember, these are patients presenting to a tertiary center, so there would probably be a referral bias. 10% of them had associated significant ethanol, and about 6% of them were diabetics. Applying the RUCAM model, about 50% odd of these patients were highly probable, and the remaining were either probable or possible. And severe delay, by the definition given, was seen in about 32% of these. Now, overall, out of 1288, we had data for 1263 patients, and of that, the mortality was about 12%. But look, as to when you were clinically jaundiced, that mortality went from 12 to 16%. And following Hy's law, which is bilirubin more than 2, and adding on inflammation in the form of AST-ALT more than 3 times, that further went up to 17.6 or almost 18%. If in the subgroup which did develop acute liver failure, which was about 124 patients, the mortality was very high, 65%. In the breakup of the mortality, anti-tuberculous drugs and anti-epileptic drugs were about 15%, followed by CAM at 13.6%, and then the rest. When they looked at predictors of mortality on a multivariate, this is sort of, you could say, expected. Creatinine, coagulopathy, encephalopathy, or ascites were predictors. And for this group, a MELD of 19 was found to have an 81% sensitivity and a 65% specificity for mortality. When you looked at the patients with ALF, it was MELD, which was a prognostic marker alone, and there was a difference in that MELD between survivors and non-survivors. Again, a busy slide. This is looking at the subgroup of CAM versus prescription drugs. And if I could ask you to focus on the right of your screen, you could see that these patients either had an increased preponderance of clinical jaundice or biochemical jaundice, an increased trend towards ascites, and a higher MELD. But overall, the mortality in these two groups was not different. If I can just take 2 minutes, please, to share some of our data on what we do for these patients who come to us with drug-induced liver injury. This is a paper or an abstract which was presented by Kunwar Ashish Singh from our team. And we've shown earlier that there's improved survival with both toxins and severe alcoholic hepatitis with plasma exchange. The rationale here being removal of harmful mediators or large molecules like VWF, which, as you know, is a predictor of mortality in both ALF and ACLF. And so we looked at whether low volume plex and low dose steroid, would it make a difference in this group of patients? This was a retrospective analysis done over 5 to 6 years. Essentially, over this period of time, we had about 6,000 patients, of which 163 had liver disease. And as you can see, about 90 of them had ACLF, and about 35 plus 25, 60 of them had ALI, ALF. So these were sick patients. Of this group, about 48 of them underwent PLEX. The RUCAM score on probable DILI was 41, and there was a 50-50% difference, a breakup between native medication and prescription medication. These were all sick patients, high bilirubin, low albumin, high INR, and high VWF levels. And in a nutshell, what we were able to show on this small group is that at 30 days, we had an overall survival of 71%. In the ALF group, it was about 57%. 23 of these ALF patients, of these 23, 20 fulfilled King's College criteria for transplant, and 12 of these survived. That's my last slide, which is actually just looking at the comparison between different series which has been published. I'll skip that and go to the summary. I think in the end, diagnosis of DILI is one of exclusion, and we forget to take history. It's not always clear whether a particular drug is causative or it's just associative or is a bystander. But if you don't take the history, then we'll miss it altogether. ATT remains the commonest etiology, and if you develop liver failure, as you saw, there's a very high mortality. And maybe in select cases, low volume plasma exchange and steroid could be considered. So thank you, and apologies again for exceeding time.
Thank you very much. I have a question, Dr. Uday. For the RUCAM scoring, you got a lot of percentage of CAM. So there's one score what is actually not complete because you got the previous hepatotoxicity as one point in that. So it actually will be giving you a low score.
No, that's absolutely right. Is the RUCAM score applicable for complementary and alternate medication? There's no other score yet, so I agree with you that we may be overcalling it.
It's a very insightful talk. We move on to the next speaker.
Dr. Hemamala on autoimmune hepatitis.
Thank you. I thank the ISG team for giving me this opportunity to talk on autoimmune hepatitis. So autoimmune hepatitis is a very huge topic, and within 10 minutes I would have to cover. So because PGs are in their large numbers, about 60 to 70% will be the traditional ones, which we know for many years, and something what is new in the last few years. So autoimmune hepatitis is a chronic inflammatory state of the liver, and this happens because of loss of the autoimmune tolerance in genetically predisposed individuals. It usually presents as a chronic hepatitis or cirrhosis, and in some patients it can present with acute hepatitis or ALF. So I would discuss with two case scenarios and raise up some questions. So our first patient is a classical patient, a 33-year-old lady. She complained of tiredness and she was found to have abnormal LFT. Her bilirubin was 4, her AST/ALT was 600, 700. Her synthetic function was good. Her ultrasound was normal. So evaluation of hepatitis, the viral markers were normal, ceruloplasmin was normal. So her autoantibodies were positive. ASMA was positive, the immunoglobulins were high, and the liver biopsy was suggestive of autoimmune hepatitis. So how do you diagnose? So there are 4 points for diagnosis of autoimmune hepatitis. One is the classical clinical findings, clinical history. Second is the laboratory findings of elevated immunoglobulins and the autoantibodies, the histology, and exclusion of other diseases like virus or alcohol or drugs. So in the laboratory findings, immunoglobulins, few points. One would be that in patients with acute hepatitis or ALF-like features, around 30 to 40% of them may be autoantibody negative, or what we call as a seronegative autoimmune hepatitis. In those patients, the histology plays a more important role in diagnosis. and in histology. So almost all patients would need a liver biopsy before we start on immunosuppression. So we look at the grade of inflammation and we look at the stage of fibrosis, which is prognostic. Second would be the level of the necroinflammatory activity in the biopsy does not correlate with the transaminase levels. So it becomes all the more important to do a biopsy, especially if you are considering treatment withdrawal or immunosuppression withdrawal later. For the PGs, if you ask what is the commonest histological findings, one is the interface hepatitis with lymphocytic or lymphoplasmacytic infiltrates. So interface is the region between the portal tract and the hepatic parenchyma, and this hepatitis was previously called as the piecemeal necrosis. Other features will be the rosette formation. Rosette formation means the hepatocytes come together to form a pseudoglandular pattern, or the emperipolysis, that means some lymphocytes get into the hepatocytes. So here the first A slide shows the interface hepatitis, and then if you look at the D, there one lymphocyte is trying to get into the hepatocyte, and if you look at E, there you can see that the hepatocytes are trying to form a gland. So these three are supposed to be classical histological findings in autoimmune hepatitis. So all these criteria is put together as simplified criteria, all these four together. This is found in textbooks. This criteria is there in all the textbooks. Now, coming to the treatment. So in a liver disease, with whatever be the etiology, our primary aim when we try to treat the disease is to ultimately improve the survival and prevent the end-stage liver disease. So as with any other liver disease, so here we want to decrease the progression of fibrosis and decompensation. And so for that, the most important thing is to suppress the inflammation, and we have to aim for a biochemical and a histological resolution. So there is nothing new in this. In fact, autoimmune hepatitis is one of the first diseases in which controlled trials were done more than 50 years back, and that was with prednisolone and azathioprine, and we are still using almost the same drugs. Probably we have some drugs when patients are intolerant to azathioprine now. So same thing, this was done in 73, and they compared that with placebo, prednisolone with placebo, and what was found was that the mortality in the prednisolone group was only 14%, whereas it was more than 50% in the placebo group. So the indication for treatment would be any patient with active hepatitis in histology needs treatment, and usual dose of prednisolone will be 0.5 to 1 milligram per kilogram body weight, and then followed by azathioprine. The long-term outcomes. The long-term outcomes is very good with autoimmune hepatitis, especially if they are on good immunosuppression, and their overall survival is comparable to the general population. And 10-year survival is more than 90%. So coming to our patient, so we started her on prednisolone 40 milligram daily for 2 weeks, and then after 2 weeks we saw a very good resolution in the liver function test, and then we put her on azathioprine, and she did well. And this is how we monitor a patient of autoimmune hepatitis. Initially, it will be usually monthly. Then it would come, once they go into remission, it will be once in 3 months to 6 months. So now, in addition to the biochemical test, now we routinely use FibroScan to monitor these patients. So FibroScan is reasonably accurate in predicting the advanced fibrosis or cirrhosis. One thing we have to remember is that in the initial few months, usually around up to 6 months, it can give falsely high values because of the inflammation. But subsequently, every year you can put them on you can do yearly once FibroScan to assess the fibrosis progression. So our patient here, so she came back after 1 year, her liver function test is normal, her liver stiffness was around 8, and then she had this question, doctor, I want to become pregnant. So what should I do? Can I stop the medications? So the first question, so pregnancy in patients planning, patients with autoimmune hepatitis. So prednisolone is safe. We now also know that azathioprine is safe. It is not associated with increased preterm birth or teratogenicity. And flares are common in the peripartum period. So the patient should be advised to continue azathioprine or prednisolone if they are on it. If they are on MMF, that has to be stopped because that is teratogenic. And only thing is that the AIH should be well controlled and they should be in remission before they plan pregnancy. Coming to our second question, can I stop drugs? So not just that lady, anybody would think after 2 or 3 years, my labs are good, so should I stop it? So one thing which we need to remember is relapse is almost universal after withdrawal of the immunosuppression medication. So we should be counseling the patient before we stop medications. I will skip these slides. We will come to the second patient who is much more sick, who came with a bilirubin of, elderly lady who came with a bilirubin of 25, her INR of 1.8 and the platelets of 1.2 lakhs with ascites. So this is what we define as acute severe autoimmune hepatitis. That means they have jaundice, their INR is more than 1.5, but no encephalopathy. If there is encephalopathy, then it is ALF. So in these patients, we have a dilemma. Can we give steroids? Will they benefit from steroids? And in which patients are steroids not useful and who should be referred for early transplant? So this is the data from the APASL, and what they have seen that about around 2% of them had AH, and out of them 1/3 they gave steroids. In the patients whom they gave steroids, the 90-day survival is good. And patients who do not respond to steroids, who are they? They are the patients with advanced age, patients with more severe disease like MELD27 or presence of hepatic encephalopathy or fibrosis. So these are patients who will not do well with steroids and they should be referred for early transplant. So here our patient, we did the transnuclear biopsy. She had fibrosis. Luckily for her, we started on steroids and she improved very well. But not everybody will do well. And waiting for 2 weeks might be sometimes too late in an acute severe hepatitis. So there are some scores which have come up wherein we can predict the INR and bilirubin change at day 3 and day 7. And we can, if they are not responding, we should not prolong the steroids more than a week and they should be referred for early transplant. So the conclusions. So AIH is a chronic inflammatory disease of the liver. Overall, it has a good long-term prognosis with immunosuppression. And in acute severe AIH, a judicious use of steroids should be done and early referral for transplant should be done for non-responders. Thank you.
So Dr. Nice presentation. Only one question, you talked something about the duration. Is there any reasonable guideline?
Yes, sir.
To say how long the steroids to be taken? Number 2, is there any tapering of the steroids or we have to continue the same dosage?
Yeah.
For how long?
So I skipped those slides because of lack of time. So basically steroids are usually tapered in the initial few months and generally they would be on azathioprine or on very minimal steroids. For the duration of treatment, generally they should be at least for 2 to 3 years, they should be in complete remission. So complete remission means normal AST, ALT and IgG. And then after counseling, we can consider withdrawal. That too, in most patients, a liver biopsy should be done, and in them, the histological activity index should be less than 3. In that also, there should be no activity. Then only we can consider stopping. Sir.
Thank you. So this is one question to Professor Epan. So we are keeping on expanding the scope for flux. Can we expect that in the near future we may have like dialysis patient with chronic liver disease walking in, getting flux done, getting albumin infused? They can prolong their survival and the bridge for transplant may be expanded or extended.
Thank you. The question is about plex. So I'm slightly biased in favor of plex. I may tend to overdo it. But I think the answer is yes. I think increasingly more and more centers are doing plex and we are identifying newer indications for it. As of now, we are focused on acute liver failure and acute and chronic liver failure. But about 10 years ago, there was a publication from Poland where they used plasma exchange to treat PBC patients. They were doing it once a month for 6 months. So that means they were doing it almost like an outpatient procedure. So we have so far focused on ALF and ACLF. In that group, increasingly it appears that survival benefit is coming. In fact, more and more data is showing it that way. The protocol is improving. The etiologies for this are different and that will vary from our population. So in the short answer, yes, I think every center will start doing it. It's like, that's what I think, because the facilities are already there. Just a matter of us figuring out the indication and which is the correct patient to use that for. I hope I've answered you.
invite the moderator for this session, Dr. Ashish Goyal. The panelists will be Dr. Dinesh Jyotimani, Dr. Arulraj Ramakrishnan, Dr. Joymore, Dr. Swati Raju, and Dr. G. Ramkumar.
Thank you, Dr. Shanti. And at the outset, thanks to Dr. Ubal and Dr. Ravi's team for the kind invite. We will try and cover a lot of topics, and as I see, 5 minutes have already been reduced. So we will try and cover some topics, and we will stop as soon as the clock winds up. So our discussion will be on acute and chronic liver failure. Let us just jump into the case directly. So a 37-year-old male presents with a short history of jaundice and develops moderate to severe ascites, gets admitted to our hospital with grade 2 hepatic NCAF. As far as past history is concerned, he had a meningioma resection 1 year back and was on anti-epileptic drugs. There is no significant family history or alcohol intake, and the admission bilirubin was 18. ALT was 660, AG ratio is sort of preserved, INR was 2.4, ultrasound done showed shrunken coarse liver, and upper GI showed no varices. MELD score was 27 and a lactate level was 2.2 at admission. So let us start with Dr. Arul. What do you think is the syndromic diagnosis in this patient?
Yeah, thanks, Ashish. I think the fact that you put forward that the time duration has been very short. On an endoscopy, there is no varices. I think Epan very clearly outlined that what was the Bavino saying about DCLD and everything. So this fits with the sort of an acute insult which has happened. And the fact that transaminase has gone up, the ALT has gone up, the fact that it's probably the fact that you violated ALT being high, it probably makes me think that there's an acute precipitant, probably a viral or something, an infection which is precipitated, and henceforth I think that it's probably an ACLF rather than a DCLD.
Yeah, thank you, Dr. Arul. And how do you think, does it impact your management in any way when you say ACLF, not DCLD? Do you think differently in your management?
Yeah, I think we've all come to recognize that ACLF definitely varies from DCLD. The DCLD we see, or the ones that who slowly deteriorate, where we got time to work on and see that where there's reversibility, and if you were to have reversibility, then you reverse the etiological agent and they get better, and if they don't improve, then you have the time to think about transplant. And in ACLF, the time period is extremely short, so you really have to catch on to it as quickly as possible.
Question to Dr. Ramkumar. How do you assess severity in these patients?
To assess the severity, we got a lot of scores, like the Cliff organ failure score, Cliff SOPA score, the Cliff ACLF score, and out of the all these scores, there are two. One is the R score, the ACLF grade, and the Cliff C ACLF score. Just add on the criteria. It's like just how we calculate the MEL calculator. We just add on the difference, 5 categories, we get the score. So you need to be very fast because it is not DCLT. So you have to plan at 2 days, 48 hours, 7 days, like that. So the best is ACLF C, Cliff C ACLF calculator is the best one. Next is ARC with the ACLF.
Thank you, Dr. Ramkumar. Just to elaborate, this is the ARC score, which is easily available online, and it has, as said, Dr. Ramkumar said, various parameters which can be used as a child score. As far as CLIF consortium is concerned, they have defined organ failure based on SOFA score, and this is the things which are being highlighted. And the grading of ACLF will definitely prognosticate in this patient. More than that, there is a CLIF C organ failure score, which helps us guide how severe is the disease. What the point Dr. Ramkumar was saying is that MELD score may not be alone enough in prognosticating patients with ACLF. It is the organ failure which adds on more information in addition to MELD score. We have utilized von Willebrand factor as one of the predictors, and I will come in detail in the subsequent slides if time permits. But we have seen that in ACLF patients, a 7-time rise in von Willebrand factor predicts mortality over the next 7 days, which is almost better than the MELD in these patients. So Dr. Swati, defining ACLF, there is still controversy. What do you think is good for you?
So there are many definitions which are in use. The most common one would be the APASL, ESL, and the ASLD definition, and the recently added WGO definition. So in the APASL, the definitions mainly look at the patient cohort whom they are defining, the precipitant or the acute insult, the organ failures, and they ultimately try to predict the short-term mortality. So when we look at APASL, it's seemingly easy to apply, but it only focuses on the liver intrahepatic. But the positive thing is it includes cirrhotics and non-cirrhotics. So for example, a severe alcoholic hepatitis, which can present as an ACLF, can also come under that. But in ESL, only cirrhotics are taken into account. And the most important thing is they look at organ failure scores. So it gives us an overall picture and a better predictor of the mortality. So for me, it would be first going for the ESL definition, and in some specific conditions, APASL also would work.
So this is what, if we apply these definitions to our patient, we will say this patient fulfills the definition for APASL ACLF. There is high bilirubin, and within a period of 2 weeks, patient has developed ascites and coagulopathy, but will not fulfill ESL definition because there is no extrahepatic organ failure per se. So I'm just asking Dr. Swati again, is there a difficulty, say, applying ESL? So now currently ESL is not fulfilling. Do you think this is less sick patient, or what is your understanding in this?
The clinical spectrum of ACLF it needn't end up the way it began. So what definition we may use at the beginning, the patient may actually end up much worse later. It's literally like a line in sand where with time even the line may fade. So looking at that, there are difficulties, and towards the end there may be a different definition we could have used. There is a very high possibility still this patient could develop, because it's a very dynamic disease. So instead of taking a beginning or the end, we need factors which would prognosticate throughout. Probably a time frame of 3 to 7 days where the picture may change, the response to treatment may change. So then the outcome will be different.
Thank you, Dr. Swati. Dr. Joymun, can we elaborate on the initial liver disease etiology workup in a patient who presents like this?
Yeah, thank you, sir. Since the patient being a non-alcoholic, I would like first to rule out the viral liver diseases. So I will do HbA1c, core antigen, hepatitis C, A, and E. Then Wilson's being a common disease, then I will do serum ceruloplasmin with KF ring evaluation, and also 24 hours urine copper. And then autoimmune evaluation, ANA, AMA, SMA, LKM1, and IgG. And then to rule out hemochromatosis, do transferrin and ferritin levels.
Thanks, Dr. Joymun. I think what Dr. Joymun says, we should concentrate on both acute etiologies and etiology for chronic liver disease. In this patient, acute etiology could be virals related or any other, but we should at the same time concentrate on what could be the underlying chronic liver disease. And this is a study from Dr. Ames group, which had looked at around 1,049 patients in a nasal consortium, where they looked at the etiology of acute and chronic liver failure. And most common etiology for chronic is alcohol, followed by cryptogenic, and most common etiology for acute, as you can see, is again alcohol, followed by hepatitis viruses. So we have got Indian data on saying alcoholic hepatitis presenting as ACLF may be the most common diagnosis, but there are hepatitis virus, which is the second most common. So Dr. Joyman, again, these are the results for this patient. How do you interpret and what could be the etiology here?
In this patient, we have a HbA1c positive, but the core antigen is negative, so it could be a chronic Hep B or it could be a immune clearance phase. Next, we have a low ceruloplasmin level also, so it could be either Wilson's disease. So also in a history, we have a patient taking anti-epileptic drugs, so it could be hepatitis B liver disease with a drug-induced liver injury, or it could be with hepatitis B with Wilson's disease.
The E antigen was negative, ma'am. So this is, thanks Dr. German. So it is acute and chronic liver failure, and after this initial evaluation, we also thought the same thing. It could be an immune clearance, though IgM core is negative. Usually it is positive in these patients, and E antigen again can be positive. It could be a drug related, and anti-epileptic drug is definitely here, but there could be a concomitant other, and what we found in our experience, complementary and alternative medications also could be causing this. And chronic could be again hepatitis B, or could it be Wilson disease? Low ceruloplasmin in this isolation may be a red herring, because we know it's a negative acute phase reactant, so low ceruloplasmin may be, we can just keep on follow-up currently. So Dr. Dinesh, 600. So is the treatment of etiology enough here when we say hepatitis B, and do we need to think about some other treatment? And you will also let us know about transplant in this patient. Is this a correct time to think about transplant?
Yeah, certainly. It's a young guy with acute on chronic liver failure, and he's not doing well. And in these patients, first you need to know what both the etiologies are. You have hepatitis B, definitely that should be, the treatment should be started for that. And of course, the other patients with ACLF, they have very high systemic inflammation, so they should be treated appropriately with antibiotics if they are septic. So, and nutrition, of course, if they are cirrhotic and if they are not, if they are malnourished, nutrition should be addressed. So all these, and make sure the kidneys are okay and you're not compromising on that. Eventually, these patients should be considered for transplantation. The question is whether do you intervene with plex at this stage. Also, what we do is to look at the liver volume. If the liver is completely collapsed and the chance of recovery is very little, those patients you can take them for transplantation. Whereas if the liver volume is reasonably adequate, still you can try conservative measures to rescue this patient without transplantation. Does this patient require transplantation? Yeah, that is the answer for that. Again, there are indications and contraindications. As you know, you can go by ACLF cliff or APASL ARC scores like that. So yeah, there are contraindications as well.
So when do you think it is too far gone for transplant?
Too late to transplant is obviously if they are florally septic, if they are on sort of complete hemodynamic compromise, advanced encephalopathy. Those are the patients who are too late for transplantation, particularly those with active bacterial sepsis. But there are scores they're coming up. One is the TAM score. It's called it's a transplant in ACLF model, which involves the age, mechanical ventilation, lactate levels based on that. So obviously lactate more than 4 after resuscitation. So
it's a relative contraindication for transplantation. But it's not just the one, so you need to take everything into account. And how you're going to do the transplant, it's the main question here.
So, as Dr. Jyotimani pointed out, there is a golden window for anything, for basically transplant and any other measures, which is when the liver failure develops and before sepsis or extrahepatic organ failure start to set in. So, Dr. Arul, how important is inflammation, a role of inflammation in acute and chronic liver failure, and how can we tackle it?
Yeah, I think I probably would say that inflammation, infection, they're probably two sides of the same coin, really. And the reason why I say that you identify that it's an infective component or a non-infective component. Let's say, for example, it's an alcoholic hepatitis, it's a non-infective component, and you try to see that they could improve on, and as well as, let's say, for example, if this is it's a reactivation of hepatitis B, then it's probably there's a reversible component with inflammatory bit. But on the other hand, if it's an infection, it's going to keep on propagating. It's probably earlier for we to get through that and just identify that, because as Dinesh was pointing out, when they develop sepsis, when they go into multi-organ failure, and you also lose the opportunity of going ahead with transplant as well.
So what I think Dr. Arul also said, that it may be a non-infective immune reaction as well, and we know that the immune system can be divided into both adaptive and innate immunity here, and we have more or less, we know what is adaptive immunity, and we heard in the last lecture that if it is adaptive immunity attacking the liver, it is called autoimmune hepatitis. But when the innate immunity attacks the liver, the terminology is not clear. So innate immunity is consisting of circulating and fixed cells, and this is how we recognize it. In some of the patients, if we do a biopsy, there may be a neutrophil infiltration in the blood. It can be picked up by these parameters, the innate immune activation. And in one of our study, what we have shown in alcoholic hepatitis ACLF patients, most of these innate immune markers, macrophage activation criteria, ferritin or CD25 or CD163 are raised in most of these patients, and one of the endothelial markers, which is von Willebrand factor, actually predicts survival in patients with alcoholic hepatitis and ACLF. And this is the way what we think is happening. If there is a acute and chronic liver failure, there is innate immune activation or endothelial activation, which increases von Willebrand factor expression, leading on to various other extrahepatic organ failure symptom. This is the markers in our patient. Von Willebrand factor normal is 150, so it is 3 times elevated. Ferritin is high, CD25 is mildly high, CD163 is twice the upper limit of normal, and you can see the neutrophils are slightly higher than the lymphocytes. So Dr. Ramkumar, as Dr. Jyotimani pointed out that this may be a correct time for transplant, how many patients will you refer and how many patients undergo transplant?
See, my friend is very eager to do transplants. See, this is a dynamic process, okay? But the dynamic ACLF is very fast and furious. So we need to put this course serially and see. So suppose we have a lot of livers waiting there, we've got few patients you can refer, but hardly in the past, how many transplants have occurred for ACLF? 1, 2, 3 maybe. So in reality, the ultimate treatment is transplant, but can we do some medical management or some bridge so that we get the adequate number of livers for transplant? So reality, we're doing really less transplant for ACLF.
I think that has been pointed out by this Tamil Nadu ISG study, and this was done across 6 centers of Tamil Nadu, and over a 6 months period, where we looked at acute liver failure and rodenticide hepatotoxicity, not ACLF, but out of 450 patients of rodenticide hepatotoxicity, out of which 150 died, so a very high illness, or a very high mortality. In all these 6 months, only 1 underwent a urgent liver transplant. So even though we realize that transplant may be a good option in this patient, it is really not feasible in most of our patients, even in a state like Tamil Nadu, where there is a organ donor network very active here. So what we had done in one of our studies is we looked at alcoholic ACLF patients, and we took the plasma from these alcoholic ACLF patients and we incubated with healthy monocytes. What we have already said that innate immune system may be the thing driving ACLF. So what we looked at after this incubation at 48 hours is there is a increased homing markers on the monocytes, and there is increased release of inflammatory cytokines and chemokines. So basically the plasma from the alcohol ACLF patients is driving the monocyte driven progression of the disease. So that is why that brings us to the role of therapeutic plasma exchange, and more we are doing it, and a lot of centers are embarking on it. So plasma exchange consists of plasma removal, which is apheresis, and replacement by equal volumes of fresh frozen plasma. The combined thing is plasma exchange. We use femoral line, and we use low volume plasma exchange, which is around 0.5 times the estimated plasma volume. How does plasma exchange work? We still are unclear, but a lot of things are getting removed and a lot of things are getting replaced. One of those, but we are all replacing or removing things from the sinusoids. We are not touching the hepatocytes. So we are only modifying the milieu or the hepatocyte milieu. So we think it is mainly because dialysis has not worked in these patients for years, but plasma exchange seems to be a more beneficial option. We think it may be because the plasma exchange removes molecules which are larger in size. And one of the candidate molecules is von Willebrand factor. In one of our study, we have shown that patients who had survived reduced the von Willebrand factor with plasma exchange. In comparison to people who did not survive, they did not reduce the von Willebrand factor. So plasma exchange does reduce von Willebrand factor, but if reduction is significant, then you are more likely to survive the illness. So this is a recent paper which is almost ready for sending for publication. One is we had compared in alcohol ACLF patients who have undergone plasma exchange as compared to SMT. We'll just concentrate on the brown thing. And we can see, now we are showing a benefit over 1 year time period of survival benefit in patients with alcoholic ACLF. I'm not going into detail, but they are well matched, but not randomized trial, but well matched retrospective cohorts. As far as the data of ACLF is concerned, we have got 2 randomized control trials now, and they are actually quite old trials, 2008 and 2015. They're both in hepatitis B ACLF, which have shown around 15% 3-month survival benefit with plasma exchange in patients with ACLF. And some of the matched cohort studies from India, like ours, also show some benefit in plasma exchange. So I'm going to open it to all panelists about their experience of plasma exchange in ACLF, maybe starting with Dr. Ramkumar.
We have done a lot of plasma exchange only for Ratol poisoning. My experience in ACLF is now.
Plasma exchange in ACLF, I have my own reservations because most of the alcoholic related hepatitis, actually if you give them good supportive care, actually they improve actually. Maybe plasma exchange accelerates the improvement, but I don't know whether it improves the long-term survival. We don't generally use for this particular indication actually.
I agree with Dinesh. I currently see this as being a bridge to transplant rather than saving the patient from a transplant really.
So in ACLF, carefully selected patients, we can use plasma exchange, but only as a bridge. I think I would agree with that. It does not, it can actually worsen also. It can make the patient more sicker. So only as a bridge, when we need the time for the patient to improve or nutritionally to improve, it can be used.
In our hospital, in some patients with drug-induced as a contributory factor, we have seen some good results. In others, it's just like a bridge to transplant.
Okay, so I think more or less what panel is saying is, in acute liver failure, we see quite a good response and quite positive feeling, and acute and chronic liver failure, because it's a very heterogeneous group, and so the response is not very clear, and it is depending on the center to center will have a difference in outcomes here. So what we are using is a low volume plasma exchange with small dose of steroids, and we have continued to use it more and more over the years, and we are almost 50% of these patients are acute on chronic liver failure, and I said we are enthused with the results that we have also in alcoholic ACLF as well. So this is the course of the patient. Patient was not willing for liver transplant. We started on tenofovir, and as I said, low volume plex, just low volume plex and low dose prednisolone. And after 3 sessions, patient was stable and was observed over the next 2 weeks in outpatient. Slowly the MELD score sort of improved. Over the next 6 months, the LFTs have normalized. HbS-AG has become negative, but ultrasound still remains a shrunken liver. We haven't biopsied the liver. So questions that we have discussed and tried to bring out is, one is ACLF. How do we define ACLF? How do we assess the severity in ACLF? What are the common etiologies? What could be the role of inflammation in pathogenesis of ACLF? What is the role of plasma exchange and the confusion around it still, and the liver transplant in ACLF. I thank all the panelists, and thanks for the chair. Thank you.
Thank you, Dr. Ashish. It was a very interesting session. Actually, a question for Dr. Ashish. You have not considered the NAXL score for futility for transplant? Because when you're saying when the boundary is...
Yeah, so if you look at EASL score and AXL score, they are more or less similar. They all talk about organ failures. When you talk about APASL score highly focuses on the liver, the bilirubin per se, and only then the organ failure comes in. So if you have more than 2 organ failures, generally it's considered as futile. So what is shown in one of the recent studies from the US is, you need to convert ACLF3 patients into ACLF2 and then transplant them, they have a better outcome. So if you transplant them in ACLF3, the survival is very less. So this is what, this is based on NAXL score. So when you talk about NAXL score, it's very similar to your EASL CLIF score actually.
So, yeah, I will agree with Dinesh. I think organ failure, as and when more and more organs start to fail, your outcome for anything starts decreasing. For us, plasma exchange as well, we have kept hemodynamic instability as one of the contraindications. So we won't take a person who is in that kind of an organ failure or on patient on ventilator. Again, it's a bit of a difficulty. So as when your cardiorespiratory system start failing, then that is a point where I think transplant also will be very difficult to consider, which is what NAXL futility criteria is.
Which organ matters actually?
And for 1 milligram, there were studies on 1 milligram and factor 8 ratio. You've been doing that too?
We are doing factor 8, ma'am, but we haven't analyzed factor 8 ratio, so I have been very biased in my talk.
Thank you very much. Thank you for all the panelists for the
Thank you.
discussion.
Thank you.
We will be having one more speaker, so I request the chairpersons to be on the dais. We'll be having Mr. Evie George Simon to present a case.
Good afternoon. I'm not speaking on a liver topic. I'll be actually sharing or giving the final update of the Tamil Nadu Okay, I'll be giving the final update of the Tamil Nadu colorectal cancer study. So as we all know, colorectal cancer stands third in terms of incidence and second in terms of mortality worldwide. There's an increase of CRCs in developing countries, including India, which is attributed to changes in lifestyle and dietary patterns. So when we looked at the studies that were available already in India before we undertook this task, the larger studies were from Mumbai and from Calcutta, where we had patient numbers of 800 and 420. And if you see, they are mostly single center and retrospective. But last year or so, we had also the data from AIMS coming up, which was a prospective database, 970 patients, but spanning over 19 years, and these were across various oncology specialties at AIMS. So the aims and objectives of our study were to look at the clinical profile of newly diagnosed CRC across Tamil Nadu under the aegis of the ISG Tamil Nadu chapter, and to assess at what stage they were presenting to us. This was a prospective study, and it spanned across medical colleges and private hospitals in Tamil Nadu. The study period was over 1 year. These were newly diagnosed patients who gave their informed consent, and we collected data. So the last time I presented data, we didn't have data from one center. PHC gave us their data of 98 patients, after which the numbers increased up to 1,208, which makes it one of the largest studies from our country. So the male-female ratio was 1.5:1. The mean age was 57. And Tamil Nadu, being a place which attracts a lot of migrant workers and also people who come abroad for treatment, we see that we were able to get data of the indigenous population in about 82%. For people who were currently residents of Tamil Nadu, that proportion was 84%. We were concerned about the socioeconomic class, and because we had government hospitals participating, we were able to also capture information from them, which was very valuable. And we found that class 4 was the dominant group, and the last 3 classes constituted 78.6% of the total. Hematochezia and change in bowel habits are typically left-sided symptoms, and these were predominant. The predominant location of cancer was in the rectum. That's about a third. But compared to other studies, that proportion was much less in our group compared to others. Again, left-sided cancers, or rather cancers within the reach of a sigmoidoscope, were about 63%. Moderately differentiated was the most common histology. Synchronous cancer and polyps were 3 and 12% respectively. Predisposing factors were about 2%. This morning we heard about colorectal cancer developing in IBD. In this 1,208, we had 12 patients who had an underlying IBD and 13 with FAP. Previous history of any cancer or family history of any cancer was about 3% and 7.6% respectively. Current smokers were 12.9%. Tobacco usage was in 5%. Frequent drinkers of alcohol was 14%. Diabetes was found in a quarter. Obesity, when applying, those in green are when you apply the WHO criteria, and the Asian criteria are those in red. So you see, when you apply the Asian criteria for obesity, we see that in again a quarter. But when we look at people who are either overweight or obese, it's almost close to 50%. Non-vegetarians were about 78%. The overall stage of disease, when we looked with the data that was available to us, we found that it was stage 3 which was the dominant, and late stage was found in 65.5%, showing that a good number present in the late stage. Narrowband imaging is not seen in, it's not there in many centers, so we could get that only in 17%. We did some subgroup analysis of people who were Tamils and non-Tamils. We found that Tamil patients were older, and we found that there were less males, and then people who were non-Tamils had more rectal disease and more advanced stage of disease at presentation. When we compared rectal cancer versus colonic cancer, the rectal cancer was found in more people who were less than 40 years, less common in Tamils, more common in those of low socioeconomic class. Comparing upper and lower socioeconomic class, we found those in the lower socioeconomic class had less number of males, more rectal disease, and were more found in those who were non-vegetarians. When you look at diet, we found that non-vegetarians were younger, and we found they had more males belonging to the low socioeconomic class, and they again had more advanced disease. Now this data was very important because a lot of reports of young colorectal cancer, there were more in males, more rectal involvement, and the new finding was they were more poorly differentiated. So limitations of our study that there was referral bias, it was hospital-based, we didn't look at genetic risk factors or treatment factors, and there was no follow-up in our study. To sum up, it is the largest prospective multi-center CRC study from India. 82% we have local data, 78% affecting the lower economic classes. Left-sided symptoms were the predominant ones. About a third can be detected on PR, 63% using a flexible sigmoidoscope. 65% exceeded stage 2 on presentation. Tamil patients, compared to their counterparts, were older, more males, less rectal cancer and advanced cancer. Rectal cancer was more in younger patients, less in Tamils. Lower socioeconomic class, more in rectal cancer and non-vegetarians, less in Tamils. Younger patients, there were more males, more rectal cancer and more poorly differentiated cancer. And non-vegetarians tended to be more males, lower socioeconomic class, and advanced cancer. This is the most recent update on colorectal cancer from our part of the country. We hope it will help design strategies to improve detection. It provides a good baseline reference for all future comparisons. This activity, which we all did and participated actively, is a good model for obtaining multi-center data. I'd like to thank the chapter for giving me the opportunity to lead this activity. I'd like to thank Ubal, who has been a constant support, my fellow committee members, some of whom are my teachers. I'd like to place on record the idea of this colon cancer study was initiated or mooted first by Dr. Jayanti. My initial plan was to do a stomach cancer, and we shifted that to colon cancer. I'd like to thank all the participating centers, the local coordinators and assistants. It's good to talk to all of them or communicate through mail. The doctors and endoscopy staff in all these 23 centers, and of course, the patients, their families and loved ones who were part of the study. Thank you very much.
Doctor, good and excellent presentation. Normally the data presentation will be boring. Here the data presentation was interesting. In one sense, I am able to interpolate or what to compare the study with what I have experienced in the past 20 years. It is almost matching 99.99% with what I have seen in the practice and the data presented. Hope everybody in this audience will be able to appreciate that. And let this throw light for the future outcomes and future data presentations and further researches. Thank you.
Thank you.
Maybe I'll have a quick question. I think the data is crystal clear. 2/3 of the cancer is left-sided and 2/3 are more than stage 2. I think Epan was talking about hepatologists having a fibrous scan. Do you think that there's a day that you're going to do a FlexiSig for everyone who comes down to the clinic for change in bowel habits? Like the UK sigmoidoscopy trial?
We might end up doing that. Right now in Tamil Nadu, colorectal cancer is the 4th most common in males and 4th most common in females. I think with awareness and with data, I think we may need to do for those who have a persistent change in bowel or recent change in bowel habits. So I think that concept will come up of doing more flexible sigmoidoscopies. Okay. Thank you very much.
Next, we will have our PG session 2. The chairperson for the session are Dr. P. Ganesh, Dr. D. Nirmala, Dr. Shiva, and Dr. B. Sumadi. I request all the chairpersons to take the chair on the dais. We'll be seeing the selected best cases in gastroenterology.
Good evening. I think we'll go to the next session, selected best cases in gastroenterology. We'll straight away start with the first presentation by Dr. Kishore Kumar. I request all the participants to stick to time. Your time is 5 minutes plus 2 minutes for discussion.
Good evening to one and all. My case is about mysterious diarrhea. Here, 41-year-old male presenting with no comorbidities presented to us with complaints of increased stool frequency and duration for 6 months, 8 to 10 episodes per day, which was large volume and watery consistency, and not assured blood and mucus, not assured food intake, and no history of tenesmus, but assured with weight loss. So his past personal and family history were not significant, it's normal. So we proceeded general examination. He was moderately built and his BMI was 21 and no pallor, no dental lymphadenopathy, and head to foot examination was normal, and there is no signs of vitamin deficiencies. And his systemic examination, CVS, cardiovascular and abdominal examinations and neurological examinations are absolutely normal. Proceeded with investigations. His complete blood picture and renal parameters and liver biochemistry were normal within limits, and thyroid function test was also normal, and EOG was normal, and his stool analysis, ovocyst and cultures and blood, alkali blood were negative, and we did upper GI scopy, it was normal, and we took duodenal biopsy and proceeded with colonoscopy, and the first image which shows colonoscopy, large bowel was normal, and entering the ileum, it shows multiple small polypoidal lesions in the terminal ileum, and multiple biopsies was taken from the lesion, and we proceeded with the enteroscopy. Second image, it also shows the multiple small tiny polypoidal lesions in the jejunum and the ileum. The duodenum was normal, and we took biopsy from there also. And at last, the CT report came, and it shows the bowel was normal, and multiple enlarged abdominal lymph nodes in paraaortic, paracaval, mesenteric, and which largest measuring 4x3 centimeter. We did endoscopic ultrasounds, and we saw multiple hypoechoic lesions, and we took FNA from the lesion. So on this, we made a diagnosis whether it could be IBD, small bowel Crohn's, or small bowel lymphoma, or polyposis syndrome like juvenile polyposis, Butte-Segar syndrome, or tuberculosis. That's a possible diagnosis. For our surprise, the report came as dual biopsy was normal, and the US guided FNA and the enteroscopy and colonoscopy all came as a lymphoproliferative disorders. The lamina propria shows monotonous population of medium-sized lymphoid cells with scanned cytoplasm with round cell nuclei suggestive of lymphoproliferative disorders. So we proceeded with IHC. The IHC came as CD10 positive and BCL2 positive. So we concluded the diagnosis of follicular lymphoma. Whether it was primary GA or secondary GA with primary nodal involvement, still we are not made a conclusion. So we proceeded with additional investigations where peripheral smear was normal, LDS was slightly elevated, and USG neck, CT chest were absolutely normal. There was no lymphadenopathy. And the bone marrow biopsy also, normocellular bone marrow, no evidence of lymphoma. So on applying the Dawson criteria of primary GA lymphoma, it satisfied all the points. Absence of peripheral lymph nodes and absence of mediastinal lymph nodes, liver and spleen are absolutely normal, with the predominant bowel lesions with the lymph nodes affected in the immediate vicinity with normal WBC count. So to satisfy the Dawson's criteria for primary GA lymphoma. So we reached a final diagnosis. It is a case of primary GA follicular lymphoma, mainly involving the jejunum and ileum, and the Lugano stage 2 and ECOG1, and the follicular lymphoma international prognostic scoring 1. So I'm here presenting the case because classically the follicular lymphoma most commonly seen in the age of 50 to 60 years. In our case it was 41, and more common in male predominance. And the most common it was duodenum according to many studies, but in our case it was jejunum and ileum. And the most common symptom in most of the cases are abdominal pain, but in this case the patient presented with chronic diarrhea. And the endoscopically we could see multiple polypoidal lesion, but this kind of lesion most commonly seen in mantle cell lymphoma rather than follicular lymphoma. Thank you. Yes, ma'am. Yes. Yes, I'm sure I will. Sure, I will let you. I will. Sir. The patient was treated with the chemotherapy, sir. Because of small bowel involvement, stage 1, Lugano stage 1, we can go for RT as a localized tumor in case of duodenal tumor, but it was mainly jejunum and ileum, so RT was not possible. So in that case, they proceeded with chemotherapy. Patient was treated with CHOP regimen, sir. Because we are not having bendamustine rituximab. The preferred therapy was bendamustine rituximab, but in our institution it was not available. So patient was treated with CHOP regimen. Because of young age of onset, 40 years, 10 to 20% of the cases can go for diffuse large B-cell lymphoma in a span of 5 to 10 years, or it can turn into nodal disease. So the patient was treated with CHOP regimen.
After treatment, how is he?
Sir, he's getting chemo, sir. He's on chemotherapy.
Okay.
He can complete 4 cycles of chemotherapy. Right now, patient was asymptomatic. That's all. We didn't do further. Yes, sir. Diarrhea was settled, but we didn't do any repeat colonoscopy. After therapy, we will follow, sir.
When you did the colonoscopy and found those lesions in the
Yes,
terminal ileum, what was your diagnosis, clinical diagnosis?
Sir, we thought it could be TB, because chronic diarrhea, IBD also, but still we are not came to conclusion at that moment, sir.
Okay.
I never thought of small bowel lymphoma in that case.
Okay.
I never thought.
So what did you think?
Routinely, we will be thinking of TB and IBD, sir.
So you thought of
I thought of like that only, sir. I'm sure.
TB and then
Like that only.
That was the colonoscopy report which you showed white exudate. Okay, doctor. Thank you. Thank you.
Why did you call it mysterious diarrhea?
Ma'am, follicular lymphoma, the general routinely follicular lymphoma is nearly prevalence 1 to 4%, ma'am. So it's uncommon to have a primary GA follicular lymphoma presenting as chronic. That's a very rare situation. So only called as mysterious diarrhea.
Response to treatment to chemotherapy in this patient.
Ma'am?
Response to chemotherapy. Yeah, what is the response?
He was symptomatic. In general, the patient will, most of the patient will respond very, mostly 80% of the patients will respond to therapy, ma'am.
So, in colonoscopy terminal biopsy, what was the report? They are all coincident with the other reports.
Yes, sir. So colonoscopy and enteroscopy reports were similar, sir.
Why did you go for enteroscopy in this case?
Sir, because colonoscopy, my lesion was found in the ileum, so we want to trace it, so we did antegrade enteroscopy, sir. The distal ileum was fully of multiple polypal lesions, so we did an enteroscopy to see the proximal extent of the lesion, sir.
Okay.
Thank you.
Thank you. Thank you.
We'll go on to the second case by Dr. Kondala Rao Edupati.
Good evening, one and all. Today I am going to talk about a case of obscure GI bleed. He is a 35-year male, came to our GRH in October 2022 with a chief complaint of pain in abdomen since one day and hematemesis, which is of 4 to 5 episodes with melena and no hemodynamic instability. He had a similar illness in the past and he is a significant alcohol intaker and smoker since the past 15 years. And his past history, the first presentation he told he is in February 2020, where he had similar complaint of pain abdomen and UGI bleed, where at that time imaging showed acute pancreatitis, OGD and colonoscopy was normal during that time, and CT angio was done, which is normal. So patient after improvement discharged. Again in March 2022, he admitted with pain abdomen and melena. At that time, the imaging showed acute and chronic pancreatitis, OGD, colon and CT angio was normal during that time. And when he admitted in October 2022, we noticed significant drop in HB and serum amylase lipase were elevated. All other blood investigations were normal and imaging showed acute and chronic pancreatitis. We proceeded with endoscopy at that time. Luckily, we have seen that blood oozing from the ampulla with D2 smeared with blood. So again, we probably thought it to be a Hemosuccus pancreaticus in background of pancreatitis. So again, CT angio, abdomen taken to rule out any pseudoaneurysm, but it was reported again as normal. So we discussed the case with radiologist. Then they told there is superior pancreatico-duodenal. They had done digital subtraction angiography. In that, they told superior pancreatico-duodenal artery aneurysm of size 4 into 2 mm of size, and we proceeded with coil embolization of the pseudoaneurysm. This is the coiling of the neck of the aneurysm of the neck, and this is the coiling of the proximal artery. And after that coiling, we have done check angiogram. There is we can see there is no filling of the aneurysm, and these are the aneurysmal coiling and check angio showing. After post procedure, patient uneventful, and patient was on follow-up and hemoglobin improved, and he had no further episodes. Thank you. The aim of presentation is rarity of the superior pancreatico-duodenal artery aneurysm. In presence of clinical suspicion of pseudoaneurysm, even though CT angio is normal, we have to go for further imaging like digital subtraction angiography, which can better delineate the small vascular lesions, and high induction of pseudoaneurysm is needed in a patient with pancreatitis with obscure GI bleed. Thank you.
Why did you label this as rare obscure GI bleed?
Because this pseudoaneurysm of superior pancreatico-duodenal artery is very rare. So less than 2% cases have been reported, and the patient has been investigated 2 times with all the investigations, but patient there is significant HB drop, but where the blood is oozing, we can't able to find out. So I told a case of obscure GI.
He had a CT angio
Yes.
earlier, which did not pick up the aneurysm.
Yes, sir, they did not
Why
pick.
do you think it was like that?
So because of size, sir, 4 mm of size, and it is in the location of the aneurysm is in the pancreatic head, sir. It is an intraparenchymal pseudo aneurysm of the superior pancreatico-duodenal artery.
You said you saw hemosuccus pancreatitis.
No history of trauma or.
You taught me, you've been doing some procedures, no? How often do you get acute pancreatitis and a pseudoaneurysm within 4 days?
Within 4 days, madam.
No, when did the patient get acute pancreatitis? When did the cerebral aneurysm take place?
Madam, generally pseudoaneurysm of visceral artery
No,
aneurysm.
in your patient. I'm just asking in your patient.
The first episode can be due to pseudoaneurysm and second or can be due to pseudoaneurysm only. Madam.
No, this was post-procedure, no?
No, madam. No procedure has been done.
No, without procedure, why do you get an acute pseudoaneurysm?
Because of blood oozing from the ampulla.
Then it is hemosuccus, no?
Hemosuccus pancreatitis.
Yeah, so why do you call it? It is hemosuccus. You said it's not pseudo. You said it is not hemosuccus.
It is hemosuccus only, madam. After, again, CT angio was repeated again normal only, madam. So that we asked again to do any angiogram. Then they selectively cannulated the celiac artery, and in that they noticed that is a aneurysmal there of 4 into 2 mm of size.
Generally, sometimes if you look only for a leak, you might miss the aneurysm. If there is even a small, what you call, blush, that would probably indicate an aneurysm. So probably it was there earlier also.
Yes, sir.
But it is not acute pancreatitis. He developed pancreatic atrophy. Actually, it is chronic pancreatitis.
Yes, sir. Initial report was given as acute pancreatitis.
Chronic pancreatitis rather than acute pancreatitis.
Yes, sir.
Unless you develop a pseudocyst and all that.
Yes, sir.
Thank you.
What is the chance of recurrence? You have coiled the aneurysm. What is the chance of recurrence? And how did you follow this check in this patient?
Madam, we actually didn't coiling of the proximal artery also, because sometimes then depending on the neck size, the recurrence rate will be there, madam. If neck size is less than 2 mm, we can do coiling and they will have less chance of again rebleed. If neck size is more than 2 mm, we have to do coiling as well as embolization, and they will have more chance of recurrence. So we have to do that feeding artery also, we have to coil.
Have you followed this patient?
Yes, madam, we are following.
Okay, what is the advantage of DSA over conventional angiography?
Because in DSA, it will only like digital subtraction angiography, madam. We can selectively canalize what artery we are suspecting, and we can notice the where is the any aneurysm or leak of blood vessel we can notice, madam.
It's a dynamic study, no? So it picks up the leak and even the extravasation in a small amount.
Yes,
madam.
madam.
Therapeutic procedure while doing the DSA and then.
For therapeutic purpose also we will do DS.
CT and if negative, I think you have to go for a conventional angio to pick up that any small amount.
Yes, madam.
Can.
Thank you, sir.
Call Dr. Dinu Abrami to present her case now.
Good evening, everyone. First of all, I would like to thank TNSG for giving me this opportunity. We all know that liver plays a major role in lipid metabolism. So here is a battle between the liver and lipids. So our patient was a 53-year-old gentleman. He underwent liver transplant in the month of March 2021 for ethanol-related DCLD. This was the course of events following liver transplant. And after nearly 16 months, in September 2022, he presented to us with persistent jaundice and pruritus. So the donor was his son of same blood group, and his recent immunosuppression because of chronic rejection diagnosed prior to sending here. He was started on everolimus, tacrolimus and Vicelo. He was a hypertensive for 5 years and a new onset diabetes post-transplant and no other addictive habits. On admission, he was hemodynamically stable except for icterus and scratch marks, no other positive clinical findings, and his BMI was 23.1. So these were the baseline labs. We could see from the LFT that his lipid profile was deranged with, liver function test was deranged, the total bilirubin of 10.2 and a predominant alkaline phosphatase and gamma GT elevation. So baseline work was for cholestasis jaundice was done outside and it was all negative. So this is the CT imaging when he came to us, showing no IHPRD. The portal vein and hepatic veins were intact. So we did on a redo liver biopsy in him. As we could see from the slide, This is the bile plug within the canaliculi, and this is the perivenular inflammatory infiltrate, neutrophilic infiltrate, and this is the central vein showing venulitis. So we also did HLA antibody for his donor-specific antibody levels for him, as his biopsy was suggestive of antibody-mediated immune rejection. That is, the C4D was positive. So these levels were also elevated in him. Other baseline evaluation we could see from the slide, that is vitamin D levels were a bit on the lower side. His T-score was minus 1.1, suggestive of osteopenia. And if we look at his lipid profile, it is erratically deranged. His total cholesterol was 745 with an LDL of 860. So the possibilities considered at this stage, this is an excellent paper in the World Journal of Transplant suggesting the possibilities of this much deranged lipid profile in a post-transplant setting. So possibilities considered in our case was immunosuppression induced, diabetes related, post-transplant metabolic syndrome, cholestasis itself causing dyslipidemia, and a genetic predisposition. So mTOR inhibitor everolimus was stopped, mycophenolate mofetil was added, his D3 and calcium were supplemented, and we started him on lipid lowering therapy with statins and fenofibrate. So diagnosis at this point was in a post-liver transplant patient with hypertension, diabetes, dyslipidemia with all three lineages elevated, cholesterol, triglycerides and LDL with osteopenia. Possibility was immunosuppression-induced dyslipidemia, a combination of cholestasis and graft dysfunction in itself leading on to dyslipidemia, and a post-transplant metabolic syndrome. So further workup and evaluation, if we could see that on day 0 he was started on statins and fenofibrate, and his immunosuppression was TAC, MMF with the Vicelone. And on day 30 still his lipid profiles are in 900s. So this was quite alarming. We took an endocrinologist consult. His previous records were all reviewed, and he was started on ezetimibe. So at this point, after starting ezetimibe 10 milligram, we could see that on day 45 his total cholesterol was 1047 and his LDL cholesterol was 924. So we did on to review all his reports, his pre-transplant lipid profile, family history was done, and all the metabolic workup turned out to be negative. We also did a genetic sequencing which was negative. So at this point we moved on to add this new batsman evolocumab, which is 140 milligram subcutaneous dose given every once in 2 weeks, and after this we could see that his lipid profile is in the downtrend. So evolocumab is a PCSK9 inhibitor which stands at the top of the pyramid of treatment of dyslipidemia. So the mechanism of action is it improves the expression of LDL receptor on the hepatocyte surface, thereby increasing the uptake of LDL into the liver and excretion into the biliary canaliculi. So overall trend of lipid profile, if we see in this patient, initially his lipid profile after starting statin and fenofibrate went up to 1047, and finally after starting evolocumab it has been in the downtrend, and currently his lipid profile is normal. So challenges in this case, a graft rejection requiring higher immunosuppression versus his refractory dyslipidemia despite addition of 3 drugs requiring injectable PCSK9 inhibitor. However, the possibilities of drug interaction between statins and our immunosuppression are to be considered, and graft dysfunction leading on to dyslipidemia and dyslipidemia worsening the graft function are also considered. So a short literature review. Post-transplant dyslipidemia is not uncommon. The incidence is around 50 to 66%, and these are the immunosuppressants which interact with the, which alter the lipid profile.
This up, I think you can come this.
Yes, ma'am. So highlights in this case, post-transplant setting, dyslipidemia with initial refractoriness to treatment and improvement with evolocumab. Thank you.
Nice presentation, Doctor.
Thank you, sir.
But in your center, where you have good number of liver transplants, what is the incidence of post-transplant dyslipidemia?
Yes, sir. So we see the base.
Is there a difference between dyslipidemias and hyperlipidemia? This is hyperlipidemia, not dyslipidemia. Quite high value.
Yes, sir.
So do you treat dyslipidemias? By definition, do you treat dyslipidemias where you may have some alteration in some of the values of the lipids
Yes, sir.
in post-transplant?
Yes, sir. Actually, when we check the lipid profile of our post-transplant patients every 3 months, and when there is an elevation, we start them on statins, sir.
So
Preferably
it is quite common. It is not uncommon.
It is not. The incidence will be around 40 to 50%, sir. So because they are on statins, it is reverting back to normal.
I think it is mostly because of the drugs which we give.
Yes, sir. Mostly because of immunosuppressants.
Especially in patients who have no previous history of dyslipidemia.
Yes, sir.
But probably it is very important to treat not only for the dyslipidemia or the hyperlipidemia, because these patients you may lose because of
cardiovascular risk. Yes,
not
sir.
because of the liver transplant.
Yes,
it's
sir.
very important to bring down the values as so.
Yes, sir. Actually, I wanted to highlight that in the conclusion, because the cardiovascular risk assessment in this patient according to American Heart Association guidelines was very high. So we wanted, endocrinologist also was very concerned to bring down the
risk more than anything else. So it's
yes, sir.
required to bring them down.
Yes, sir. That increases the mortality.
It's nice that you treated this patient and got it.
Yes,
Ma'am, any comments?
I just wanted to ask you this, if it's 40 to 50% dyslipidemia post-transplant, why is this unique? This case is so unique?
Ma'am, the refractoriness to treatment, ma'am.
No,
Usually,
how often have you faced? 40 to 50% means you would have at least got at least 10 or 15% this type.
most of our patients are on rosuvastatin and they respond to that very well, ma'am. If the triglycerides are
what
high,
I'm
we
asking
start
is,
them on.
if 40 to 50% is a post-transplant dyslipidemia, I stand to correction, what percentage would be this? It's not that one case out of that 40 to 50% is presenting like this. Yes, I'm sure I've seen either 10 or 15 cases.
Actually, this was the first case I saw.
I would really like to know that.
Well, I don't think the values are as high as you say. It is quite common, not uncommon, to have dyslipidemias in
post-transplant setting.
Any solid organ, not only liver.
Yes,
any solid organ.
it is more with renal transplant than with liver
Some
transplant.
of them may not require treatment, some of them may require follow-up. But some of them like this definitely requires aggressive management. Dinesh, your views on this?
Yeah, so first thing is how sure that he is taking the drugs, because 1.5 years after liver transplantation is gone on to develop chronic rejection. That means there's a serious non-compliance issues here. And the other issue is probably on the same lines, he's not been taking the medications. That's maybe the reason why it improved its subcutaneous, where you given under observation rather than, because within 1.5 years, if he develops a chronic rejection and the levels have been low, the tacrolimus levels have been low, that means there is some big element of non-compliance here.
So actually our patient, he was a well-educated and well-informed patient and he is very concerned about his lipid profile. So whatever we suggest, he was on compliance when after he came to us. That is maybe before he came to us, we are not sure, but his records do say that, and the patient himself assures that he is compliant. He is well-educated and he wants his disease to be cured.
Okay, we'll close the session. Thank you very much, doctor. Next, Dr. Subratnam Gopalan, please come on to the station.
Good evening, everyone. Today, I am going to present a case foreign body in CBD. 33-year-old male presented with an uneven full laparoscopic cholecystectomy 5 years back. Presented with intermittent right upper quadrant pain for past 1 year. Now aggravated since 10 days and jaundice and fever for 10 days. He had no alarming weight loss or other decompensation features. On presentation, patient was febrile, icteric, and right hypochondrial tenderness, and other system was normal. Patient had, on investigation, patient had leukocytosis, direct hyperbilirubinemia with the transaminitis, and elevated ALP. Total bilirubinemia was 6.7, direct bilirubinemia was 4.2, and ALT 315, AST was 270, ALP was 354. On further workup, ultrasound abdomen, it shows IHPR and CBD dilatation and 2 hyperechoic areas noted in distal CBD each measuring 5 to 6 mm. For further elaboration of lesion, we proceeded with MRCP. It shows filling defect noted in distal CBD causing obstructive biliopathy and upstream dilatation. It was suspected metallic foreign bodies. With this clinical background and investigation, we arrived at the provisional diagnosis of post-cholecystectomy status with obstructive jaundice and cholangitis caused by suspected metallic foreign body in CBD. Patient was managed with IV fluids and antibiotics, and with SGE backup, we proceeded with ERCP. In ERCP, after CBD cannulation, balloon sphincterotomy, then balloon sphincterotomy and balloon sphincteroplasty was done. We attempted balloon rolling cautiously with the metallic foreign body in mind. We are able to successfully retrieve a metallic foreign body and a stone, and the metallic foreign body was removed in toto, which was cholecystectomy surgical clip, and intra-op cholangiogram was done, which to ensure that no CBD was to ensure CBD clearance and no contrast leak was seen. This was a clip showing the metallic clip was retrieving. Hence, we arrived at a final diagnosis of post-cholecystectomy surgical clip migration to CBDs. On follow-up, on post-ERCP, cholangitis was resolved, and LFT was normalized. With on follow-up, patient was completely recovered. Follow-up after 6 weeks, stent was removed. Post-ERCP clip, surgical clip migration was very rare. Because of rarity, I presented this case here. The possible mechanism attributed for clip migration were compression of clipped cystic duct stump by adjacent structures, and too many clip placement, incomplete cystic duct closure, bilioma formation, and necrosis of cystic duct stump, and localized inflammation causing erosion. And methods to prevent this clip migration were use of observable sutures, minimum number of clips, placement of clip away from the cystic duct and common bile duct junction. And clipless cholecystectomy can be considered. Conclusion: post-cholecystectomy clip migration is very rare. Around 100 case reports were reported so far in literature. And though the post-cholecystectomy clip migration was very rare, there should be a high index of suspicion needed in case of patient presenting with the post-cholecystectomy status with residual or recurrent CBD stones with or without cholangitis. These are some articles, similar articles with the surgical clip migration. Sir. Thank you, sir.
Very good, Doctor. Good presentation. In this case, why did you place a stent in CBD?
Sir,
you confirm there is no filling defect.
Sir, in view of cholangitis, we placed cholangitis, and we had injected we did intra-op cholangiogram. For that, we placed stent, sir.
You used a balloon to draw the clip.
Yes, sir.
There was no problem? Metal clip, do you think the balloon will break?
Sir, around...
Is it better to use some other device rather than balloon?
Sir, around... Sir, we can use spike cholangiogram also. Spike cholangioscopy also.
No, you've done this, you've removed it.
Yes, sir.
But then, did you anticipate a problem when you used the balloon?
Sir, puncture of balloon will happen.
Okay, Doctor.
Okay.
Any comment from the surgical experts?
Dr. Kanan, sir.
I have seen only one case The probable reason could be cystic duct is occluded very close to the CBD. Because of the necrosis, it might have migrated into the CBD. That's all I could explain. The only way to prevent is using the absorbable clips. I've seen only one case.
Thank you.
Thank you, Doctor.
Next presenter, Dr. Asisha Janila.
Good evening, everyone. I'll be presenting this case, Double Trouble. So this is the story of Mr. X, a 22-year-old gentleman who presented to us with progressive jaundice for 4 weeks, abdominal distension for 3 weeks with bilateral pedal edema. There was no decreased urine output. There was history of complementary and alternative medicine intake after the onset of jaundice for 2 days. There was no fever, no prodromal symptoms, no abdominal pain, no bleeding manifestations, and no altered sensorium. Relevant past and family history, his antenatal, natal, developmental history was normal. However, family does report history of pigmentation of the palms, soles, since childhood, since he was around 10 years of age. There was also history of loss of scalp hair. Now, he was born out of second-degree consanguineous marriage. His maternal aunt also had history of pigmentation of the palms, soles, and sparse hair. So this is the pedigree chart. His elder sibling died at the age of 18 years. He was also noted to have reticulate pigmentation of the palms and soles, delayed milestones, poor scholastic performance. He developed jaundice 1 year prior to death. His ultrasound had shown coarse ecotexture of liver, and bone marrow had mild hypocellular marrow. Now going on to examination, his vitals were stable. He had icterus, he had bilateral pedal edema. His oral cavity showed leukoplakia. This is the examination of his skin. He had these hyperpigmented reticulate pigmentation of the palms, soles, and over the anterior wall of the chest. Looking at the nails, he had pterygium, he had thinning of nails, and these longitudinal ridging that was present. His scalp had alopecia, as can be seen. His systemic examination, abdomen was soft, non-tender, splenomegaly was there, and there was shifting dullness. Other systemic examination was normal. Looking at the baseline investigation, what I would like to draw attention is he had a pancytopenia, his HB was 11.6, total counts was 3,400, platelets of 42,000. His LFT had a bilirubin of 15.6, 13.8, liver enzymes of 75, 35, and ALK was of 164. All other workup for jaundice was negative. Ascitic fluid analysis was a high SAG, low protein ascites. Ultrasound showed features of chronic liver disease. There were no varices. Doppler showed attenuated portal vein. Bone marrow showed a normocellular marrow with erythroid hyperplasia. Now with this basic history, examination, and investigation, our differential diagnosis was of an acute on chronic liver failure. Acute, we were not sure of. Contributory CAM was considered. Chronic, again, we were not sure of. But with this clinical syndrome of a pancytopenia, abnormal skin pigmentation, nail dystrophy, leukoplakia, and liver involvement, the differentials considered were 1, a dyskeratosis congenita, and second, we also thought of an arsenic toxicity. Going on with his evaluation, we did a HVPG. His HVPG was 19, suggestive of portal hypertension, and liver biopsy was suggestive of cirrhosis. These are his slides showing nodules. Now, on the liver biopsy, we also did the TERT promoter mutational analysis for C2280 and C250, which were both negative. We did a whole genome sequencing, which showed a PRKCD mutation, which had uncertain significance. We went ahead and got a dermatology opinion. So with the clinical triad of skin, nail findings, a probable dyskeratosis congenita was made. A hematology opinion was also sought. Bone marrow suppression with liver involvement and skin findings. Again, a probable dyskeratosis congenita was thought of. So our final diagnosis was a patient with acute on chronic liver failure, acute not sure, chronic of dyskeratosis congenita, with a syndrome of what I mentioned, a diagnosis of dyskeratosis congenita was made. This is a slide showing the 4 patients we've seen over the last 5 years. The first patient is what I presented. The remaining 3 patients also we saw in our, as our IP patient. So all of them were young males. All of them had liver, skin and bone marrow involvement. 1 had ACLF, the other 3 were incidental CLD. 2 had large esophageal varices. All had pancytopenia. 3 of them had specific mutations for dyskeratosis congenita. 3 of them had stanozol, danazol as treatment. 2 are being worked up for bone marrow transplant. So one slide on dyskeratosis congenita. It is a problem of telomere biology whereby there is shortening of the telomeres. So it's a rare progressive bone marrow failure syndrome where there is a triad of skin, nail, oral involvement. Now liver involvement is a varied spectrum ranging from incidental to cirrhosis. Going on to take-home message, it's a rare condition. Liver involvement is vast. Early recognition of clinical signs may lead to a better management. Thank you.
Good drag presentation. What is the cause for liver failure in this patient?
What is the cause, sir? So the acute cause, we are not sure for the ACLF. There was history of CAM intake. However, we are not sure of the acute hit. The underlying chronic liver disease was probably dyskeratosis congenita.
So did you have a clinical diagnosis of dyskeratosis, or was it proven by genetic studies which said did not contribute in this patient?
So
the clinical picture is quite significant.
Yes, sir. So the diagnosis of dyskeratosis congenita is mainly clinical. 60% of them may have mutations, but there is 40% which may not have mutations.
So what is the cause for liver disease in these patients?
So the pathogenesis that they've explained is shortening of the telomeres. So shortening of the telomere leading to cell apoptosis, cell senescence is the same pathogenesis that they've explained for liver cirrhosis also.
Okay, but he had multiple hits also.
Yes.
CAMS plus something else also.
Yes.
Very interesting, doctor.
What's the age of presentation usually?
Ma'am, usually it is the first decade. Around 10 to 15 years is when the skin manifestation begins. And mortality is usually by the second decade. There is high mortality.
What a mutation of uncertain significance. Did you do it for the parents?
Did we do? There is his elder sibling who died had a mutation and analysis. They said which was positive, but we didn't have the reports, ma'am, of that. We have not done their parents also.
4 patients. Which patient is this?
So the first one. The other 3 had specific mutations.
What is your plan?
Yes, sir?
What is your plan?
So this patient, it was conservative management. There are other 2 patients who are being worked up for a bone marrow transplant.
Bone marrow transplant.
Yes, ma'am?
Planning bone marrow.
Bone marrow transplant.
What about the liver then?
Ma'am, there are literature, there are very few cases of liver transplantation in dyskeratosis, maybe 1 or 2.
Did this patient have bone marrow failure?
So it's a spectrum, sir, of the he had a pancytopenia, but bone marrow did not show a hypocellular marrow.
So why are you planning for transplant?
Why bone marrow? No, there no immunological manifestation in this patient. Why bone marrow?
For this patient, it was conservative management, ma'am. The other 3 patients that we had shown had...
They are associated with marrow.
Yeah.
Sometimes systemic mastocytosis can present with hyperpigmentation, progressing to decommon liver disease as the age advances.
Sure, ma'am.
Thank you, doctor.
Thank you.
Next presenter, Nischal Mundak.
Good evening, respected faculties. I'm Dr. Nischal from Government Kilpauk Medical College. I'm presenting a case. The patient is a 55-year female homemaker residing from Kanchipuram. She presented with the chief complaint of difficulty in swallowing, followed by loss of weight and loss of appetite since 5 months. Presenting illness, she had dysphagia since 5 months, insidious in onset and progressive, from solid to semi-solid, and it was associated with the feeling of stuck-up sensation in the throat. There was no history of associated with cough during swallowing, or rhinophagia or hoarseness of voice. There was also no history of gurgling of swallowing, swelling in neck, or coughing of foot debris. There was history of unintentional loss of weight over 5 months, which was unquantified, but it was appreciated by the patient as loosening of clothes, and there was also global loss of weight. There was no history of similar complaint in the past. She is a known case of diabetic and taking oral medication, no history of caustic injection or NSAID injection, and there is no prior history of endoscopic procedure or surgery. Personal history and family history are not significant, and she is having a calorie deficit of 700 kilocalories. On clinical examination, patient BMI is 16 kg per meter square. Apart from that, everything was normal. There was no cutaneous signs of GI malignancy, no thyromegaly. On systemic examination was also unremarkable. On investigation, hemogram showed 8 grams of hemoglobin. Apart from that, everything was normal. So we did an endoscopy which showed a nodular lesion at 30 centimeter from incisor with ulcerated mucosa at apex. Stomach had antral erosion and duodenum was normal. We did a histopathology which showed a dysplastic squamous epithelium and subepithelium, which was replaced by columnar pattern with distended melanophagocytes, suggestive of esophageal melanoma. Then we followed by immunohistochemistry, which was positive for S100 and HMB 455, which is diagnostic of primary malignant melanoma of the esophagus. And we did an imaging. CT chest showed a circumferential wall thickening in the mid-esophagus, and we did a CT abdomen which showed 2 hypodense lesions in the right lobe of liver. We did a PET CT for looking for the staging of the disease, which showed a primary neoplastic esophageal growth with mediastinal mets, liver mets, and multiple skeletal mets. So with no cutaneous primary manifestation with skin manifestation of melanoma, we arrived with a diagnosis of primary malignant melanoma with a TNM stage of 4B with diabetes type 2. So we referred patient for further treatment, but patient denied for the treatment. She succumbed to her illness. So what is so special about this case? A systemic review was done and it was published in 2021, which showed 374 cases till today, and the first case was reported in 1906. And why it is important to distinguish between primary versus metastatic melanoma? First of all, mets to the esophagus is very rare, and mets are either from breast or either from melanoma. That's why it's very important to differentiate between it is a primary or metastatic melanoma. The features suggestive of primary melanoma, there should be no cutaneous manifestation of melanoma. Apart from that, and it should fulfill the criteria for diagnosing a melanoma. A normal presentation is dysphagia is the most common presentation, and on presentation 40 to 80% of patients will already have a metastasis, and the most common solid organ metastasis will be a liver. Endoscopic appearance, it is generally a polypodial mass, and with melanotic appearance, 85% will have melanotic appearance, but 15% will have amelanotic appearance, as it was in our case. And diagnosis, endoscopic biopsy is the definitive way of diagnosing with the immunohistochemistry. And HMB 445 is the most specific for diagnosing primary malignant melanoma. And FDG PET set is most important for diagnosing metastasis. Surgical resection is the primary mode of treatment, and overall survival rate is less than 5%. And NF1 has been shown to be most frequently muted gene in the recent advances. And take-home messages, it is a very rare tumor with very minimal case report presented and very minimal ways to treatment of the same disease. Novel therapy with PD-1 inhibitor are showing some promising result, but yet to be substantiated. Thank you.
What was the stage of the disease when you made the diagnosis?
Sir, it was stage 4B, sir, already metastasized.
Didn't metastasize?
Yes, sir.
Okay. There was a supraclavicular node also, according to...
So it was not palpable on CT, it was fine, but on clinical examination, it was not there.
So, what was the surgical advice?
Sir,
you got the surgeons to see him.
Yeah, we advised, but she refused for it because we explained that it is...
What surgery can you offer him?
We referred for the further treatment, sort of palliative treatment. Actually, ideal treatment, we will advise patient for going esophagectomy, followed by chemotherapy.
He's already stage 4.
Sir,
did you consider him? He came at this stage, yeah?
Sir, case reports are there, patient having any surgery. After esophagectomy, there are 5 to 6 months more survival benefit after that.
But he's already advanced, no? He's in stage 4.
Yes.
Why didn't you palliate him for the dysphagia?
Palliative treatment for dysphagia is like STEMS placements.
Why didn't you do that?
So
He's come to
unavailable.
you, no?
Did
He's
you
come to
offer
you.
the treatment for
Why
the
didn't you do
patient?
that? Okay. then.
Unavailable, sir.
Thank you.
Thank you, doctor.
The next presentation is by Dr. Omkar Singh Mathuru.
Good afternoon to all present. My case presentation is regarding a case of pain abdomen. My title is Expect the Unexpected. Starting with case history, 54-year-old female presented with the vague, non-specific right hypochondrial pain for a period of 2 weeks, which was intermittent, non-radiating, not associated with any aggravating or relieving factors. It was associated with the nausea, vomiting since 5 days, which was non-projectile, non-bile stained, and no blood and vomitus. Moving on to the case previous history, patient had a history of acute necrotizing pancreatitis, which was diagnosed in November 2020 with a CT severity index of 6/10, which was managed conservatively, and patient was discharged. Moving on to examination, patient had moderate build and moderately nourished with a BMI of 22 kgs per meter square. Patient was vitally stable only mild tenderness was there in right hypochondrium, other system was normal only. Moving on to investigations, patient was having a fairly normal CBC with LFT. RFT was also normal with the normal creatinine of 0.9. Patient's serum amylase was done in view of pain abdomen, which was normal only. Urine routine show no proteinuria, no RBCs with the ESR of 24. ANA was negative, normal triglyceride level. CA99 was done to rule out cause of pancreatitis after ruling out all normal common causes of pancreatitis, which was also normal. Upper GI endoscopy came out to be normal, and side view scopy showed normal ampulla. Moving on to CT, this is a CT abdomen with the IV contrast. The CT abdomen is showing mildly thinned out in a axial plane. It is showing mildly thinned out pancreas with a small cystic lesion in the neck of the pancreas, 1.3 cross 1.3, which was later confirmed on ultrasonography as with the well-formed capsule, labeling it as a pseudocyst. Moving on, as we trace abdominal aorta, there we can trace celiac artery. As we move down, there is SMA branching, and moving on down, we can see imprisonment of left renal vein between SMA and abdominal aorta. Further tracing it down, we can see a dilatation of left renal vein with dilatation of lumbar vein. This diameter, left renal vein diameter came out to be 1.7 with left gonadal vein also dilated. On coronal section, we can see a dilated left renal vein with a dilated left gonadal vein. This is abdominal aorta giving a branch of SMA. Provisional diagnosis of nutcracker phenomena was kept, and there we can see some filling defect, probably suggesting thrombus. On sagittal section, we can see abdominal aorta giving a branch ciliate trunk and giving SMA branch. Here we can see imprisonment of left renal vein, making an acute angle. This phenomenon is called nutcracker phenomena. This is 3D constitution showing same findings only. So final CT report is saying left renal vein appear compressed between superior mesenteric artery and abdominal aorta, with proximal dilatation of maximum diameter of 1.8 with 15 cross 11 mm filling defect suggestive of thrombosis, with left venal vein diameter of dilatation with maximum diameter of 1.3 and multiple tortuous veins in bilateral parauterine region. However, the pancreas was showing 1.3 cross 1.4 centimeter cystic lesion suggestive of pseudocyst. Final impression of nutcracker phenomena with thrombosis in the left renal vein with pelvic congestion syndrome was kept. This was confirmed on Doppler ultrasound, which was showing acute angle, aortomesoteric angle less than around 25 degrees. Moving on to discussion, nutcracker syndrome is very rare entity with the prevalence and natural course is very poorly understood. There are two terminologies. One is called nutcracker phenomena and nutcracker syndrome. Nutcracker phenomena is simply presence of left renal vein compression between IVC and aorta, whereas if this produce symptoms, it is called nutcracker syndrome. Because of variability in symptoms and absence of any consensus on diagnostic criteria, the exact prevalence of this syndrome is unknown. However, it is believed that it is more common in females. Usually patients present with hematuria, which is usually microscopic, with orthostatic proteinuria, flank pains, and gonadal varices. Very rare, it presents with chronic renal disease and renal vein thrombosis. So usually these patients are presented with asthenic constitution. That is, these patients are usually thin lean with reduced retroperitoneal mesenteric fat. Yes, sir. Usually investigation tries of Doppler ultrasound, which is confirmed by CT and MRI. These radiological findings in review of literature only came to a point that beak sign is there, whereas left renal will have diameter to the ratio to aortomesenteric diameter more than 4.9 with acute angling of SMA branching from abdominal aorta. This has a sensitivity of around 90%, which is we have seen from the literature. These are few case reports. First case report was around, this is from 2013. What make our cases more interesting is only 4 or 5 articles are there suggesting renal vein thrombosis, nutcracker syndrome presenting with renal vein thrombosis. So in that case, our finding is rarest amongst a rare case. Learning point is with pain abdomen presenting with hematuria, usually we should consider nutcracker syndrome as a possibility. These patients should be followed up because they can present with end-stage renal disease. So. Sir, there are 2 criteria to manage the patient. Usually these patients presented in young age. In a young age.
How did you manage the pain in this patient?
Sir, this patient has mild pain only, that is non-specific, which is very common. This patient, we started this patient on anticoagulation in view of thrombus. However, there was no collaterals. With starting with the anticoagulant alone, patient pain settled and patient is on regular follow-up. After 3 months, we are planning to do a repeat ultrasound to check for the status of thrombus.
How would you follow up this patient?
Sir, actually, usually these symptom is not affecting the quality of life of that patient. We can follow this patient conservatively. There is no consensus on what treatment has to be given, but what literature says, few articles only, this is saying conservative management for 6 months. If after 6 months patient is not recovering, then we can plan some surgical intervention. Had this patient been...
We appreciate you to have made this diagnosis, but for mild abdominal pain, did you have to do all these tests?
Sir, this is more of incidental finding.
You have to do all these
But since this patient had a renal vein thrombosis, that makes, if had this patient not been tackled, he would have come with the renal dysfunction that would have...
Ask for tests. Patient has to pay for everything, na?
Yes, sir.
So will the test benefit? Will it impact his treatment?
Sir,
After doing all these tests, did it impact your management of pain? You say not give anything for pain.
Sir, if had this patient not tackled now, this would have come in a later 6 months, 7 months, patient would have landed in with the renal dysfunction. That would have even causes more poor quality of life later maybe. We have started on anticoagulation only, ma'am.
Only anticoagulation. Thank you, doctor. Thank you. Thank you.
So next I will call upon Dr. Paila Ramesh, last presentation.
Good evening to respected professors and delegates. I am presenting a rare case of multiple splenic artery pseudoaneurysms in a patient with idiopathic portal hypertension with splenomegaly. So I want to tell a small incident what happened. This child during childhood who explained A plus B whole to the power of n, he joined as he joined medical school. One of our HOD went as examiner. He asked tell the 3 causes of non-pitting edema. So that child who grown as a MBBS student, he told first cause as pulmonary edema. So really surprised our sir. He asked with excitement, what is the next cause? So then he told papillary edema. So after little more excitement, he asked what is the next cause? Cerebral edema. Our HOD sir came outside exam hall. So sorry. My case presentation is a 40-year-old female presented with complaints of easy fatigability since 2 months, abdominal distension since 2 weeks, and history of melena 20 days back for 5 days. He referred to RGGH in view of abdominal distension and severe anemia, admitted on 16/10/2022. So no other significant history, no history of similar illness in the past. Is not a known diabetic, hypertensive, CAD, CKD, not on regular medication. On examination, patient is conscious, oriented, afebrile, vitals are stable, only pallor is there, abdomen is distended, and splenomegaly is there, and free fluid is present. PR examination, no melena. Other system examination normal. On the day of admission, hemoglobin is 6.2, total count 1200, platelets is 68,000. LFT 1.9, total protein 6.4, albumin 3.2, INR 1.65, viral markers are negative. So we did ultrasound abdomen, it showed normal liver echoes with splenomegaly and ascites. We did portal vein Doppler, it shows portal hypertension. So upper GI endoscopy we did, it shows large esophageal varix with two column with severe portal hypertensive gastropathy. So in view of portal hypertensive gastropathy and esophageal varix and abdominal distension, we did CT abdominal angio to rule out chronic Budd-Chiari syndrome like that we suspected. It showed large broad-based saccular outpouchings noted from the distal splenic artery, posterior-inferiorly 12 into 16 mm, posterior-superiorly 12 into 16 mm, posterior-inferiorly 6 into 6 mm, anterior-inferiorly 9 into 10 mm, and distally 1.8 into 1.6 centimeters and inferiorly 10 into 6.7 mm. Like this, multiple pseudoaneurysms are there. And portal vein is 21.3 mm, splenic vein 29.5 mm, appears tortuous and dilated. Few perigastric collaterals are noted. Many of the aneurysms showed peripheral wall calcification. So hepatic vein and IVC appears normal, pancreas appears normal. Impression is multiple pseudoaneurysms from the distal splenic artery and its branches, tortuous and dilated portal vein and splenic vein, massive splenomegaly with few perigastric collaterals and minimal ascites. That CT abdominal angio showing multiple splenic artery pseudoaneurysms. Diagnosis is multiple splenic artery pseudoaneurysms with idiopathic portal hypertension with splenomegaly with ascites and recent UGI bleed. We went to literature regarding this case because splenic artery pseudoaneurysms are commonly we will see in chronic pancreatitis or else sometimes acute pancreatitis, sometimes iatrogenic trauma. So literature, it shows that BMJ 2019, one article published from the AIMS, it showed that splenic artery pseudoaneurysms are rare complication of non-cirrhotic hepatic fibrosis and are usually asymptomatic. Follow-up of these patients with ultrasound Doppler is imperative. Large size of splenic artery aneurysms, lack of wall calcification on the CT are predictors of the risk of rupture and dictate the management of decisions. Other article in 1992, it showed that splenic artery aneurysms in cases of portal hypertension may be consequence of the hyperkinetic state in spleen. Management, what we did means initially we treated with IV fluids, proton pump inhibitors, diuretics and blood transfusion 2 units given. After that for esophageal varix we did banding and we started antibiotics and beta blockers. Patient responded to treatment well and no further drop in hemoglobin, ascites reduced, patient on regular follow-up. We have doubt regarding what we have to do regarding that splenic artery pseudoaneurysms. So we took opinion from the surgical gastro, from in MMC, SGE, good support they will give, and interventional radiology opinion also we taken. So they told we will observe after seeing all literature articles, we will follow up like that, they discuss. So patient on follow up, these are the...
Can you summarize, please?
Yes, madam. Yes. Conclusion, splenic artery pseudoaneurysm is an uncommon vascular lesion and pathogenesis is not well understood with variable presentations and dreaded complications. Literature recommends to repair the splenic artery pseudoaneurysm of any size with or without symptoms secondary to pancreatitis or iatrogenic injuries. But in splenic artery pseudoaneurysm secondary to portal hypertension of size up to 2 centimeters with peripheral wall calcification can be managed conservatively with beta blockers and regular ultrasound Doppler scanning. It requires further follow-up studies. Thank you. Madam. Yes, madam. Yes.
What do you think has happened? Yes, the patient has got dilated. This we have seen quite often. It's like a chicken and egg story, no?
Yes.
Which has come first. So usually it is a problem in the liver, yes. NCIPH, causing huge dilated aneurysmal dilatation of the portal vein and splenic vein and the artery. So if you start attacking the artery, you'll get splenic infarcts,
yes,
and you lose the patient.
Yes,
22 centimeter spleen with a dilated portal vein in this thing, it is NCIPH. Yes, so I think it's only observation and management of portal hypertension, not to intervene in these patients. When it's more than 2 centimeters, it's a very tricky story what to do.
Yes,
we have lost patients.
Yes, madam. Yes, madam.
Okay,
in
so
this patient, we are follow-up.
No, follow-up is nothing. It's just management of portal hypertension. Keep the pressure down.
Yes, ma'am.
Because if you do coil embolization of the splenic artery, you'll have splenic infarct, and then you lose the patient.
Yes, madam.
Liver biopsy indicated?
No, it is NCIPH.
Yes, madam. And we have doubt regarding this NC. What review of literature is telling that because of splenic whatever madam told, splenic hyperkinetic state is the reason for the pseudoaneurysms in this.
Yeah, it's a reverse. It's a reverse.
Yes, madam.
The artery, then the spleen, and it's artery aneurysm.
Madam. Yes,
but it may also be forward flow portal hypertension.
Yes, madam.
Maybe primarily it is arterial flow. What is a Doppler study? So Doppler study will be informative. What is the flow pattern? If you have a splenic artery, you'll have it to be a forward flow portal hypertension. So that has to be ruled out.
Yes, madam. And one more thing is...
Thank you. I think we just conclude the session.
We'll conclude. Thank you for that exciting presentation. Seem to be very excited. So, thank you very much. I think we close the session and we thank all the presenters for the excellent presentation. Thank you.
Our next session is Gastro Upgrade Session 2. The chairpersons of the session are Dr. M. Radha, Dr. D. Kannan, Dr. M. Manimaran, and Dr. Raghavendra. I request all the chairpersons to take the seats on the dais.
Good evening, friends. So let's start the first speaker. By Dr. Govind Makaria. He is going to talk about H. pylori, which is a common problem we all gastroenterologists face in the clinical practice.
Thank you, chairpersons. Very good evening, everyone. Thank you, Dr. Ubal, the Tamil Nadu chapter of ISG, and all the Dr. Ravi, and all the members of this committee for kind invitation. I think it's a wonderful meeting. We had very good cases in last session, quite a learning in that. Coming to a very common problem, which is Helicobacter pylori. So to do that, let's take a case, and this 59 years old lady who came to us with symptoms of dyspepsia, mainly postprandial distress syndrome, for 6 months, and she also had nausea and early satiety. Since her age was high, we thought we must do endoscopy, and endoscopy showed there is a lesion in the antrum, which was a nodular lesion with ulceration in between. Certainly this was a lesion which was very relevant, and therefore we took biopsy from here. The question is here, you do biopsy for histology, but do you do biopsy also for what else we do? The question was, should we also test for H. pylori? And I want to ask how many people will say we take biopsy for H. pylori? How many people will say that? I think everyone will do testing for H. pylori in this subject. So what are the conditions where we test for Helicobacter? In those patients who have peptic ulcer disease. Patient coming with upper GI bleeding, we do endoscopy, find an ulcer, must take biopsy for Helicobacter. If not then at a later date. That's number one. Anybody who suspect mild lymphomas or lymphomas, adenocarcinomas, or if you are doing EST for early gastric cancer, even then we must do biopsy for or look for H. pylori in them. And in those patients who require long-term treatment with NSAIDs, we test and treat for H. pylori, and also those patients have gastric atrophy. Other controversy stays that what to do in our country in those patients who come with dyspepsia. And a lot of, there are two schools of thought. One school of thought say we should do it, others say there's no need. And no need school is probably is larger compared to those who believe in testing and treating the patient. Again, over time we must resolve this question, but I personally believe that if there is dyspepsia, should investigate for H. pylori and treat them. And other conditions like those who have a ITP or iron deficiency anemia should look at H. pylori. So if you plan to do testing, what test? I think it's known to every one of us, but just to make a summary, if you're doing an endoscopy, then certainly you do RUT, do biopsy, but if you're not planning to do endoscopy, like most patients with dyspepsia will not require endoscopy. In those situations, we'll do either urea bed test, which is a non-invasive test, or stool antigen. Stool antigen may not be available everywhere, might be expensive, but these are the options we have. Serology has no role in clinical practice. This is done only for looking seroepidemiology of H. pylori. From there, so this lady underwent testing, found to have a maltoma on biopsy, and she was H. pylori was positive, RUT was positive, biopsy also showed H. pylori, and also her UBT was positive. So certainly she had a mild lymphoma with H. pylori. We showed to a medical oncologist, and she was planned to give anti-HP treatment and put her on surveillance. and no resection, no chemo was decided at this point of time. So question of who are the patients we should treat patients? Straightforward, those who have peptic ulcer disease, those who have maltomas, those who have adenocarcinomas, those who have a early gastric cancer doing ESD and find H. pylori, and those who have a long-term NSAID treatment. And also, again, I said dyspepsia, a lot of people believe that most guidelines in Europe, America, and also in Japan, and even our own Asia Pacific guidelines says that patients with functional dyspepsia should be tested for H. pylori, either invasive or non-invasive. If positive, treat them. But in our country, we still don't have a great consensus on this. So while we treat, I will put forward to you 4 relevant points which are very important and we must consider in each and every patient once we plan to treat H. pylori. Number 1, the goal of treatment should be that at least we should treat or eradicate by our treatment 90% times. This is the most critical thing. Thus, giving antibiotic is not the answer. I must use the antibiotic which is going to work. So my end point will be at least in 90% times I must eradicate H. pylori. And to do that, and we know that in our country, and many other countries, H. pylori is taken non-seriously. Just prescribe treatment for H. pylori, write some drugs, some antibiotic, which are not exact, they are not full dose, they are incomplete, and that we must avoid. So there are three things: appropriate regimen, appropriate duration, and appropriate patient compliance. All three are important to achieve 90% eradication. The second point, and basic philosophy of treating H. pylori is that is combine acid suppression and also give not one but two or more antibiotics. Why acid suppression? We give PPI twice a day. This is important. I think all of us would know that at high pH, bacteria multiply, and therefore your antibiotic will work. Therefore, you give double dose PPI to raise the gastric pH to 6 to 8. Therefore, bacteria multiplies, your antibiotic works. Therefore, double dose PPI. And antibiotic, we know all antibiotics which are being used, most important being erythromycin, which is the heart of treatment, and also amoxicillin. And there are many other antibiotics. Will come back as we talk of regimen. And third, I would like to you think again that bismuth is very important part of H. pylori treatment, which is underutilized, and this drug is now available again. So bismuth must be considered to be used in patients once you want to eradicate H. pylori. Further, coming to what are the regimens, the standard regimens is what we call standard triple regimen, triple drug, where we have a PPI, and we have antibiotic. So we have PPI, we have antibiotic, and also we'll have two antibiotics. Point out to highlight here, metronidazole, although the Western guidelines would say metronidazole to be used in H. pylori, but in our country, 90% times there is resistance to metronidazole. Therefore, you must not use metronidazole. Even their textbook says, or even the guidelines says, metronidazole in our country must not be used for H. pylori. Then again, we have bismuth quadruple therapies, and where we have used bismuth, PPI, and two antibiotics. And three other concepts is concomitant regimen. It means give antibiotics in full dose, 2 to 3 antibiotic, PPI kind of thing, use sequential therapy and use hybrid therapy. So any of these are good, and we can use any one of them. So, and these are guidelines to suggest that which drug to use, but most important, what to do now. So which one to choose. And in H. pylori, there have been a lot of experience. So this is the network meta-analysis of 117 RCTs, which summarizes what is the right way to treat H. pylori today. And what the 3 or 4 principles this network shows. First, that bismuth-containing regimens are much better compared to other regimens. Number 1. Number 2, duration 14 days is much better than 7 days. So 7 days or 10 days is now out all over the world, but certainly in our country. In those states where high chance of drug resistance to erythromycin, then standard triple therapy is if there are low resistance rate, triple therapy, if high resistance rate, quadruple therapy. And consider using bismuth in all the regimens. So there are basic guidelines now that you use most of the time bismuth-containing regimen and 14 days, not 7 or 10 days. So coming back to the patient, we talked about a patient who has a maltoma. And so in this patient, she has maltoma. We asked about antibiotic use earlier. She denied of using levofloxacin earlier. So we gave her standard first-line treatment and she had good compliance. The question is that in this patient, would we do repeat endoscopy or not? Or test for H. pylori again? She has maltoma. We're giving H. pylori treatment. Therefore, we must go back and see had the lesion regressed or not. If not, more therapy, right? And also to confirm has H. pylori has been eradicated or not. So the conditions where we confirm HP eradication are HP-associated ulcers. Anybody had duodenal ulcer and you treat for H. pylori, always go back, either endoscopy or non-invasive, to confirm that bacteria has been eradicated. This is number 1. Why it is number 1? Very important. because peptic ulcer will reappear if you don't eradicate appropriately. So appropriate eradication is the key to avoid recurrence of peptic ulcer. And so is lymphoma, so is carcinomas. You must demonstrate eradication. So in this patient, we looked at, we went back to again, and since wanted to look at lesion and want to look at did she have lost H. pylori or not. What showed endoscopy? Lesions were better, but not healed completely, and so are still positive for H. pylori. Therefore, question comes, is it a refractory disease or refractory H. pylori, or this is a recurrence of or reinfection? So just to know, reinfection occurs generally we define after 1 year of therapy. So this is within 3 months. So this is so we could not eradicate. This is called refractory H. pylori. So what do you do in that situation? Important to realize the refractory, the most important cause globally and also in our country is this one, that we do use inappropriate antibiotic. Sorry. We use inappropriate antibiotic, poor adherence by patient. We don't explain. Write prescription, take this drug for 14 days. Doesn't work. This is very important. HP eradication is an important task, and also sometimes other bacterial factors. But most important is our own failure explaining to patients well. Also, drug resistance is important, and drug resistance is common sense. That if you use antibiotic for a long time, which country or which antibiotic, which bacteria will not develop drug resistance? And therefore, look at this as a resistance study in relation to H. pylori. Metro resistance is 42% globally, but in our country, 80 to 90%. Levofloxacin, 40%. Clarithromycin, 30%. In our country, maybe much more. Amoxicillin, good. There's no resistance. To amoxicillin, resistance is much less, and also to bismuth, there's no drug resistance. And this is our own little data. Not own means our country's data. Very little showing that there are certain pockets where clarithromycin resistance is prevalent. Further, so coming back to this patient again, what to do? She has refractory H. pylori. So what to do? So we give her next antibiotic. We gave her quadruple therapy with what we call. We give her. We give her bismuth, levoflox, amoxicillin 4 grams, not 2 grams. Because maltoma, we wanted to be sure that this bacteria has to go. And to that she responded. We followed her up. Next endoscopy, lesions have disappeared, and H. pylori also has disappeared. So there was success of the story, and this patient is still on surveillance. So this is 4-drug regimen. Other drugs, you can use rifabutin or levofloxacin. Both can be used as a second-line therapy in these patients. Where available, one should look at bacterial culture and find antibiotic to which the bacteria respond the best. And in those subjects where even second-line fails, then one can use a culture-based antibiotic, or one can use furazolidone as one of the treatment. The key is that appropriate regimen is important. Antibiotic resistance will keep developing. Therefore, this regimen will change time to time, and one must update what is the most important regimen in this year or this point of time. And we have our own guidelines, which is the Indian Society of Gastroenterology guidelines on H. pylori treatment, and this has been published about 2 years back, and which was led by Dr. S.P. Singh from Bhubaneswar. I think we'd like to go over this guideline. So coming to summary, best practices. Number 1, that if you plan to treat H. pylori, treat well. Means good drugs, good duration, and right adherence by the patient. The 3 keywords must be remembered. Resistance is low with bismuth, amoxicillin, and tetracycline, so therefore these drugs can be used in those situations. Point 2, 14 days better than 7 days. And point 3, that if triple survival fails, then bismuth-based regimen may be used, and there are many more regimens out there. And lastly, if there is a resistance to bacteria, we should avoid developing resistance. And there comes a role of antibiotic stewardship. one must not use antibiotic just left and right. There has to be indication. If there's indication, then use right antibiotic for right duration of treatment. And I would like to wrap up this lecture with two inspiratory stories. Number one, everyone knows Robin Warren and Dr. Marshall, Barry Marshall. Warren is a pathologist, and Marshall was, when we discovered Helicobacter, he was a resident, gastro-resident in Australia. Warren found this bacteria in one of the patients with having gastritis. He proposed to his colleague. Every colleague denied, no, stomach has acid. They can't have bacteria. He said, I saw it. People didn't believe him. And later on, over years, they confirmed that yes, indeed, there's a bacteria. Marshall swallowed this bacteria and sowed disease in himself, and this is how the whole story began. H. pylori changed our lives, have led to eradication of peptic ulcers, not eradication, at least recurrence is altered. Therefore, bacteria are sometimes important. And one more new beginning has just started. In those patients who have idiopathic constipation, we think this is a motility disorder or is a functional disorder. But now, a bacteria which is Shigella species have been proposed as a cause of functional constipation. This paper was published in JCI, worth reading. All the steps, how it leads to motility disorder, so worth. So there are two inspirations. With that, I stop my talk. Thank you so very much.
Thank you, sir. When will you do urea breath test? When will you do endoscopy in your practice?
So it's straight. If you're doing endoscopy for other indication, like you want to look at 50 years of age, somebody comes with dyspepsia, you need to do endoscopy. You test that point of time. But if you don't want to do endoscopy, then UVT, then you have a test, if available.
Anyone else want to make a comment, madam?
Culture facilities are not available, only. Sorry, assistance. So we have to have culture. Now we have a different technique. Now we can do testing for clarithromycin or levofloxacin by doing a PCR. So there are three genes, there are three SNPs which are responsible for drug resistance. So we can test that. In fact, we are developing a kit where you test, do RUT, we take a biopsy. So here in the lab itself, one can do PCR and tell you this is drug resistance.
What is the recurrence rate after eradication?
Data 40% at least.
So would you recommend anti-H. pylori treatment for all patients with dyspepsia or only select patients which you showed?
I will, because I told you that we have two schools of thought. One school says no, one school says, I'm from the schools who says yes. Because 10%, those patients who have a dyspepsia is multifactorial. One of the reasons is acid, 40%. 10% is by H. pylori, because if you eradicate H. pylori in these patients, 10% will have no symptom for next 1 year. It means in these 10% people, anti-HP therapy works, right? But in 90% it will not work. That's one reason that we should treat.
Dr. Govind, despite the high prevalence of H. pylori, we don't see that high prevalence of CA stomach, no?
We have, CA stomach is the most common gastrointestinal cancer in our country.
Yeah, no, H. pylori related. It's not, 90% are positive, but we don't see that high prevalence of gastric
I think
cancer.
we need to work more on this.
We have been,
our voice have been always suppressed by these kind of anecdotes, these kind of thoughts. But I think we should go with clear mind that in our country, colorectal cancer, gastric cancer are reality. We should accept, work on it, so it doesn't happen. But till it happens, we should keep with our mind open, go with clear thought. We have a problem, look at it, realize, and if we don't have H. pylori induced gastric cancer, fine. But till then, we must keep our mind open.
What is the role of probiotic in adding to the standard therapy?
I'm not proponent personally, There are reports to say that probiotics might be added as an adjuvant, not as a treatment, but as an adjuvant, but not as a treatment.
Is there a role for empirical H. pylori treatment? Empirical H. pylori treatment.
Empirical test and not empirical, test and treat. So test either by stool antigen or by UBT and then treat. Because what happened, empirical therapy is a problem that we just write some kit for 14 days. Neither patient takes, nor the drug is that good size in that antibiotic dose is much less, and you prescribe, let's say, appropriate. Once you decide to treat, then treat well, not half-hearted.
Now, can I ask a question? A patient coming with upper GI bleed, duodenal ulcer bleed, and many times at that time we cannot do a rapid urease test, and how do you eradicate H. pylori? Because we know that duodenal ulcer almost 95% or up to 100% it is H. pylori related. So in those cases, are we justified in empirical therapy? I actually do a serology. And another question is, this is one question, another question is, suppose a family member has come to us, husband has come to us with H. pylori related disease. Should we screen the family and treat? If so, screening is justified in which all groups?
Taking your question, first question first, empirical treatment. And in those situations, you said GI bleeding, peptic ulcer, and you treat empirical. Now, if it's empirical, and when do I test again? Because in this patient, chance of recurrence is high. There's peptic ulcer. He may bleed again. If I test, I know there's bacteria present, and then I can treat, retest to confirm that bacteria have been eradicated. But empirical means what? Was the bacteria there or not, I am not sure. Therefore, either you do EBT later, maybe a week later, or you do re-endoscopy and take a biopsy at that point of time. I agree that the patient will on PPI, but one has to find a place to do H. pylori. This is what we do always. Your second question, I'm not sure there's a need to do family screening for Helicobacter pylori, unless they're symptomatic. Because most of us, half the world has a H. pylori. Yes, I would agree, yes. Carcinoma stomach, multiple, because there you like to eradicate for sure, because you might prevent a grave disease.
So one last question, sir. If the patient not tolerating the drugs, what will you do?
Not tolerating?
Yes.
Less likely, like tetracycline, amoxicillin. I mean, what option we have? I mean, living not tolerate means they may have mild GI side effects, nausea, vomiting, discomfort. But do we have option? Options that don't treat. Once we decide to treat, then we must treat. Mild side effects should be accepted by patient. Unless they are liver toxicity because of amoxicillin, in that case we change the antibiotic.
So the final question. So the role of stool PCR in H. pylori testing. So when we have to do or when to follow the test?
You mean antigen or PCR?
PCR, so stool PCR.
For what?
For assessing the resistance of H. pylori or any other thing, have any indication in a routine management?
Resistance is, I'm not sure about the stool PCR, yes. But certainly for biopsy, because you're finding a bacteria from the stool will be too difficult. One. Number two, if you find, then the DNA, the amount of DNA in the stool of H. pylori will be difficult to find from the stool. Therefore, all people will do in the lab to take gastric biopsy, isolate bacteria, and do PCR for drug-resistant gene.
Thank you, sir. Thank you so much for this
Thank
session.
you so very much. Thank you so much.
As our next speaker, we call Dr. Matthew Philip to the stage to talk about the Clostridium difficile infection. Thank you, sir.
A small change in the schedule. We have Dr. Matthew Philip to do his case presentation now, and Dr. Bharat Kumar will be presenting tomorrow.
Not this talk. I'm just checking it. Now let me see whether it's the same we have given or not. I have got a doubt. This is not the talk. And this one. This step is little too much for me. It would have been okay for Govind. The step is too much for me, but it's okay. So, good evening. I'm extremely sorry that I have to peep in for this talk. This was actually supposed to be given. This time was allotted to Dr. Bharat Kumar. Unfortunately, tomorrow my flight got cancelled, so I have no option to go back. So there is an early morning flight, so I will go back by that. And train I tried, I could not get the tickets. Anyway, respected chairperson and my dear friends, senior colleagues, pancreatic cyst as such is quite common. And this is the WHO classification of cystic lesions in the pancreas. It can be epithelial neoplastic or epithelial non-neoplastic, which will come to it later. And there are other cysts also. There are non-epithelial neoplastic and non-epithelial non-neoplastic, like pseudocyst, etc. So when we, the terminology, the talk title given to me is pancreatic cyst, then I have to include pancreatic fluid collection also. So pancreatic fluid collection I will just touch upon. We know that pancreatic fluid collection can be related to acute as well as on chronic. And acute can be either acute pancreatic fluid collection or acute necrotic collection. Usually we don't intervene that at that time unless it is an emergency. And on chronic related, we have pseudocyst and Waldorf necrosis. And the differentiation between these two is basically the duration and the nature of the collection. And by definition, pseudocyst has clear contents and WN has got variable amount of solid necrotic material. And this is the picture which above picture shows actually there is clear cyst, and down you can see the necrotic material. When you come to the endoscopic management of this, we have what am pointer? Okay. This is a pancreatic pseudocyst being drained by using a double pigtail stent. And there is a Waldorf necrosis, both one with a Nagy stent and there is the LAMS. And you can also have other modalities of treatment, endoscopic, laparoscopic, then necrosectomy as well as ward, video-assisted percutaneous drainage also. So there are different techniques of drainage of pancreatic fluid collection. So coming to the next epithelial cystic lesions of pancreas, there can be generally known as cystic neoplasms of pancreas. They are basically of 4 major types. Most commonly serocystinodenoma, then mucinous, IPMN, and solid pseudopapillary neoplasm, SPEN. And most important, why these are important is basically this is because of the malignant potential on that. So we just classify them into those without any malignant potential or very low malignant potential, or there is a potential for malignancy, or that basically when we see them, they are actually malignant. Pseudocyst, you know that there is no serocystodenoma, no malignant potential or very low, lymphoepithelial cyst low, then retention cyst like that, congenital cyst, lymphangioма and all. But IPM and mucinous cystic neoplasm, they have a potential for malignancy. But when you see a cystic lesion along with adenocarcinoma, you know it's already a malignancy. Neuroendocrine tumor can get cystic degeneration. And solid SPN also has got very high incidence of malignancy in that. Pancreatoblastoma and acinar cell cystadenocarcinoma. And when you look at these lesions, it actually tells that the age and the gender and location and malignancy all are quite important in classifying this. When you look at that, this is actually a disease of a little elderly, except the solid papillary neoplasm tumor that occurs in young females. IPMN is always in the 5th, 6th or 7th decade, And most of this occurs in females. All these lesions are mostly in females, but IPMN can occur a little more common in males, but the ratio is a little more in the females. Location also varies mostly, and most of these tumors are either in the body or tail. And malignant potential is highest with IPMN, and then MCN and SPN also. When you look at the different types of lesions and its characteristics, it is found the communication between the main pancreatic duct is mostly with IPMN and not with any other list, except in those cases of pseudosis, etc. So how will you reach to a diagnosis? There is a 4-step approach. One is that you have a clinical examination history, and now ultrasound is an extension of our arm for physical examination. So we many times include ultrasound in the physical examination group. Then is a cross-sectional imaging, which is the best. Most likely, most of the places people think that when you do an MRCP and MRI, you get a cross-sectional imaging along with a ductal anatomy also. Third is the endoscopic ultrasound, not only for a characterization, but also you can get tissue diagnosis, assessment of mural nodules, and if required, US-gated aspiration. So these are the 4 major cornerstones or important steps or important aspects of evaluation of a patient. When you do an imaging, there is certain imaging checklist. One is that where is the site and what is the size of the lesion, because size is also important. Then whether looking at that, we decide whether they have got malignant potential. If the septa is quite thick, or the wall thickness is quite, or the wall is quite thick, or there is an associated mass lesion, all this suggests probably this is a malignancy. Then when there is a mural nodule or a focal thickening in the wall, that also suggests this could be a malignancy. Coming to serous cystic neoplasm, it's a benign lesion. It's known as a grand mass tumor or a grand mass lesion. When elderly people, when you do an ultrasound or a screening, you just see such type of lesions. Sorry, I will just remove. And most of these are asymptomatic, and it does not communicate with the main pancreatic duct. And it can be microcystic or macrocystic or so-called oligocystic. Oligocystic, that differential diagnosis comes towards mucinous cystic neoplasm also. And this is an MRI picture as well as an endoscopic ultrasound. Endoscopic ultrasound actually shows a honeycombing or multiple small cysts are there. And it is highly vascular also. When it comes to mucinous cystadenoma, you can see that it can be single cystic or it can be septated, and there can be relatively thick wall when compared to that of mucinous cystic, compared to the serous cystadenoma. And basically, when you look at the histology, you can see the one is with thick walled and lot of tissue reaction there, and it is covered with the tissue, covered with the mucinous glands there. The other one is mostly spaces with the lined with blood vessels and thin layer of epithelium. When the size is more than 5 centimeter, or when there is an irregular thickened wall, or when there is a solid component, or when there is a calcification extensively, all these indicate that probably this is malignancy. When you think about SPN, solid pseudopapillary neoplasm, this here it is, you can see this is in the tail region, and this is in the US, and mostly it is solid, but there are certain small cystic lesions also. And we do an FNA to make a diagnosis, in fact, to make sure that there is malignancy or not, to make an extent of dissection, etc. And coming to IPMN, basically we classify IPMN into main duct, branch duct, or when there is a combination of these two, is a mixed one. This is a CT picture of a main duct IPMN with a large mass in the head region. This is another a main duct IPMN, but grossly dilated main pancreatic duct. You can see throughout it is dilated. This is a branch duct IPMN. It's actually a multiple branch duct in the head region. This is an MRI. MRI shows another. This is a main duct IPMN. This is a branch duct IPMN. And you can usually get mural nodules inside the cystic area, but sometimes in main duct IPMN, you should always look for mural nodules in the main duct also. Mural nodules alone cannot predict malignancy, but it has got a high risk of predicting malignancy. And cytology also, when you get an atypical cells or a dysplastic cells, that also suggests this malignancy. But the combination of these two makes the diagnosis more certain. So what is the indications, what are things you can do with endoscopy? One is that you can do a diagnostic EUS and to assess the morphology of the cyst. You can do a EUS-guided fluid analysis. You can do a fine needle aspiration biopsy from the mural nodules or a solid component. And in certain places where it's available, you can do a confocal laser examination, or you can do a cyst wall biopsy through the needle. And contrast enhanced EUS can be done to assess what is the vascularity of the mural nodule, or it is actually a sludge ball. Then side viewing endoscopy, where you can look at the ampulla to see the fish mouth appearance. Always when you do EUS for this patient, make sure that you see the ampulla also, so that you can make a diagnosis of IPM, and that sometimes help. And sometimes we can do a pancreatoscopy. So EUS, there are a lot of guidelines of whether to use, in which conditions to use, but generally it is used very commonly. And here actually we can do the cyst aspiration. You can puncture the needle, puncture the cyst, and trying to aspirate. And the second video shows that you should aspirate full. Otherwise, there is a high risk of infection. And when you aspirate full, the cytology specimen should be the last amount, 1 or 2 ml of the fluid, because that is close to the, you will get more tissue in that to get cytology. So what are the benefits of doing it? What are the advantages, or is there any merit in doing these cystic fluid studies? One is that you can do a macroscopic one, that's a string sign, which will come to a very high specificity for mucinous cyst, or you can do a cyst fluid cytology. Generally, it is not highly valuable. The sensitivity is not very good. And then you can do even a biopsy from the cyst wall. People have even used a brush. People have used biopsy. Then the most 2 important things are carcinoembryonic antigen and the glucose. The third important is amylase, to rule out whether it's a pancreatic cyst or not. And nowadays, people are more into markers, especially molecular markers. This is actually the string sign. When you take out the fluid, you can use your hand, or when you pour into the test tube, you can see whether it's actually forming a thread-like thing. That is a string sign, which is highly specific for mucinous one. And there is actually, recent multiple studies have shown that glucose is highly specific when compared to that of CEA. So in general, glucose estimation, which can be done immediately on the spot, use a glucometer and make sure that if it is less than 50, high chance of it is mucinous. And those are different types of molecular markers we can study, but in intraductal papillary neoplasm as well as in mucinous, it is found to be quite useful to do this. And what is the other advantage is that you look at the mural nodule and can do a Doppler study and make sure that this is vascular or not. This is a case of, IPMN. You can see the fish mouth or wide open mucinous opening there on the ampulla. And this is a solid component there, and we are taking a biopsy from that region, and we can make a diagnosis there. And this is, it's almost over. And this is actually the fluid there. We can actually take a tissue from that. That's a needle-based microbiopsy. You can see the tending. Unless you see the tending, you can see the tending there. You cannot say that the tissue you have got the tissue. This is actually passed through the EUS FNA needle of 19 gauge, and then you can get a biopsy. And contrast EUS also another good area. You can see this is actually a mural nodule, or it can be a sludge ball. So once you do a contrast EUS study in this patient, you can even do as elastography. We have shown you the elastography, and contrast EUS is being done. You can see the wall is getting lightened up, but not the nodule. That means it is not a mural nodule. Confocal laser endoscopy, I have no experience in that, but people say it is quite good in differentiating between mucinous versus serous adenoma. And when you single operator cholangioscopy, this is actually a fish mouth opening, you can see there. And you can see that this is inside the pancreas, phone-like structures, and this is the tissue there. And this is a very interesting one which we used a 20 gauge and 19 gauge needle through which we actually passed a fiber into the cyst, and you can see inside the cyst. It's actually a cyst, a scopy of the cyst. This is actually a serous cystadenoma, macrocystic. This is actually a mucinous cystadenoma. You can see the fluid is slightly cloudy there, and there is bumpy areas inside. And treatment is mainstay is surgical, and surgical options are different. I'm not going to details of that. And endotherapy can also be done using certain agents or ablation of a cyst. And this is the algorithm for, I'm not discussing it now, but you have to, what you have to do is, if the evidence of, or the suspicion of malignancy is quite high, this patient should go for malignancy. The second step is, if there are any worrisome features, then this patient should be taken up for surgery, or a patient should be kept at high close monitoring. And those patients without any high-risk features can be followed up. And in conclusion, there is an individualist approach for management of this patient. A good quality MRI and MRCP is the most important modality of imaging. And EUS is an important tool in imaging as well as for getting tissues. Surgery should be done in those patients with high-risk features. And it's always a challenge to use good markers to find out the malignancy or not. Thank you so much. I request to all of your presence during the Crohn's colitis meeting, which we are having at IPD clinics. For postgraduate students, it is free. Thank you so much.
Thank you, sir, for enlightening on this broad topic. Sir, one question. Do we have to do these genetic mutation studies in all these patients with suspected neoplasms, and how really it is helpful in management of these patients?
I will rather say that I don't do generally, but in those patients who, when there is a diagnostic dilemma, for example, in the head of pancreas, and the patient requires a Whipple's resection, and in those situations, if you want to leave alone or to operate, in those situations, I think this is. Or if you are planning for an endotherapy, like using a injection into the cyst and then manage or take care for surgery, in those patients, if the genetic molecular biology is positive, then you can think about surgery in those patients.
Thank you. It was an excellent lecture. The question I want to ask is, what is the antibiotic policy? There are certain cysts which never get infection. For example, serous adenoma. Mucinous has a high risk of infection, and you said we need to aspirate completely. Because it is mucinous, it is quite difficult to aspirate completely also. So, do you give antibiotic routinely, and how long if you give?
I give antibiotics 1 hour prior to the procedure, and usually I don't repeat it. If the aspiration is incomplete, I always continue with antibiotics. My policy is that I use a 19-gauge needle and try to aspirate. You have to wait for some time, you aspirate everything. But sometimes it's not possible, I agree that it may not be possible, but you continue with antibiotics, and I actually give antibiotics for 3 days. Because the same day or next day the patient will get discharged. And I always give antibiotics for when I'm dealing with cystic neoplasms.
In your algorithm, you have not included CT scan.
See, the question of CT scan versus MRI, we cannot actually do both. So basically the concept is that MRI will show the morphology of the gland as well as the ducts. So you better use one test which can include both. But CT scan is good enough if it is a single lesion, and if you are not really thinking that the patient has got a IPMN, in those situations, it is a non-IPMN case, probably CT scan will do. But MRI will also help you sometimes to see whether there is any communication with the main duct or not. That also becomes important.
Any questions from the audience? Thank you, sir.
Thank
We'll
you.
go to the next. Yeah. Now we go to the polypectomy techniques by Dr. Gogol. The panelists, I would like to invite Dr. Ilavarasi, Dr. Mohan Raj, Dr. Karthikeyan Kumbugonam, Dr. Vishnu Abhishek.
Good evening, chairpersons and dear panelists. At the outset, I like to sincerely thank the Tamil Nadu ISG for giving me this opportunity. Special thanks to Dr. Ravi and Dr. Rubal. So we'll go to this polypectomy techniques. We are all aware that the prevalence of polyps increases with age, and the national polyp studies have shown that removing adenomas actually helps in preventing colon cancer. On an average, it takes 10 years for the polyp to develop into cancer. And we also know that it depends on the size of the polyp, the histology, and the association with polyposis syndromes. This interesting slide tells us that the degree of protection conferred by colonoscopy is largely dependent on the skill of the endoscopist in removing the polyps. And up to 22% of polyps that are deemed to be adequately removed, there is some residual tissue that is left. And majority of post-colonoscopy colon cancers were likely due to missed lesions and 1/5 due to incomplete resection. So all this means that we need to look into it more deeply. So to begin with, this is a sessile polyp. Now, in a polyp like this, how do you assess the size of the polyp at colonoscopy, which is very important in determining the risk of cancer? Since Dr. Balamurali is not there, I would request Dr. Vishnu to take up this question.
We can put out the open snare, wherein we already know the predetermined size of the snare, wrap it around the polyp and assess the size. Or we can get the open biopsy forceps, which is around like 8 mm to 7.5 mm, keep it near the polyp. That will give a rough estimate of the size. Or we can have a calibrated catheter tip and keep it near the polyp. Now the new thing which has come is a calibrated cap, wherein we can attach the cap. Inside the cap there will be like graduations, like every 5 mm and 10 mm. That also can be used to assess the size of the polyp.
Yeah, that's true. The only thing with the graduated cap is, so we need to remove the cap once we assess the size of the polyp to go back and do a polypectomy. Unlike other techniques, you go with, okay. So how to treat this sessile polyp? Up to what size of the polyp is cold snare resection advice?
So,
Dr. Ilavarasi.
Sessile polyp up to 10 millimeter, that is 1 centimeter, can be removed by cold snare resection technique. So cold snare polypectomy is the first line of treatment for all sessile polyps less than 1 millimeter. There are advantages of cold snare polypectomy, that is, it offers a complete resection when it is done in the right way. And there is no risk of diathermy related complications like bleeding or perforation. There can be a minimal self-limited bleeding, so that we need to assess after the resection completely. The base has to be assessed by flushing adequate water. So this technique should be done in the right way. A dedicated cold snare, that is usually for hot snare we use braided snares, but a small and a stiff snare will be adequate for the cold snare polypectomy technique. And as a general rule for any polypectomy, it should be oriented in 6 o'clock position. The polyp should be oriented in 6 o'clock position, because this is where the gadgets come out. And then the polyp the scope tip has to be, should be in a downward deflection, and the snare should be placed parallel to the mucosa. Around 1 to 2 millimeter of the normal mucosa can be grasped around the polyp, and some amount of air has to be suctioned while closing the snare. And after the removal, the base has to be adequately inspected for any further bleeding.
So what is the basic difference between using a cold snare and a hot polypectomy snare?
One basic difference is basic difference is no diathermy. The other one is upward. Usually in the hot snare, it's upward and tenting. We need to lift and tent the polyp in hot snare polypectomy, whereas this is downward pressure. Some amount of downward pressure and push is needed for the cold snare polypectomy.
Exactly, because we're using the electrocautery, we need to tent the polyp upwards so that inadvertent colonic wall injury can be avoided. So, Dr. Mohan Raj, is there a role for cold biopsy forceps in managing polyps? And do we still use hot biopsy forceps in our practice?
Yes, like cold biopsy forceps, generally no, as both European and American guidelines suggest no, but it can be done in certain situation where cold snare polypectomy can't be done. That situation we can try cold biopsy forceps. And because cold biopsy forceps, the complete eradication of polyp is very less. So we tend to go towards cold snare polypectomy than cold biopsy forceps. And coming to hot polypectomy, hot biopsy forceps, no, because the incomplete resection is there, and inadequate tissue sampling is there, more thermal injury, and if you use more cautery, delayed bleeding risk is there. So we generally avoid hot biopsy forceps.
So for the postgraduates, it's very important that we don't use hot biopsy forceps. It is currently not recommended. And cold biopsy forceps only if you are not able to orient the polyp in a conducive position. Now for a polyp like this, which is more than 10 millimeters, or more than 1 centimeter, so the society has been advocating either hot snare or a cold snare, especially the US Multi-Society Task Force, whereas the ESG recommends only hot snare polypectomy, and that too after injecting the polyp and lifting the polyp. Now coming to submucosal injection, so how does a submucosal injection help, and what solution is commonly used in our practice? Dr. Karthikeyan sir?
Actually, submucosal solution helps to elevate the polypoidal lesion, and it facilitates lassoing of polyp, and it prevents electrocautery induced thermal injury. The solution commonly we used are normal saline. Other solutions are hyaluronic acid and gel fusin. Even dextrose, 10% dextrose can be used. There are advantages and disadvantages for each and every solution. The normal saline is the cheapest one and easily available, but the disadvantage is the elevation lasts for only 3 to 4 minutes, whereas hyaluronic acid, the elevation lasts for around 7 to 8 minutes. It is better always to mix the solution with adjuvants like methylene blue in order to opacify the solution, and adrenaline in order to minimize the bleeding.
So that's true. For a polypectomy, which is going to last only for very few minutes, it is enough we use normal saline. Whereas for EMR and ESD, where the procedure is going to be a little prolonged, we can use gelfusion or other agents, what he mentioned. Now, Dr. Vishnu, what dye is used, and how does it help in polypectomy or EMR, and how do you recommend adding adrenaline to the injectate? What are the advantages and disadvantages with using adrenaline?
Any inert dye like methylene blue, indigo, carmine can be used, and now malachite green also is being used in some centers for the green color to differentiate between different sites. And regarding adrenaline, for polyp and a small EMR cases we can use, as long as the dilute adrenaline injection, if the amount is less than 20 cc, it's fine, but beyond 20 cc, at one go, it can lead to systemic complications like tachycardia and arrhythmia. So generally, if the lesion is in rectum, where the vascularity is so high, then adrenaline injection will give a little more clear vision during the ESD or EMR. And if the polyp is also too large, injecting into the stalk will reduce the size of the polyp, wherein the polypectomy will become easier. But the size, the amount of injection also matters. Less than 20 ml is fine.
So the concentration, as you mentioned, is 1 in 1 lakh. It helps in reducing the intra-procedural bleeding, which is a very important risk factor for polyp recurrence. That is what the A study from Dr. Alan Moss from Australia. They found that intra-procedural bleeding actually is a very important risk factor for polyp recurrence. To avoid that, adrenaline can be very helpful. The one problem, it doesn't prevent post-polypectomy. Delayed post-polypectomy bleeding is not prevented by adrenaline. So there is a very important risk factor. Regarding the use of dye, one important thing is while we cut the polyp, when we identify a thing like this, what we call the target sign on the left side image, that means you have inadvertently cut the muscle. So you need to close the defect using clips after you identify this. So this dye actually helps in identifying this target sign also. Now, if you see a large laterally spreading lesion like this in the right colon, so how to assess the depth of invasion of such polyps? What are the macroscopic features? At white light endoscopy, which will tell you that this polyp has to be subjected to surgery, or this polyp has to be done by an endoscopist.
So two things are very important in assessing the depth of invasion in white light endoscopy. One is the morphology, the appearance of the polyp, and the size. So for the morphology to assess, we need to be well aware of the Paris classification. The Paris classification is broadly classified into protruding and non-protruding lesions. So the protruding variety is further classified into 1P and 1S, which is polypoidal and sessile. The non-protruding variety is further divided into 2A, 2B, 2C and 3. The 2A is superficially elevated, 2B is flat lesions, and 2C is depressed, and 3 is excavated. Among all these, any of them can have a higher depth of invasion if the size of the tumor is more than 4 to 6 centimeters especially. And the 2C and the 3 varieties have a higher rate of submucosal or a higher depth of invasion. So on general appearance, when we try to do the procedure, the non-lifting sign is again a sign of deeper invasion. When there is a highly bleeding lesion or an ulcerated lesion, or when the stalk is very broad, or we call it as stalk swelling, or when there is a fold convergency or loss of lobulation, all these are general signs of deeper invasion.
So while injecting the polyp doesn't lift, that is, does it adequately rule out that there is no submucosal invasion?
Sometimes it can be a procedure, technique related testing also.
Exactly.
We need to inject at the right site.
It's not a foolproof sign to say that there is no submucosal invasion when there is no when the non-lifting sign is positive. So how does the narrowband imaging helps in identifying deeper invasion or polyps with advanced histology?
Basically, NICE and JNET, they classify the polyps based on the color, vessel, surface pattern, and they are supposed to correlate with the pathology. Most likely the type 1 is hyperplastic, type 2 is adenomatous, and type 3 is almost carcinoma in situ. And JNET scores over NICE because in type 2 they divide it into type 2A and B, because in 2A it is probably low grade dysplasia and 2B is high grade. The basic difference is in type 1, the polyp almost appears of the same color as the background, and whatever pit pattern is there on the background, that is enlarged in this polyp. So that's basically a hyperplastic polyp. In 2, it is mostly a gyrate pit pattern with the brown vessels just following the contour of a white gyrate pit pattern. If that pit pattern, that is the surface, and if the vessel is enlarged, irregular, of variable caliber, then that is type 2B. If that is very regular and not so variable, and if the vessel is of same caliber, then that is type 2A. So 2A is mostly low-grade dysplasia and 2B is high-grade dysplasia. Whereas if we don't see that regular enlarged vessels or irregular enlarged vessels, instead if there is an amorphous lacy network of vessels just running along a surface which is destroyed, then that is probably type 3, which is carcinoma in situ. They are mostly subjected to surgery, and 2A and B are subjected to endoscopic resections.
So 2A and 2B, does the mode of endoscopic management differ?
In 2A, probably an EMR helps, and 2B, if there is probably a superficial submucosal invasion, then ESD scores better over EMR.
So these two classifications, postgraduates, it helps us to decide whether to go for an EMR or ESD, or whether the patient has to be subjected for surgery. Now, with a big lesion which we saw in the right colon, what is the best modality to proceed? Is a piecemeal resection acceptable? Because ESD in a location like right colon is fraught with complications like perforation or bleeding. So what is your thought on this?
Piecemeal resection is very well acceptable because we do it more often. Nordic countries in Northern Europe, they use it more common. Only the Eastern countries, they recommend ESD in this case. But both are very widely accepted. Only problem is if there is a piecemeal resection, the surveillance has to be like in a stepped up fashion, because the risk of leftover tissue and risk of recurrence is going to be high. So that's the only difference. Otherwise, if it is possible, on-block resection by EMR is recommended, ESD is recommended, but if the site and everything prevents us from doing an ESD, piecemeal resection is very well recommended.
Okay. So when do you, what is the advantage of ESD in such a polyp if it is with the technical, facilities are available to do that ESD compared to EMR? How does ESD score over EMR in such dealing such polyps?
We are removing the tumor in total. We are marking the lesion, so that's going to be an R0 resection. We are giving the specimen with the submucosal layer to the pathologist, so we can assess the depth of the lesion and see whether any of the tissue is left over in the body. So ESD scores over EMR in that fashion. And especially if it's a rectum, better to do ESD, and if it's a non-lifting polyp with a good amount of submucosal fibrosis, again ESD scores. And a polyp in IBD cases also, ESD is more recommended.
Suppose we do piecemeal resection for such a big polyp, when is the next colonoscopy to be scheduled?
It's usually recommended within 6 months, and if it's negative, again a year, and if that is also negative, again at 3 years. If that is again negative, we can drop the patient.
That is because such piecemeal resection is, there is a high risk of leaving behind adenoma. So the next colonoscopy has to be in 2 to 6 months' time according to recommendations. So Dr. Mohan Raj, so which scenario after resecting the polyp would you clip the base? So why should we clip the base at all? And
Yes.
how big the polyp should be?
Yes. It is not necessary to clip resection for all cases. It is indicated in certain cases, like more proximal lesion, that is right side of the colon, and size of the lesion is also important. If the size is more than 2 to 3 centimeter, then you have to clip, or if there is any perforation, we have to clip. And especially those patients who has a chance of increased bleed, like those who will be anticipating to start antiplatelets or anticoagulation, that patient we should put clip. So these are the scenarios we usually clip.
True. So right colonic polyp size more than 2 centimeters, and when you notice a target sign after resection, all these would prompt you to put a clip after resection. So after resection, suppose there is an adenomatous tissue which you are able to see macroscopically, or you are not able to see anything. Should we go for a thermal ablative techniques after resection? What are the indications?
Any residual adenoma should be removed in toto. The organ plasma coagulation and other thermal method will not give complete protection. It is recommended only after EMR or ESD, the margins should be ablated. Endoscopy wise, there should not be any tumor left out. If the margins are clear, then the organ plasma coagulation may be helpful.
That's true. So there is two things they are mentioning. One is adjunct treatment, where you are not supposed to do an APC or soft coagulation, and only as an adjuvant treatment. That is, you are not seeing any residual tissue. Only then you have to use APC to prevent recurrence. If you are able to see adenomatous tissue, then you are not supposed to do APC. Instead, you are supposed to do a hot avulsion technique. Now, this is the patient we managed. So we did a piecemeal polypectomy and put the clip at the base, and we removed it through the Roth net. Now coming to pedunculated polyps. So this is a big pedunculated polyp in the left colon. So Dr. Vishnu, what are the risk factors for post-polypectomy bleeding, which is one of the most important and foremost complications after polypectomy, and how do you prevent it?
If the stalk is thick, like more than 1 centimeter, or the polyp head is more than 2 centimeters, there is going to be a definite risk of bleeding. And if the polyp is mostly from the right side of the colon, or if there is a lateral spreading tumor, especially non-granular type, then there is a risk of bleeding. Patients who are on anticoagulation, patients who are having other comorbidities like undiagnosed cardiovascular disease or undiagnosed chronic renal failure or chronic liver disease, they are going to have a probable risk of bleeding. And if the endoscopist is cutting only pure cutting current, then there also is going to be a risk of post-polypectomy bleeding. And the ways to reduce it is like if the polyp size is more than 2 centimeter, or if the stalk is more than 1 centimeter, better to use either injection method or a mechanical method. Mechanical method can be an endo loop application and cutting above the endo loop, or we can use 2 to 3 hemoclips to occlude the stalk of the polyp and then put the snare above that and cut the polyp. Or we can use a dilute 1 in 10,000 dilute adrenaline injection so that the vascularity of the polyp comes down. Then again we can
Okay, the advantage hemoclip is it is easier to put, but it is not a secure method even after deploying multiple clips. Whereas endo loop, it is a secure method, but now mal deployment is very common. The technical person who is assisting has to be extremely good. Now, what are the cartridge setting, Dr. Ilavarsi? Does it depend on the size of the polyp or the location of the polyp?
So, all electrosurgical diathermy units contain a continuous power output, but that is the cutting current, and it also has an interrupted waveform, which is the coagulation. So we also have in all the, never a pure cutting current should be used for polypectomy. There is a high risk of bleeding. So in the standard Urbe diathermy, we have an option called endocut Q, which is the blended current, which is a cut and a coagulation. So endocut Q is the one which should be used for polypectomy, as well as there is an option called effect. So there are 4 ranges of effect, that is effect 1 to 4. Effect is nothing but to determine how effective is your coagulation. So effect 1 has a least coagulation, effect 4 has the highest coagulation. So for any general polypectomy like the stomach, esophagus or the left colon, effect 4 is better. Only for the right sided colonic polyp, as the colonic wall is very thin and there is a high risk of perforation, we need to come down on the effect to 1 or 2.
So the commonly used modality is endocut Q. So Dr. Mohanraj, what are the 2 important steps you want to tell the postgraduates while doing a hot snare polypectomy? Out of the many steps, which is the most important step you think?
First step is position the scope at the right thing. Like you should position the polyp at 6 o'clock position is very important. It achieves very good a complete eradication of the polyp, and it is the technique, and we can finish it as soon as possible.
Now, last thing is how to retrieve the polyp. Retrieving the polyp, sometimes most often it is left behind. We are not able to trace it. So, what are the various methods to retrieve
just
the
use
polyp?
the rock net to catch hold of the leftover pieces in one go, if possible. Otherwise, go back in again, retrieve with the rock net. Or we can have, if we have a cap, and if the polyp size is small, use the suction to get the polyp into the trap. If it's a very diminutive polyp, use a suction trap to get it into the air channel.
So, polyp traps are very helpful to remove the diminutive polyps and smaller polyps. Whereas for others, forceps is not to be recommended. Forceps is currently not recommended to remove the polyp because it distorts the histology. Now this is a patient, a video showing endoloop assisted polypectomy. You're placing the endoloop at the base, and once endoloop is tightened, it is very important to snare the polyp just above it, leaving a small amount of stalk above, so that if there is inadvertent bleeding from the stalk, then you have a space to put a clip. So this is after polypectomy, removing using rock net. So it is very important that it is colonoscopy. Once a procedure is done, polypectomy is done, we need to tell the patient when the patient should come back for a surveillance colonoscopy. That is very important, and one of the metrics in assessing the whether the colonoscopy procedure has been proper or not. So what are the recommendations for follow-up colonoscopy once polypectomy has been done and the histology report is available?
We have no societal recommendation, but we follow the American and European guidelines. Where if the low risk polyp is there only less than 2 polyps, each less than a centimeter, then there is no surveillance, or they can ask to come for colonoscopy after 5 years. If there is 3 to 4 polyps, or at least 1 polyp more than a centimeter, then the surveillance interval will be 3 years. After 3 years, if there is no polyp, then either we can drop the surveillance or go back to every 5 years. If there is a high risk polyp, like at least 2 more than 1 centimeter, or more than 3 polyps, of which at least 1 is more than a centimeter, then we have to call them up at least in a year to follow up. And after a year, if it's going to be in intermediate risk or high risk, based on that we can recommend.
So it basically depends on the size of the polyp and the histology.
Size and the number, yes.
Okay. Thank you very much. We'll be glad to have valuable feedback and suggestions from the chairpersons for this.
It's a wonderful panel discussion. Any questions from the audience?
I've written down a lot of things. You asked her difference between hard snare and cold snare, and she mentioned about the technique of hard snare and cold snare. Actually, the difference is the thickness. The hard snares are about, I think, 0.47 millimeter diameter, whereas cold snare is 0.3 millimeter. And there are a lot of studies which said it is the snare type which matters. And publications are also favoring cold snare, which is very thin, stiffer, and smaller. But later on, recently, there is a publication which says it is only the technique. If a technically good person does it correctly, then there is a CR, complete resection rate is very high. After the resection, you should in fact examine the site for completeness and so many things which you mentioned. And about the injection. Injection, as somebody mentioned it, is useful to prevent deep muscular injury. It is also useful sometime if you don't get a good angle. If you inject far away, then you can bring the polyp to the correct place for applying a snare and completing a polypectomy. And the biopsy still is useful, and there are many centers, they practice cold biopsy forces for complete removal of the polyp if it is less than 2 millimeter. And you have to completely able to remove the polyp in at least 2 bites. If you require more than that, you should do the other methods. And of course, large polyp, generally in our practice, we don't take a consent for polypectomy at the first time. The kind of polyp which you showed, a large polyp, one can easily do a biopsy, and then if it comes as adenocarcinoma, you can, invasive cancer, you can send them for surgery. If it comes as polyp without dysplasia, and if you think you can remove it endoscopically. You can take a consent and go and do an appropriate. You showed an envelope. You are an expert. You are easily applying it. But envelope is also equally a dangerous procedure. If you don't have an assistant, you should be very careful in applying envelope. Many times during application of the envelope itself, they will snare it off, and
bleeding happens.
And if you had already caught the polyp close to the wall, you won't have a further stock to catch any further. And it's a dangerous situation, and then you maybe end up...
yes, I completely agree with you on that point. Yes,
and
sir.
the polyp trap. These polyp traps are applied at the suction side, in the endoscopic process side. There are people who insist when these polyps travel through the suction valve,
distorted.
It gets distorted. In fact, they remove the suction valve and apply suction without the valve, so that the polyp enters the trap without damage. And there are people who, in fact, apply the trap at the port, the instrument port, so that it doesn't have to travel through all the distance, and it can be applied for only small polyps which can come through the channel. Larger polyps still require some other methods of removal. I think that's all.
Yes, sir.
That's all I remember.
Points, sir. Thank you, sir. Thank you.
Ravi. We'll go to our next, please.
I have one doubt about after ESD, you find that there is a target sign. Would you be happy in closing just that portion or the entire dissected area? Because when we put a clip over that site, on both sides there's just submucosa or a very thin muscle. Already there is only muscle there exposed, and the clips have a sharp edge. So what do you usually do?
Perforation. Typically after polypectomy is what we notice, the target sign. Not, generally at ESG we'll identify the defect during the procedure itself.
Yes,
whereas the target sign is only for a polypectomy or an EMR. We need to close the whole defect, not the target sign alone. Because it creates more perforations doing the other way.
But putting a clip on such a surface also is a little bit dangerous, is it? Because the clips are a little sharp.
That's why we need to approximate the edges rather than the site of target.
Sir, inverted colonic diverticulum polyps, so how do you go about differentiating during colonoscopy?
I think that is true most often for the appendix, where there is an inverted appendix looking like a polyp. There are case reports which say that inverted appendix can look like a polyp, can be mistaken for a polyp. So other sites I am not aware of diverticulum being.
Diverticulum also gets inverted, and
look like a polyp.
And if you resect it,
it doesn't come. Is there any way to identify, sir, inverted diverticulum from a polyp?
Yeah, it is there.
Sir, the polyp is situated in the IC valve. What is the treatment option?
I think it's one of the difficult polyps. It comes under complex polypectomies, like the polyps spread over the IC valve, periappendiceal. All these, most often they end up in a surgery, though there are experts who would do ESD in those locations.
Thank you, Gokul.
Thank you.
Thank you all the panelists and the co-chairpersons. Thank you. We had a wonderful time.
Thank you, sir.